I welcome everyone to this online version of EM Conclave 2021. I'm very happy to see that we are adopting our ways and learning to live with new changes which have been happening in our times. As emergency physicians, we are the front line of all medical emergencies presenting to our healthcare system. It's very important that we are ever alert and ever active to keep guard at the doors to attend to these emergencies as they come. We should be able to start the initial management and set these patients at the right path towards the recovery from their ailments. It's very encouraging to see that SEMI has not let its guard down, even in times of these restrictions, and working out ways to keep our academics going, as this is a vital part of any specialty. It is these platforms and conferences which would provide opportunity for not only initiating and having healthy, productive debates, but also to provide opportunity to share and showcase the hard work and good practice across the specialty. As these are testing times with pandemic, throwing new challenges at every turn, it is all the more important that we have conference on COVID to spread not just awareness, but also the good practice, a new thinking, and healthy productive discussion. As we have already witnessed today over the last couple of hours, some of the most experienced emergency physicians sharing and discussing their experiences and also guiding the budding emergency physicians to the way forward. I also see that there are more experienced emergency clinicians lined up for further discussions and talks. With Mumbai being one of the places which saw the increase in COVID infection this year, and the response of the authorities and medical teams was very heartening. Their hard work seems to have been successful thus far in stopping the rapid surge in number of cases and also keeping them under check. The work of COVID warriors at the front line is very much commendable. We have witnessed and experienced the hardship faced by our doctors, not just in emergency medicine, but across the hospital. The second wave has undoubtedly thrown a set of new challenges and exposure to our staff. It was this wave and shortcomings of our system which made us all witness an emotional trauma experienced by family of patients with COVID-19. I would not wish to say that as emergency physicians, we are no strangers to death or suffering, but the scale and rapidity of illness during this wave was too much to bear even for the most experienced emergency physician and has brought them into tears. No amount of training or preparation could have prepared us to face this type of enormous emotional turmoil. I would look forward to be able to address and support our forthcoming generation of emergency physicians, not just in their clinical and academic skills, but also in their communication skills and support them emotionally. I congratulate the Maharashtra State Chapter for heading the way on this front and look forward for further conferences, not just at the state level, but work towards a national conference. It gives me added pleasure that our young specialty of emergency medicine is able to grow, and SEMI is playing a significant role in providing a platform for clinicians with similar interest and thinking to be able to interact and work together. Today being World Emergency Day, I wish and congratulate all emergency clinicians. I wish everyone a productive and fruitful conference. Thank you all for your hard work and contribution towards emergency medicine, and look forward for all your continued support and encouragement to take this specialty to reach out to every individual. Thank you very much.
Thank you, Venkatesh. On behalf of Society for Emergency Medicine India and Fortis Hospital, Mulund, Mumbai, I welcome all delegates and faculty for EM Conclave. The theme of this conference is celebrating the spirit of emergency medicine. So what is the spirit of emergency medicine? Because in last 1.5 years, we are seeing that emergency doctors are working very hard on the being the forefront doctors in this pandemic. The situation is very challenging. Most of the time hospital beds are full and emergency departments gets packed up. They have to not only to treat the daunting emergencies, they have to communicate to the relatives very well. And because sometimes relatives may go aggressive, We have to calm down them. We have to resuscitate the patient, and after getting the bed, we have to send this patient in the respective areas of the hospital. And if beds are not available in hospital, it's a responsibility of emergency doctor to make a safe transport of the patient by arranging a bed in other hospital. So these are not small things. I think arranging a bed is a very big thing in this pandemic that emergency doctors are doing day and night towards the pandemic. They they have shown a resilience. They have shown a great temperament. They have never lost the cool. And I can see all across the India in a state, this emergency medicine doctors are continuing to work in this adverse environment, but they are doing it on a very much positive note. This indomitable spirit of emergency physician or a clinician is the spirit of emergency physician, and we are here to celebrate this particular spirit here. So I again welcome to everyone and congratulate to the all the emergency doctors for exhibiting their great clinical acumen in this the pandemic. Now, at the last session of this inauguration ceremony, I call our very own, our leader, our zonal director, yes, Narayani madam, for the further talk. She has pivotal in COVID management in our hospital. From day one, she encouraged all of us to take up this challenge, and it was a very much challenging journey for all of us, 1.5 years. So many times, I think she inspired us, she was inspired, and she motivated the entire team for a common goal, means to deliver the best emergency care to every patient coming to emergency department in the pandemic. So this is the leadership quality that has been shown, and she was a role model as a result, as a leader. I request madam to give some opening remarks as well as give her thoughts as a leader, as a dynamic leader on this COVID management. Your topic of the talk will be the madam leading the team against invisible enemy, a story of epic fight. And before that, you just give inaugural remarks as well.
Thank you, Sandeep. Good afternoon, everybody, and a very, very warm welcome to this session today. So, just to say my, on a note of inaugurating this session, the last 1.5 years of this COVID pandemic has thrown up several thoughts, several myths, has been a year of fear, has been a year of panic, has been a year of discoveries, has been a year of successes across. It's not just in the medical field, but across society. It's been a constant change and a constant a kind of turmoil happening all the time. In all of this, while clearly there have been some takeaways and clearly there have been some facts or some realities which will be here to stay, and there will be some things which have made a name for themselves. So in terms of the medical field, I would think that what was clearly brought out was this pandemic handling was about 3 key areas or 3 key specialities which actually work together in synergy along with all the rest, but the lead role being played by 3 pillars, which have been the emergency department, the ID department, and the critical care department. It is the working together of these 3 which has helped us to handle this pandemic. And in every hospital, we realize that the working of the emergency department, the working of the emergency physicians who are the front line actually to receive these patients has played a very big role in deciding, one, how safe the hospital remained in terms of segregating patients, how well the patients were managed, and how safe the staff remained in terms of making sure that the spread of infection was not too much. So in a very, while all of these in big institutions, these departments exist, I think this is one pandemic which brought to the knowledge of even the common man what really is an emergency department and its importance, what is really infectious disease and its importance, and what is critical care and its importance. So it is most appropriate that today on the World Emergency Day, we have this session where we exchange notes and we understand more about what's been done about emergency medicine. And many ways we keep deciding on what our way forward would be. So I thank you, Sandeep and the entire team which has put together the session. And once again, a very warm welcome to all of you all. And I'm sure there is going to be a veritable feast of scientific sessions as well and information exchange. Thank you once again for being here in this session today. Moving on to the subject which I've been asked to speak on, leading the team against an invisible enemy, story of an epic fight. This is a kind of topic which one does come across for various sessions when you do a symposium, when you do a leadership session. This is a kind of topic which is given to you to speak on, and several times. But I must say that in all the previous times when I've been had to give a talk on leading a team, I would probably be talking more with what I think I could do rather than having real life experience of leading a team against an invisible enemy. The last year with COVID and the pandemic, truly, in a very true sense of term, it has been a journey against an invisible enemy and truly an epic fight. It's been more than 14, 15 months since it all started. And this question has been posed to me several times. And the underlying thought with which, or the approach with which I answer this question has been different in different stages. In the very early stages of the pandemic, when somebody posed me this question, let's say within 2 to 3 months of the pandemic starting, my entire response would have been extremely tentative, extremely unsure, because while I was leading the team, we really did not know where we were going, how we were going. We were just taking one step at a time. Somewhere during the middle of the pandemic, say about 8 to 9 months, a lot more confidence, a lot more comfort, and a lot more sense of, okay, we know what we are doing and we know where we are headed and we are doing the right thing by the patient, and a little bit of, a lot more conviction. I don't know if I can safely say that we are towards the end of the pandemic or closer to the end of the pandemic. I hope so. But now when this question is posed to me, I do feel that the greatest sentiment in me is a lot more confidence, a lot more satisfaction that we've done a good deal of good work with the team. And more importantly, a lot of learnings, which makes you start thinking about what are the things and learnings which you will implement for the future and kind of get ready for something which may land up on our doorstep sooner or later. While having said that, so I mean, that just goes to show what has been the ever-changing scenario in this 14, 15-month-long journey. But still, I must go back, to answer this question honestly and to catch the spectrum of emotions, I must go back to right in the beginning. So this is about the month of March. Clearly, we heard about it. We knew that we need to get into something like treating COVID patients, but we really did not know what it was. We did not know what we were going to get into. And there was a lot of confusion. There was only one thing which was truly clear. There was an objective of that this is an area which we need to participate in. Like many have talked about it, I think me and a lot of the core team are there on this, sitting here in this session today. What we were clear about was we did not know what we were getting into, but this is like a wartime situation, and this is a wartime situation for healthcare, and this is a time we need to stand up and be there to serve the community. So with a lot of tentativeness, with a lot of confusion in our minds, we were clear about our objective that we wanted to get out and be there to serve the community. The very first task was to putting together a team, and this was a core team, which we were like-minded, and we were a team of say about 5 or 6 people who actually volunteered, and they covered the spectrum of our emergency medicine, infectious disease, and our critical care team, who came forward, and there was that confidence and that willingness to go ahead and face whatever we had to and getting ready for the pandemic. So once we had the core team in place, we needed to make sure that we had a buy-in from everybody. While we may not have been, not everybody would have been wanting to be a frontline, the entire clinical team, the entire staff, we needed to have a buy-in so that this was a common goal which we had and working towards this. And the minute we had this, the next step was to put away and allaying fears for people. You know, when you are completely in a situation today, when we look back, it's so difficult to imagine what it must be to say that we really did not understand. Today, there are so many aspects of it which we completely understand. So look back at that time when we started, like if all of y'all, it must have been the same for all of y'all. We really had no clear idea of what is safety, how we would keep ourselves safe. And while we had this good intention of wanting to be there and work for the community, there was a niggling fear. I'm sure every clinician had this niggling fear about whether they would be safe themselves. And from our own point of view, from my own point of view, every single moment I had this constant worry: am I pushing people into doing something, and which will am I pushing them into an unsafe zone? Am I taking sufficient precautions? Am I making sure that my people are safe? It was a constant niggling doubt. At no point of time did I always have an answer that yes, everything which we were doing was right, but we went into it. The strength of it was the team came together and we knew that this was our objective and we went into it. And I think it worked out very well. So let me share just 3 or 4 things which were the manner in which we went about it, or our principle by which we actually were able to continue with this journey. So starting out, like I said, when we had our team ready, the first important aspect was with what little we knew, we needed to get our protocols right, and we needed to get our infrastructure right. And this with great deal of planning and very elaborate working, we with the team, we got this together. But do it all right for the next couple of days. Within 24 hours, sometimes we would have realized that all that we'd planned for did not really work, and we have to realign and rework and recoup. And so every best laid plan lasted for not longer than 24 hours, but we had the wherewithal, and together as a team, we were able to constantly redefine our working, redefine our protocols, and keep getting ready for the next day. I think the first lesson we learned was, while we needed to have protocols in place, we had to be very nimble on our feet to be able to be ready for a change. And the whole approach was completely collaborative and with extensive education, extensive communication, and handling one problem at a time. And taking one day at a time was how we were able to approach the problem. Having done this, and within with a couple of days into it, into the pandemics, probably a couple of months into the pandemic, the whole aspect was about scaling up the infrastructure. So while we had a clinical team, initially we started off with only a few critical care patients which we were taking care of, because we thought we were best suited for critical care management. And then we realized that we would need to take care of patients who were not in need of critical care, but a little less critical care. So we expanded our services. So we started off with critical care beds, but rapidly we went in to expand our requirement. So this, the second aspect of our whole management was, even in terms of our infrastructure, to be able to quickly scale up services depending on the need. And this is a hospital which was working with both COVID and non-COVID patients. So they, as and when, and there was, we serve the community for non-COVID as much as for COVID. So we had to be constantly very, very aware and extremely efficient in terms of utilizing what resources we had, depending on the ratio of COVID to non-COVID need. So while we would, rapidly escalate the COVID services, like we did when the second wave happened, putting in all our beds and everything to COVID service, at the same time maintaining our segregation and division, we would rapidly be also able to de-escalate and bring back the non-COVID services the minute we felt the need of the community was more non-COVID, at which we could not neglect, being in a serving a large community. So the ability to move around with this was another a very important factor in our success. And this was a team which was working this thing, and it has been a very, very long period. I mean, 14 to 16 months of continuously working, and at all points of time, having some of our own staff falling ill, from the clinicians to the nurses to at all stages falling ill, was a very, very tough thing to handle. But to keep people motivated, to keep people motivated in different ways, and not letting a feeling of a sense of defeat, or not letting a sense of we can't do this, kind of this thing seeping into anybody's psyche, was something we really focused on, and I think that really helped. So, one of the things which we would hear from patients or people who walked into the hospital, even at the peak of the pandemic, was even if when there's so much of fear all around, when we walk into the hospital, we find even your security makes kind of comes and talks, and every member of the hospital doesn't seem to show fear. Now, that was a big validation of the spirit which we'd been able to keep alive in the hospital, and which was, I think, only through a collective approach and repeatedly educating people, repeatedly supporting the staff, whatever the category they were, with the best of protective approach for them. And in the first place, giving all of them the comfort that the hospital is there to take care of them and their families, and they need not worry about any of that. They only needed to go out into the, the battlefield, so to say, and to manage patients and serve the community. So with all of this, the next challenge was staying afloat and to keep going, and which we've managed so far quite well. And the next part of it was, at some point of time when we realized that while we have learned to manage the pandemic, it was also about getting collaborating. So, in the city of Bombay, we've had excellent collaboration and excellent sharing of education and protocols, and in networking between hospitals and networking between public and private care, which also helped us to stay connected in terms of requirement and exchange of information. In all of this, there are many lessons which we learned. As we moved on into the second phase, knowing from other people's problems, we learned to handle the oxygen shortages. We learned to handle drug shortages. We learned by and by, we also settled on what is the optimum approach for us. I really have great admiration for the clinical team, which I had the good fortune to lead, because they knew exactly, there was a information overdrive. In this information overdrive, they were able to figure out what was the appropriate clinical treatment which would work in our setting, and we rapidly did away with that which was not validated, and hence constantly keeping an eye on outcomes and results, we were able to really give out good results. And if there were a couple of points which were really features which helped us in doing a good job, it was a collaborative approach. It was a complete open-mindedness to constant change. It was our ability to be dynamic and keep changing our protocols. It was treading cautiously on all aspects. It was to have a logic in our decision-making and not to be overrun by the various emotions and the fear, the panic. We did not allow any of that to come in our way. And at all points of time, I think at the end of every day, there was a huge sense of gratitude that we survived the day, a huge sense of gratitude that we ended the day with some positive contribution to the society. And now we've also started looking on to the future to see how we would take all our learnings from here and go into the next level. So all in all, it's been a phenomenal journey. It's been an opportunity of a lifetime to be able to go through this as a leader of a healthcare organization. Very humbling experience. But the biggest, I would say that the emotion today which I feel is a sense of gratitude to the team which I led, a sense of gratitude to the clinical team which I led, which never tired, which never stopped working, and which I had something new to be able to offer to everybody. And in all of this, not losing their cool, not losing their own sense of balance, and to keep at this for say 14 to 16 months has been a very, very enriching experience for all of us and for myself, and extremely grateful that we've been able to do what we could in the city of Mumbai. So it's been a very gratifying journey, and I hope the pandemic ends soon, but I hope we continue to keep doing our good clinical work, and of course, keeping the society safe with vaccination and other measures also going side by side along with treating of patients. So thank you, Sandeep. Thank you for giving me this opportunity. And thank you, everybody.
Yeah. Thank you, madam, for giving this enlightening talk. Dr. Shweta, you would like to have some comment?
Thank you so much, ma'am, for your detailed and comprehensive insight about the challenges you faced in the leadership role through the pandemic. This truly is inspiring, and this puts so much of confidence in the entire team that they are well taken care of. At the same time, there is no compromise in the efficient medical care. A leader is one who knows the way, goes the way, and shows the way. And I think you did all the three very well. Thank you so much, ma'am.
Yeah, thank you, madam, for the talk, and thank you for always being the inspirational leader for all of us. Thank you very much. Now I'm going to our next talk. Next talk is how Mumbai and Maharashtra fought against the pandemic, a saga of strategic success. Our speaker is Dr. Rahul Pandit sir. I think I should not be giving his introduction to this forum because he is a very well-known personality in this crusade against the pandemic. He is the director of critical care medicine in our hospital. He is a member of COVID task force of Maharashtra state, and he helped Maharashtra government in various aspects while managing this COVID pandemic. As a recognition of his work in task force, he has been appointed as a member of task force at the national level by the Supreme Court. We have seen him on various academic, non-academic program of public programs by enlightening people and doctors all across the Maharashtra, giving them knowledge about the COVID evidence-based practices in the COVID. I think he has gave the lion's share against this war against the pandemic, crusade against the pandemic, when Maharashtra and Mumbai is fighting against this unforeseen calamity. With this introduction, I request Pandit sir to share the strategies which you have adopted along with the government of Maharashtra and other your team members to overcome this pandemic calamity. Thank you.
Sandeep, good afternoon, and thank you very much for that lovely introduction. I really am kind to you for allowing me to sort of interact with you guys. And first and foremost, congratulations and enjoy the World Emergency Day. You guys are the first responders in anything, whether it is in the hospital or outside the hospital. The world would not be the same without the emergency medicine department actually stepping out of the hospital and helping people out. So I think you guys do a stellar job. And the hospital, literally, you are the doors of the hospital where the patient comes in. You have no idea what the patient is in. And I can tell you that was exactly the feeling which we all of us had when the pandemic struck us. And I'm going to just share my slides, Sandeep, if that's okay with you. Just let me know if the slides are visible to you. Can you see the slides? Sandeep, are the slides visible?
Yes, sir. Yes, sir.
Very much
Thank you.
visible, sir.
Thank you very much. So, Sandeep, how much time do I have? Because originally I was supposed to finish at 4. So,
No, you are not supposed to finish. You are supposed to start at 4.
I was supposed to start at 4. Okay, so I'm right on time. I thought we were running a bit late.
No, we are at time, sir.
My ignorance. Sorry about that. Thank you. Thank you very much. So, look, over the next 20 minutes or so, I would like to share what we all went through. And the slides are nothing but a pictorial, representation of what we all felt. And I would just start with, recently I gave a TED talk. And in that, the first actual memory of me remembering that we need to be prepared about the pandemic was the IICCM conference in Hyderabad, which was just before the pandemic actually hit us. It was in the first week of February, last week of January, first week of February 2020. And we had a few colleagues from Singapore, Hong Kong, who sort of talked about the presence of this virus and how WHO is thinking that it's already gone into pandemic proportions and it has been declared as a pandemic and we need to be prepared about it. Even till that time, January end, it was not on our shores. It had not come into India. So we were really, quite surprised that why is everybody so worked up about this? And the idea looked very, very freakish, honestly, but it was sort of taking birth in all of our minds. And all of us were wondering what would happen if this turns out to be a reality. The spacesuit clad people who are seen in this photograph with the patient talking to a patient were only photographed in our memory from what was being shown on the television happening in China, Hong Kong, Australia, Malaysia. And we were really wondering what would happen if it does come to India, and then how do we actually go across with it. But where we always that but comes up, that when we are least expecting it, it comes to your shores. And all we knew was, yes, it is probably going to come, but come up with that kind of an aggression is not what any one of us actually thought, and any one of us even was prepared for it. But it happened, and the cases started pouring in. The first case, which was detected in Pune, I've got my friend Dr. Prasad Rajhans, who is I could see on the dais as well. And Prasad would know that there was this panic that the first case has been detected in Pune. Then the Italian tourist came through from Delhi, and we had the Italian tourist then flew. Sorry, not Delhi. In fact, it was Jaipur. Fortis Hospital, Jaipur was looking after a few of them. The SMS Hospital was looking after a few of them. And then they were flown across to Vedanta in New Delhi to be looked after. And then the cases started to trickle down in Mumbai. And where did the cases start coming down? I think what could we have done differently at that time? We knew that this was a disease of the passport holders. It was not in the country until the passport holders came across. And what we could have probably done there was we could have isolated those people at the airport itself, which I think did not happen. And it did not happen because we were really not sure whether that's the right way to do it or not. You can always say that we need to learn from our mistakes. And we did eventually do that in the second wave when we actually stopped people from coming, especially when the UK strain was talked about. But in the first wave, the Mumbai airport, which is one of the busiest one, had a lot of people coming in from UK, US, and Middle East, which is what brought the virus to the shores and which is what brought the virus to Mumbai. And suddenly, Mumbai became the main, the center point. Kerala and Maharashtra became the two states where the cases were seen maximum. And the reason was we had this population which had flown into the country, into the cities, into the states, and we were not sure how we are going to actually look after the population. And slowly and steadily, the cases started to go in. I remember the first patient which got admitted to Hinduja Hospital and who succumbed. You know, the chaos, the fear, hospitals shutting down, all became a reality. And this all happened before the 13th of April. I've got this slide up here, which shows in Marathi, 13th of April 2020 is the day the task force was formulated by the order of the Chief Secretary of Maharashtra government. But all of this happened before that. Even before we knew what was happening, 2 or 3 major hospitals in the city were shut for a few days. People were quarantined, and once they were quarantined, at that time we were actually quarantining them for 14 days. Even we do that even now. But I think just by the presence of a patient in the hospital, entire chaos had set in, and we were not really sure which direction we are going to move across. The mortality rate was seemingly very high. There was hardly any information, education, and communication which was happening. And the mortality rate in the first 3 or 4 weeks of the pandemic hitting the state was Mumbai showing a mortality rate of around 10%, and Maharashtra having a mortality rate of around 8%. And it looked like people were just coming to the hospital, and no matter how hard the doctors tried, they were not able to save these patients. We were actually looking and facing at an enemy which had no form or shape, which was microscopic, and obviously was able to cause this amount of devastation that we could not even comprehend it in our minds, rapidity with which the patients were actually succumbing to it. So the government of Maharashtra, under the leadership of Honorable Chief Minister, actually formulated a task force of around 10 doctors. And these 10 doctors were chosen predominantly from the private setup and the public setup of Mumbai. And they were supposed to be the committee which would advise on how are we going to bring the mortality rate down, and what do we do with this unknown enemy which has come to haunt us literally, and how are we actually going to improve the outcomes on these patients. And these were very, very serious questions. I remember the thought process when I actually went in from this from hospital to the Mantralaya to meet the Honorable CM. And what are we going to talk about? What are we going to think about? How are we going to clear this pandemic? I knew my role in the committee, that I was going to basically be involved with the critical care management rather than the infectious disease and maintaining quarantine and stuff. I was actually going to be in the critical care, where the battle was going to be fought inside. It was going to be an indoor battlefield where you would see that the patients were essentially going to be our center of our care, center of our attention, and we were supposed to get them better somehow. And that's when I realized that, look, I need to give ideas and thought processes which would actually be of some scientific background, and not just say that we've got a virus, what do we do? So with that thought process, I entered that room, that conference room of Mantralaya, and a lot of people, initial introduction and stuff which happened. And I mentioned about 2 things at that time. And why was I there? We were one of the first ICUs, as Madam Narayani said. We were one of the first ICUs to actually start admitting patients in Mumbai. The private sector I'm talking about. We had hardly 3 weeks in, and we were already being talked about as the ICU to look after patients and stuff. Already I've been communicating with the BMC guys, and we had conducted a big webinar. And the first time I realized that you do an online webinar and you could actually have 2,500 people attend to it, and that was at a day's notice, 1 day's notice. So that is the amount of information people were wanting to know. What can be done? How can it be done? So anyways, I enter that room, and I think I'm going to just talk about what has been proven things, and I'm going to talk about a few simple things. The 2 things I mentioned on that day was, one, I said we need to use proning as our main method of care. So we should be proning these patients, awake proning, as well as we should be proning them when they ventilate them. And the second thing I talked about was the 6-minute walk test. And literally everybody in the room looked at me when I talked about 6-minute walk test, and they said, "What's that? Why are we talking about 6-minute walk test?" And how did it strike me? In one of the patients I was seeing in the hospital in the ICU. He came in on a wheelchair, and there was a monitor put up, and not wheelchair, I think it was stretcher or something, a wheelchair maybe. Monitor was put up, and the saturation was 90%. And he must have walked like 10 steps on his own to get onto the bed. And as soon as he went onto the bed, the saturation fell down. Saturation fell down from 90% to 74, 75. And that is how Sandeep,
Yes,
can
sir.
you can you switch off your microphone? Your background sound is coming through.
Yes.
Yeah, thank you. So that was the moment, everybody looked at me and said that why 6-minute walk test? And now 15 minutes down the lane, whenever I meet the Honorable CM, uh, many times he sort of brought it to my attention that these were the two things and we were all wondering, what are you talking about? So this indoor battlefield was going to be the playground with which we were going to be there for the next 15 months, 16 months. And why am I saying playground? It's a bad word to use for hospital care, but literally we've actually stayed there for the last 15 months. My team, the leadership by Madam, support from Sandeep and his team, the infectious disease team, the physicians, we've all had only one life in the last 15 months. None of us have taken more than 2 or 3 days break, apart from the fact that most of us have had COVID and had taken those 13, 14 days as a holiday, which were terrible days. I don't even want to remember them. But those were the only times when we thought of that we were probably, are we doing the right thing? Are we going to get out of this problem or not? But apart from those 14 days, I think we've had an extremely positive team who is considered that is going to be the turf on which we have to actually keep on working hard, and we have to keep on improving. Whether it was the indoor in the ICU, whether it was the indoor in the emergency department, I think that's what we needed. And lot of things which we did here kept on getting added to the recommendations which we started to putting up. So the first task which was given by the committee to us was to come out with recommendations for treatment protocol. And trust me, 13th of April was the day the committee was formed. The first set of recommendations came out on the 22nd of April. So within 9 days, we brainstormed, looked at all the documents which were there currently available, looked at all the papers across the world, spoke with multiple individuals who were looking after patients. And I actually had a couple of webinars with people from China. Even there, even though the English was very limited, we actually had few people who could interpret for us. And we looked at the way these people were treating patients at that time, and that is how the first set of recommendations came. And the recommendations have evolved. It has been a live document. It is not a document which was just put up once. Every Monday, one of the main agendas on the task force meeting, which happens on every Monday, is actually to look at the evidence and keep on adding to it. And this is how we have been able to come up with more and more scientific evidence. We've got some recommendations, and we've got some drugs, especially in the section of drugs, where we've actually put up some for compassionate use. And there is a warning that when would you not want to use it, or when you should use it. So it's been a fairly scientifically based document which came out. The similar thought process got followed very quickly. Though we were the Maharashtra government task force, there were district and city task forces which were set up, and there were smaller and smaller task forces which come up, which started mushrooming up. And one of the things which helped all of this was that even to the village level, there was some form of accountability which went down. Even to the small block levels, there was an accountability which was there. And over the next 2 or 3 months, every single day, apart from the fact that we were working, every single day, there used to be a 1 hour or 2 hour communication with one of the task force of one of the districts, or maybe even one of the blocks. And that is how the knowledge was disseminated. That is how the knowledge was disseminated. People from Pune did it, people from Aurangabad did it, and more the Maharashtra task force from us, our side, we kept on talking to all of these people several times. I have forgotten the number of meetings I've had with every single district, multiple meetings with every single district of Maharashtra. And yesterday, day before yesterday, we were with Ratnagiri. Every time a request comes, we've never said no to even one request. We've always tried to accommodate it. Accommodate it. Sometimes two task force meetings in a day, looking at just the dissemination of knowledge. And then when the basics was being improved, obviously started the results to be seen. We could see that people were now coming to the hospital on time. We could see that the broad deaths started decreasing gradually, and we could see that the preparation which we had put up so much of effort in had started to sort of make some wave. Well, the preparation started off with we making videos of how to actually do a donning and doffing. Even to that extent, we had to start out doing things. There was a plethora of information which was being given out. Everybody was doing it, but I think the preparation needed to be done in the right way. And along with the preparation, we also had a preparation which was needed to have an infrastructure scaling up at the state level. One of the first things which happened was we realized the testing capacity of the city as such and the state as such was extremely limited. And unless we were going to see the testing capacity being broadened up, we would not have the capability or the ability to actually identify positive patients. And mushrooming of these biosafety labs across the state helped us a lot. From one lab in Pune and one lab in Mumbai, which is the Kasturba and the NIV in Pune, we now have more than 500 testing facilities in the state of Maharashtra. Maybe it has reached to 600 already. This information is around 2 months old. And that is the exact reason why we are actually seeing reporting of cases being much higher than many other states. And one of the criticisms which Maharashtra went through and has been going through, even today, I got a WhatsApp message saying that it is the financial capital of the country. The state boasts of having the best preparedness for COVID-19. The state still has the highest mortality and still has the highest number of cases. And the only reason why we have is, yes, we have the richest municipal corporations in the country. We have the most advanced healthcare facilities any other place in the country would actually be envy of. We have been leading the fight, whether it is at our level, government level, doctors level, public level, and we have had a large number of cases come across. That's because we've been responsibly testing them and reporting them. Not one case in Maharashtra and Mumbai has not been it's not, you cannot point a finger, beg your pardon, that the reporting has not been responsible. Every single case which has been come positive has been reported. Every single COVID related death has been reported. And that is the only reason why you're seeing our numbers are very high. Why does it start from Mumbai and Maharashtra? Well, it obviously is going to start from Mumbai and Maharashtra because it's a financial capital. People come and work here. They come from other states. There's a large density of population in the city, and to look at that density, there is no other comparable density seen across the country anywhere, leaving some parts of Bombay, of Delhi and Kolkata away. Otherwise, Mumbai is the most densely populated city, and surrounding the Mumbai area, there are probably less denser parts, but we still have the population which comes into Mumbai to work every day from Kalyan, Navi Mumbai, Vasai Virar, Bhiwandi, so on and so forth. So the preparation started, and the first challenge which we actually did was chase the virus. And the chase the virus, though the concept has been talked about by our Honorable Municipal Commissioner, Shri Iqbal Singh Chahal, it was a task force which actually recommended that let's have our pulse polio team go from house to house in Dharavi, because Dharavi was the action point at that point. If Dharavi would have had multiple cases and the COVID would have entered Dharavi in a larger way, we would have actually had large number of mortalities, much higher than what we are seeing right now. And the pulse oximeter campaign picked up very quickly. That helped with the basis of the whole planning in Mumbai was done by Honorable Municipal Commissioner at that time, which was Praveen Pardesi. And then Mr. Chahal took over and he took it to the next level. The day after he was appointed, you actually saw him inside the Dharavi in a PPE suit. And he was sort of in a PPE suit, he was moving around and instilling confidence in his team that it is safe to come in with a PPE kit. You don't have to worry. You can wear a PPE kit and walk in. And I think that was a game changer. That was a game changer. The doctors and nurses were not alone anymore. We had all of this admin staff, including police, who would actually come in. And I think that made a big difference. What we did was a very simple thing. We would put up a pulse oximeter on every patient who had comorbidities and who was above 60, 55 years of age. And if their saturation was below 93, they were taken to the hospital. No questions asked. Then the testing was done, X-ray was done, treatment was given, prone position was advocated. And that is the way we controlled the virus, by aggressively testing, tracing, isolating, and then contact tracing and isolating those patients again in Dharavi at a very, very crucial junction. I think it happened at a very crucial junction. And this chase the virus was obviously appreciated across the world, because you don't have a denser population more than Mumbai anywhere, and Mumbai doesn't have a denser place in terms of population than Dharavi anywhere. So as we all know, Dharavi would have been the turning point, and it did become a turning point, but in a good way. The other thing which task force immensely contributed was, and this is, I would say, the idea of our task force chairman, Dr. Oak, who actually discussed it at length with the Honorable CM. And in no time, there was permission granted to build up these huge jumbo units. The huge jumbo units which were there were brought up to look after 500,000 patients with 100 intensive care beds, ventilator. The funding was quickly allocated, and we could see that the infrastructure was not going to be the limiting thing. The limiting thing was going to be the manpower to actually manage them. And another thing which came up was the war room setup. This war room setup today, I am talking about the same war room setup at a national level as well. And the war room made a big difference. From one war room, we divided it into 24 war rooms in the 24 wards of Mumbai. And a similar concept came up at every district level in the state. And what we had was, we had 10 computer screens, 10 people sitting in each war room, and 24 war rooms. So we had 240 screens. So even if 1,000 patients came up positive every day, each one had to only look after 5 patients. If 2,000 came up, each one had to look after 10 patients. So when 11,000 patients came up, 11,000 divided by 240, each one had to only look after 30 or 40 patients, not more than that. And they were able to quickly assign these patients into hospital beds, while entire country struggled. And I'm not saying Mumbai did not struggle. While entire country struggled, Mumbai did not come anywhere close to that. We always had beds in form of, we were touching brim to brim, and we rapidly escalated in the second wave to more jumbo centers being built up. But there was a process in place, and that's why the beds were allocated very, very quickly. The war room became the way to go, and the intensive care became the way of living. It was almost like a modus vivendi. We were looking after patient. This is my ICU photograph. You can see that most of the beds are full. Patients are being prone ventilated, and some patients are good. But soon we sort of started to come out of the wave as well. We started to realize that the numbers are starting to drop down. The patients are equally being distributed, and the critical patients were coming to us, whereas majority of the patients were now getting managed either in the corona care centers or in the wards. We were not really looking after those patients. The ICU became a different place. We started realizing the patient's needs. The patients took the disease in a reasonably positive way, that we need to come out of this. This is one of the policemen who was one of our highlights, who would play flute every evening and afternoon and keep other patients entertained as well. And I think people like him actually brought in a lot of positivity in that completely gloomy ICU environment which was there. And a lot of patients relate this kind of an attitude when the other patients come and talk to them, when the other patients are seen being a little bit better. I think it brings out a little positivity in those patients whom they feel that their outcomes are not very good. As time went by, the cases started to drop down. The cases dropped down, and the cases dropped down by the end of September. Mumbai and Maharashtra peaked and had already starting to come down. By December, the virus and vaccine were the two things to talk about. And across the world, the vaccination program was launched. And we were thinking, when are we going to have the vaccination program launched? And on 16th of January 2021, the vaccination program got launched. As all of us are healthcare workers, we were fortunate to be among the first batch of people who the government actually wanted to vaccinate. And I think that was a very, very good step. And you can see me getting vaccinated here right on the day one. And from there on, the entire focus changed to not only just taking vaccine, but also talking about vaccine hesitancy, which became a new word for me to actually understand why should there be an hesitancy. And that was from these reports of some of the complications of vaccine. Some of them actually saying that now that the numbers are down, do we actually need to take vaccine? The general feeling amongst people was that corona has gone away. Why should we have a vaccination program continue? And this is my lovely team of nurses and doctors, just a small bunch of them, and a couple of them are from emergency department as well, and a few physician trainees as well, who actually, were staying together. They had become a big family. This is one of the floors which madam was kind enough to actually empty out for all our staff to stay in. Of course, times have changed now. Most of us now go home and come back. We have now got to know the virus better and better. If we keep up our PPE kit intact and we have a good shower after that, you can easily go home and be with your family. But those were the times when we were actually still working as a group and also staying and living as one family. And these were some of the happy memories which I think we would all cherish, that we actually spent some good time with our colleagues and friends. But long before we could forget about the things, the second wave struck us. And the second wave struck us with such a ferocity that the first wave looked like nothing absolutely in front of it. From having 2,600 patients at the peak on 16th of September 2021 in Mumbai, and around 32,000 to 30,000 patients in Maharashtra, we were going to 11,500 patients on 4th of April, and Maharashtra touching and crossing 70,000, 60,000 on numerous occasions in the last few months. Last few months. And with that came up a new problem. We always were thinking of oxygen, and the oxygen shortage became a big concern. Now, here again, I would tell you that as the cases started to go up on February the 10th, I think a Sunday following that 10th of February, I was going to, it was a Sunday, I finished my round and decided with my wife, I've got a small place near Karjat to go. And we decided to sort of drive down there. And I was driving, they got a call that task force meeting has been called by Honorable CM. He wants you on there. So I stopped the car on the highway on a side, and I logged in from my phone. And the thing was that, look, the cases have started to go up. What should we do? Here again, the task force first said that if the second wave is now coming up, and which is what it looks like it's coming up, we all were warning about it, but it was now, we were well and truly into it. Oxygen is going to be the biggest problem. And we need to look after the oxygen. And I must say the Maharashtra government actually took a lot of proactive steps. From our requirement of oxygen being around 800, 900 metric ton, we went up to a requirement of around 1800 metric ton. And while Maharashtra is one of the oxygen producing states of the country, our oxygen requirement went beyond our production capacity in the state. And we had to then ask some of the steel plants in the state, as well as the nearby steel plants. And we went right up to Visakhapatnam, and the first Ro-Ro Express, which was talked about, the idea was given by the task force to Honorable CM that let's get the Ro-Ro Express to come and get us oxygen, because these oxygen containers, the cryogenic tankers, which we call as, have got a governor, and the governor, they limits their speed to 35 kilometers per hour only. So if you have to bring in the oxygen from the east coast, which is where we were given, right in West Bengal, the pickup point for oxygen, it would take at least 6 days for a truck to just reach here, and 6 days for them to go and pick up. So it would have taken 12 days. The Ro-Ro Express changed the whole thing. We put up the trucks on the train. In a day and a half, the train reached there, and a day and a half the train was back. And oxygen crisis in Mumbai was dealt in much better way. What Mr. Chehel did was he divided the 24 wards into 6 of each group and put up oxygen depot, a small depots in each of them, and we could fill up the oxygen from there. The second crisis was about the drugs, be it remdesivir, be it tocilizumab. A lot of education went in. Right from the top, the education went in that these are not drugs which are going to be acting like a magic bullet. You need to use them rationally. How to use those drugs, which condition to use, what and what not. A lot of talk went about that. And then I'm coming to my last couple of slides. Came the dreaded news that actually we have a double mutant variant, and that concern was really alarming for all of us. So we knew in Amravati there was the second wave, which is where it originated from. The double mutant was there, but now it was actually spreading across the country, and it was well and truly seen around 26% samples of Maharashtra, and that's when the genome sequencing started to pick up. As of today, Maharashtra is the only state which, on a weekly basis, from every district collects samples for gene sequencing and is sending it. No other state in the country is doing that right now. We are the only state in the country which is actually doing it on a regular basis, and we are getting information about our strains which are there, the variants of concerns which are there. Why do we need this? We need this because there is a fear now that with the vaccination program, now people have understood the importance of vaccination. There might be still outliers, that's a different thing. But we now know that if people have a vaccination program going on, we need to know the immune escape mechanism which is present or not. And if the immune escape is something which we have to deal, we have to then vaccinate these people smartly. While we know that the majority of them have the Covishield, Covaxin, and now the Sputnik, which is available, and we may have a few more vaccine platforms coming up in the few months to go, and it would probably ease out. As I was speaking with Madam this morning, Dr. Narayani this morning, we all feel that in a month or two, the vaccination may become even more smoother process than what we have today. But the reality remains that if I have an immune escape seen in Covishield, in a group of population where this variant of concern is present, I may have to deploy another vaccine which will actually look after that. And unless we do gene sequencing, we will not be able to understand which is the variant of concern which is causing infection somewhere else. And friends, why are we worried about it? Because if we don't vaccinate enough, we are going to land up in a third wave. And if we don't keep up with our COVID appropriate behavior, the third wave could be either reaching much higher than the second wave, or it could be down as well. Nobody knows. It's a crystal ball. Anybody can think what they want, but it only time will tell us where we are. But at the second wave, the entire country's infrastructure is challenged. Entire country, not one city, not one town, not one village has seen been battered for healthcare infrastructure, which has been woefully short. But if the third wave is going to be bigger than the second wave, historically it has not been, but if it does, it will be putting up all of us out of the context completely. Today, there is no citizen in the country who has not lost a near and dear one, or a friend, or somebody they knew at least. So we all know families now, or we've had deaths in our families. At least this is what I have understood, that this second wave has been unforgiving. And it is in our hands to make sure that the third wave doesn't come in. And what are the simple things which you would do? You would basically put up a double mask. When you're walking out of the house, double masking. Social distancing and sanitization are the virtues. And whenever your turn comes for vaccination, please go and vaccinate. The fear which is being described is that we are going to have children as a vulnerable population which is going to be affected. I hope we don't see a third wave. I sincerely hope that if we all remain and have our COVID appropriate behavior intact, do not tolerate other people who don't keep up with the COVID appropriate behavior. Report them, teach them, educate them, fine them, do whatever it is, but keep up with the importance of the COVID appropriate behavior and vaccination. We don't want our younger generation to have any sort of problems. You may have your own opinions whether it's going to happen or not, but God forbid if this happens, we are all going to be stressed out and stretched out beyond our capacity. Even the second wave would just look like a trailer. So My friends, with this, I would like to end and summarize that it was an amazing journey to actually go through the whole process of 1.5 years almost, but it is a daily learning process, and every single day things have taught us a lot. Sandeep, I am sorry I took 4 or 5 minutes more, but thank you very much for inviting me and allowing me to talk. Thank you, Sandeep.
Yeah, thank you, sir. It was a very much enlightening talk. They say that strategy is the key for success. And I think Honorable Chief Minister of Maharashtra, he did a first strategy by making a COVID task force. And we are seeing the tangible effect of this thing now. The wave is waning off, and Maharashtra is doing far better as compared to the other state. Credit go to the all task force member and visionaries of the state. Thank you very much for this fantastic talk, and I think this gives lots of learning to other young emergency doctors also. Now, I will move to the next session. I think now we have two senior most panelists in our next section. Is Dr. Prasad Rajhans. Prasad Rajhans, sir. I can say he is the pioneer of pre-hospital medical care in India. 100 is his brainchild, and he is past president of Society for Emergency Medicine India. He is a director of critical care as well as emergency medicine at Dinath Mangeshkar Hospital. And we'll lots learn from him, not only medicine, but also wisdom, because lots of time he shares beautiful quotes with us. And they are the quotes, means they are very beautiful quotes, and they think us to think about the quotes. So he is not only a source of knowledge, but he is a source of wisdom also. And our next panelist is Dr. Moderator is Dr. Sanjay Mehta, sir. He is a senior most emergency physician. I can say one of the senior most emergency physician in the entire country. He heads emergency medicine department at Kokilaben Dhirubhai Ambani Hospital. Sir has various research papers published, and he is a strong academic support to the Society for Emergency Medicine India Maharashtra chapter. He always available for us various academic activities, and his clinical pearls are always helpful for all young budding dynamic clinicians. And hence I gave entire these things to both of you. I think, and shortly I will brief the panelist also, and then I will give to this our panelist. I think Dr. Charudat Vaiti. Hello, Dr. Charudat Vaiti is a senior critical care consultant in our hospital. He is the backbone of our ICU. And then Dr. Shweta Tyagi, she is a Maharashtra State President of Society for Emergency Medicine India. And she is a consultant emergency medicine at HN Reliance Hospital, Mumbai. And our third panelist is Dr. Nitin Zagasia. He heads the Department of Emergency Medicine at Apollo Hospital, Navi Mumbai. And he always contributes to the academics to the Maharashtra state. And the fourth panelist is Dr. Sagar Sinha. He heads the critical care department of the MGM Hospital. Also, he is associate professor of emergency medicine. He has a meritorious career. He has some couple of gold medals in his career, as well as he has some 20 publication out. So with this esteemed moderators and faculty, I give further things in hands of Prasad Rajan sir and Sanjay Mehta.
Yeah, good evening, everybody. Myself and Sanjay were discussing what should be the topic of discussion regarding the panel discussion. And we have kind of framed some questions for the panelists. So Sanjay, would you like to start and start with the first question, what we have planned?
Yeah, so I think we have a good bunch of people here and hope we have a good discussion. So my first question is, the theme is managing teams and managing COVID. So it has been a dual challenge for most of the people. So I'm going to pick up some questions from each of these themes and put it across to the panelists and see their views. So the first is that during this entire pandemic, how were each of you able to manage the duty rota and the shifts of the available staff? Because it would have been a big challenge to give them duty, to give them rest, to give them quarantine period and all that. So can we start with Nitin?
You'll have to audio. Nitin, you'll have to
Audio.
put on the audio.
Can you hear me now? Sorry.
Yeah.
Yeah. No, thank you. And it's great to have this session today, the entire day. Already learned a lot. Coming to your question, yeah, I was just thinking as you were talking, and it seems like such a long time ago because we've come a long way with respect to duty rotas. But to remind myself, yeah, we had to create um, a separate team altogether. We had to keep them in the same area. They couldn't mix around. So it was hugely challenging. First of all, they are working in this COVID environment, wearing PPEs. And then even when they finish the duty, they cannot meet other people. So I was particularly strict here. And now looking back, it feels like, okay, but it had to be done at that time. What we had done is we had to help with the rota gone to a 12-hour shift, and we had kept people in rotation. So they did few weeks in COVID duty, and then they rotated to non-COVID after a period of only 4 days. We could only afford 4 days. The guidelines were 7 days between COVID and non-COVID, and that is how we kept them separate. And I had to be the main person to tell them they cannot eat together, they cannot, socialize in any kind, because if one person got infected, we would lose 3 or 4, and then that would be difficult to run the department. So those were the initial, you can say, couple of months. It went like that. And similar to the nursing, so we had to keep the nursing in the same way, the housekeeping in the same way, organize food and drink for them while they were on shift. Where do they eat? Where do they don and off? So it was, I have to say, I was very lucky to be at Apollo because we are a relatively new building. So we had multiple entries and exits. So we could coordinate and label areas that they would use. And even from, I think Rahul Pandit sir mentioned about the floor at Fortis. So we also had a floor which was given to the doctors and nurses, and they were staying there, and we were arranging food and drink to be delivered over there and disposable stuff. But yeah, so the rota primarily 12
Did you
hours
have to
shift,
actually
4 hour
restructure
quarantine.
anything? Did you have to actually restructure
No.
any part of the department?
No, we were lucky. When I started at Apollo, I was actually disappointed that we had 2 separate areas. We have a 6-bedded emergency and a 12-bedded emergency. And I always felt it should have been together, something like Conclave or HN. It's fantastic. You can look after the whole department from one spot. But we had 2 separate areas. So we didn't have to restructure. We could just keep the 6-bedded for COVID and the 12-bedded for non-COVID. And the 6-bedded area, luckily, our maintenance team were able to make it completely negative pressure. So our entire COVID workload was in there, including the suspect cases. So they were all looked after over there, and we could increase the capacity there from 6 to almost 10. And with that, we were still stretched, but we were able to manage. Yeah.
So can I ask one of the critical care person, maybe Charudat Veti, that how did you manage the shifts and your staff in the ICUs?
Hi, good evening, everyone. Yeah, nice to be here, part of this panel and this, the wonderful educational program Dr. Sandeep has arranged and the emergency medicine department. So it's been an evolving sort of structure, as Dr. Yagyasi was saying. It's been a similar kind of process for us as well. So at the beginning of the pandemic, we're not very clear about how we should be going about it, the work stress, the isolation, and trying to manage the non-COVID areas at the same time. So we had a similar kind of process where the critical care teams were initially doing 4 or 7 days in a row, or 7 nights in a row, and then having the week off in the beginning. But then as time passed, it was not looking like a feasible option, and the duty schedules were modified to have 4 days. And initially, we had people staying in the hospital. Isolation policies were more or less similar, that they were not, allowed to meet the teams outside the COVID work areas for the obvious reasons. But then, as time has passed by over the last 1 year, now we have a rota schedule where we have our team working 4 shifts for the continuity, and then they have a couple of days off, and then they come out and work in the non-COVID area. I would also like to, thank the other departments who have pitched in to help us. The anesthesia department has been extremely helpful, because we always want an airway person stationed in the ICU, even if they are not been from the intensive care department. We wanted the airway person to be there in case of intubation or any airway emergency. So the anesthesia department helped to cover that particular segment for us and sort of eased our burden. Also, the other departments like the medical residents or even the surgical department, yeah, they pitched in to help us to manage the other aspects of care. Where the airway and the access was not an issue. The medical management, all that was helped by the non-critical care people, and it was extremely helpful, because otherwise I don't think we could shoulder the burden of workload which has been on all of us. So that's
Sanjay, I think
essentially how things have been.
Sanjay, I think Dr. Sagar also has joined. Looks like, welcome, Sagar.
Yeah.
Thank you, sir.
Yeah, you want to throw any light on the critical care aspect, the duty
Uh,
rota?
yes, sir. So, sir, being part of a medical college, it came a little bit easier to us. The difficult challenge for our team was that we were the only tertiary care center for the entire district, that is for Raigad. And in our department, we have a 60-bed unit, a 12-bed resus AD,
So
40.
primarily you are working in the critical care.
Sir, it's emergency and critical care for us at
Both.
MGM Kamote. Yes, sir. So it was a lot easier for us to integrate everything.
Okay.
So we had a 12-bed resus ED, we had a 18-bed EM ICU, and a 30-bed EM HDU. So at the very start, we immediately bifurcated a triage area for outside the hospital, and we shifted patients into COVID, non-COVID ED. And it was easier for us. We have a cubicle system for suspects as well as the ICU. And our team also takes the lead in the mass casualties and the disaster care. So it was very easy for us to appoint team leaders and get a lot of the people into various teams. And we had the war room with the core departments: general medicine, anesthesia, pulmonology, and emergency medicine. These four taking the SRs out, pairing teams with a clinical, non-clinical. So we had a buddy system. So it came a lot easier to us. And with the buddy system, 14 days on, 14 days off. And so we realized the biggest strength, medical college means no great tech, but we had manpower. So not trained manpower. So every 14 days, we would do these training sessions, crash courses, epidemiology of COVID, IPC protocols for nurses, doctors, mama moshis, the housekeeping staff, that is, and mental health preparedness, and then get the teams trained clinically into COVID and use our best resources at the most critical areas. So that was the start, of course. As of now, we have 300 residents trained in COVID care.
Okay. Yeah, I think, yeah. Sanjay, you would like to say something?
Enough for this point. I think we can move.
Yeah, we'll go to the next question, maybe for triage.
Yeah.
So Shweta.
So in this, in the same continuity, I mean, can I ask Shweta to just comment on how did you cope up with the infections happening in the staff and their families, and they getting quarantined, And how did you provide mental support, and what incentives were sort of provided to people working as frontline?
So yeah, so this was a very valid point, and the most important thing through the entire pandemic has been to keep the spirits of our own people high, and this is definitely not easy. The first thing is the long working hours we all had, then the continuous inflow of patients and sick patients. So, I mean, the depression was manifold. It was the fear of, taking the virus home, fear of getting infected yourself, fear of, seeing so many sick patients dying in front of you, so many of them worsening so rapidly. So, I mean, to keep up the spirit high for all the team, including your nurses, your doctors, was really, really difficult. But I think that's the spirit of emergency medicine, and that's how every one of us have coped with it. But yes, I definitely feel that breaking the bad news, the steps which we use for breaking the bad news, I think I use those steps to break the bad news of if somebody had actually come COVID positive in my team. So using all those things and telling them, okay, fine, even if you are detected positive, you will be taken care of. Seeing whether they were symptomatic, asymptomatic, depending upon whether they have facilities to be able to isolate themselves at home, or whether to arrange an isolation facility for them, and taking care of their families, their contact tracing. So everything was actually micromanaged by us for all our team members. So that really kept their morale high. And luckily, actually, we had hardly, not even, I can say, only 30 to 40% of our team members actually getting positive. So most of them did not go through that ordeal. So
Did anybody get positive after vaccination?
Yes, one of our doctors did get positive after vaccination, but that was an asymptomatic disease. He did not have any symptoms, and he tested negative in the next 7 days also. So that was
Okay.
it.
Great. So, Prasad, would you like to take up any critical care issue here?
No, I think before that, maybe we can ask. Yeah, I will take it up, but maybe regarding some triage, maybe Shweta can elaborate, because I think they did a good triaging system in their hospital. Just I
Yeah.
wanted to listen from her what they did actually.
Yeah. So, sir, we actually are a non-COVID center. So the entire, the burden of
Disconnected,
COVID.
Shweta.
Are you able to hear me?
Yeah.
Yeah. So being a non-COVID center, the entire COVID had to be, restrained at the emergency department level. So we actually restructured the department. So our waiting areas and the previous minor OTs and all that got converted into negative isolation, and we created a 10-bedded unit in the emergency department, which was completely negative isolation, and in which we had 4 resus beds, which we have, rather it's being continued. We are having 4 resus beds, 2 dialysis beds, and 4 observation beds. So 10 patients can be catered to, sick patients can be catered to in the isolation unit in the ER itself. So these patients actually are managed there itself. So coming to the triage and the screening, so we have a robust screening right at the gate of the emergency department, where the initial questioning and suspect symptoms and all. So if the patient is suspected or having any symptoms suggestive, are taken into the isolation. Their testing is done. Our gene experts come into 1.5 hours is actually the run time. So the complete turnaround time is somewhere around 3 hours. So within 3 hours, we get to know whether the gene expert is positive or negative. So once it's negative, they are moved into the normal ER. But if it is positive, we move them if they are in a condition to be stabilized and moved. We have our COVID facility in Seven Hills where 100 beds are managed by Reliance Foundation. So our team only manages there. So those patients are transferred to Seven Hills. So further management of the ICU and what happens there. So at any point of time still, we had like 10 patients most of the times here who couldn't have been shifted for some reason or the other, needed some interventions, some life-threatening, some angio, somebody with STEMI, with stroke, needed thrombectomy. So all those, will end up being with you because surgical backup wasn't available at Seven Hills. So that is how we managed to keep our emergency and hospital segregated from COVID and non-COVID. So we had 12 non-COVID beds and 10 COVID beds, so suspect COVID beds. So we are running the entire show with this kind of an arrangement.
Okay. Regarding critical care, like Sanjay mentioned, yesterday we discussed that we'll not go too much into the management of COVID, because then you start off with NIV and oxygen and remdesivir and ventilation and proning and awake proning and whatnot, and plasma therapy. So there'll be a lot of debate and discussion. But I think we'll try to restrict ourselves to managing teams and managing COVID as a challenge. So in critical care, particularly, I thought that communication with the relatives was very difficult. Communication with the patients was very difficult. Patients were seeing only people who are in the PPE and they don't recognize. So there's no human touch to the patients and they're feeling very lonely and isolated, away from the relatives, not communicating. So how did you guys communicate with the relatives? How did you make the patients more comfortable so that there are certain, not robots moving around, but human beings moving around them? Yeah, maybe Charudatta can answer this or Sagar can answer this.
Yeah. So yeah, I mean, as you rightly said, I mean, the communication has been an definite challenge in these times, but we have managed to sort of come to make it as like a process. So I'll tell you, I mean, we've been collecting a survey on this, and what we do is essentially on the first day we connect with the families, and we would tell them
So when you
about
say
what is
when you
happening with
connect
their
with the
patients.
family, do you actually discuss them in person or on video call?
It's telephonic. So it's all communication is virtual, telephonic. So our
Video call.
family, so family update is on the audio call, sir.
Audio call.
And so what we tend to do is we introduce ourselves. We tell them that it is a team which is looking after their loved ones. We would touch upon what is the clinical status of the patient. Obviously try to get some history from them. Once the communication is over, we try to set up the ground rules of communication so that the anxiety is alleviated, because we are all overworked and overburdened. So first and foremost, we try to make it clear that our priority is patient care, and communication, though important, it would be not feasible to do multiple communication. But then there is a reassurance to that statement that if you don't hear from us, then usually the situation is same. But if there is an issue, then you will be connected even if it is in the middle of the night. So no news is good news is one of the things which we would emphasize. And every day afternoon after the rounds, there is a general update. That general update is not a quick brush off update. It is usually a good time spent with the family, give them a detailed information, opportunity to ask questions, and conclude the conversation on the note that if there is an issue, we'll connect with you, otherwise we'll speak tomorrow. And that would essentially be a daily process. Apart from that, we would make efforts for the people who are dependent or on the ventilators to try and arrange video calls for them. If a person is on the ventilator who is sedated, paralyzed, prone, for family sake, sometimes we would make what we call as a virtual visit video. It is sort of shot in a way where there is a feel of almost visiting the the patient himself. They're like a walk-in video where you see the patient and the ambience and what is happening
So it is a
around them.
pre-recorded video, is that right?
Pre-recorded video, yeah. So we
it's
tell them
it's
that
not a live video.
it's not a live, because the patient is not interacting at that time, so we record it, and that clip can
It's
be
not a live video
seen
call.
by, not a live video call when the person is sedated, paralyzed. When the person is awake interacting, we'll do a live video call, because it would be like a pointless exercise of non-communication. So they can see the clips, they can share the clip between their family members, and it is almost like visiting the patient when the patient is asleep. When the
Yeah,
person
live
is
video call was
awake.
very helpful. Sorry to interrupt,
Yes.
but I'm just trying to channelize this discussion. The live video call was very helpful because, particularly in awake patients, because they used to feel connected with the family.
Right. So all awake patients, we would do live video calls, connect with the family members. The patient would also feel that he's interacting with the patient, with the family. The family will also be very happy to see their loved ones, and that would essentially be, if the person is able to use their own mobile, then that is also allowed, and they could use their own mobiles to connect with their families. But all efforts were made to give the details about the clinical status as well as the social requirements of seeing the person.
Sagar, anything you would like to add?
Sir, we did try to do some physical counseling as well. Like I said, so the location of my ICU is quite unique. It's on the ground floor. So we created a massive waiting area on the backside of the hospital. And we used to do essentially do counseling under a giant parapet. And because, sir, the type of clientele we deal with is the extreme low socioeconomic class. Till they don't see the doctor and till they don't have those questions to be asked. So it was very difficult for us.
Even during the first wave, you had patients' relatives coming to the hospital, because that time they were really scared.
Sir, not inside the hospital, but sir, in Navi Mumbai, Raigad area, everybody would be in the campus, and we have a huge campus. So they would be outside the building, obviously with social distancing, but they wanted to see the doctors, and they wanted to have that one-on-one talk with them. Here's a glass of juice, please take it to my mother. So that is very difficult for us not to do. And many of these guys don't even have smartphones, so it was very difficult for us to do the video counseling. A few of the middle economic class, we were able to connect with the video calls or try to get some communication, but it's a very different situation, in a rural side, very difficult to manage that clientele.
Looks like, I mean, what you are talking is completely different from many of the hospitals that were doing what they were doing in the cities.
Yes.
I think one of the biggest challenge was the communication with the relatives. So we all know now, everybody is talking that we did a good triage, we did a good segregation of COVID and non-COVID, we did a good ICU management, we did all, technical management. But, I feel somehow that the relatives were still left unsatisfied because of a lack of expected communication. So Indian patients, they want to talk to doctor every 10 to 15 minutes. Like even if they are waiting outside ICU or outside accident and emergency, they would come in every 10, 15 minutes and ask what is happening and what is not. So I think that this has been a big, challenge to maintain a satisfactory communication. And I'm working in A&E, not in the COVID ICU, but a lot of people who know me or know me through somebody call me and tell me to find out what is the status of their patient in ICU because they are not getting proper input. And once a day input is too less for Indian patients, or Indian relatives. So I think that challenge is one thing where we have not been able to go over the board and satisfy all our customers.
Very true. Very true. Yes.
Okay. So one thing, a new topic which I would, although it has been covered now. So would all of you give your input that if you have to redesign your department in future, whether it is critical care or whether accident and emergency, do you get a lot of input from handling this, that how your next or future emergency department or ICU will be like broadly? Nitin?
I think one of the major things would be negative pressure because that seemed to solve a lot of problems. So I think that,
Does everybody have
and
negative
like I
pressure?
said,
Negative pressure privilege? Everybody has got the negative pressure areas in their A&E or ER and ICU as well. Proper negative pressure in the sense there's anti-room and proper negative pressure is being, yeah.
So we
So
have
that
10 beds, 10 such beds in ER.
Yeah, I've seen your department. Yeah.
yeah. So negative pressure would be one thing. Second thing would be a bit more, I was always interested in it, but now a bit more interest in entry and exit and corridors to have this in mind a bit more. Um, Other would be also access control. So I think Dr. Mehta just touched upon. So, relatives coming in constantly asking about, uh, relatives asking about the COVID ICU patients. So some sort of access control area within the emergency as well, which we were able to do. Obviously, we can't do that for the resuscitation area, but the remaining areas can be done. And rather than just that, we uh, again, Dr. Mehta used the words customer. So within the emergency department, having a team that can cater to all these. So I had one of my managers trained into that. So I used to direct all these, if you call non-clinical but urgent inquiries or everything that you need to have someone clearly defined in your team who can handle all those things. So those will be a initial few thoughts that I can think of for a new, if I had all the money in the world. Yeah.
You
you were
have.
fortunate that you had a ED in two sections, one 8-bedded and one 12-bedded, and that proved as a boon now. Yeah.
Oh, it's an absolute boon.
Yeah. So our ED is a single ED, and so we had a great problem segregating COVID area from the non-COVID areas. And whatever we try, there is some mixing up. You cannot have totally compartmentalized COVID and a non-COVID, because some of the stuff will be common and they will keep on moving from here to there. At least now, earlier we tried to keep a lot of barriers, but now I think things are a little relaxed now.
Yeah. I mean, that's played a huge role in us at Apollo. We've had only about 7 to 8 staff who came positive out of the entire 50, 60 year staff. So I think that having two separate areas probably played a huge role in that, and the negative pressure, I think.
Great.
At the peak of the COVID, I mean, most of the cities like Mumbai, Pune have bed shortages. So did you have the bed shortage problem in your ED, and how did you deal with that? Because it was like a situation where patients were going from one hospital to another, you trying to call up another hospital, the beds are not available, trying to stabilize the patient in your own ED, sometimes even getting the patients intubated and shifting the patients to other hospitals. So these kind of challenges you must have faced. So what did you do when during the bed shortage? Was there any algorithm?
So like Shweta, initially for the first 2 months, we were also non-COVID because NMMC decided to keep all the COVID in certain centers. So we had the same situation. So the 6-bedded area, luckily there were two oxygen ports and 2 suction ports and 2 air ports in each bay. So we doubled that up. So we could have stretchers in there whenever required. Then one room was like a separate cubicle. So in that, what I did, I had extra oxygen cylinders, and I had the so-called stable patients on nasal oxygen could be accommodated there. So at times there were 3 or 4 patients sitting there on oxygen, not on a stretcher. So that is how we increased the capacity as much as we could. Just by memory, in June last year, we received around 1,800 requests for beds, which we could not cater to. So these were phone calls coming on our emergency number, and they were all answered by us, as in the doctors, because we had to triage them whether they need ward or ICU beds. So those were the amount of numbers we couldn't accommodate. So it was a really difficult time. The team was very depressed because they were constantly just answering the phone and saying, sorry, no beds, sorry, no beds. So, it was horrible. But yeah, it
so when
was
you're
like
doing this
anywhere else.
triaging,
We were
sorry
not
to
able
interrupt,
to.
Nitin. Sorry to interrupt. When
No
you're doing
worries.
this triaging on telephone, did you also consider home isolation?
Not in that phase, because that time home isolation wasn't an option. We were isolating all patients in hospitals, so no. But what we did was we would triage them lower down the list. So when we maintained our waiting list, we had an ICU waiting list and a ward waiting list. So people who we felt were completely stable, did not need oxygen, they were way down on the list. So they never got called to the hospital. So indirect home isolation.
Okay. Shweta, you want to talk about this bed shortage problems and how did you manage that?
Yeah, so what I mentioned as 10-bedded isolation unit for us actually started off with 2-bedded unit. So initially our plan was to keep it as 2 beds for patients
We
who
have
would
lost
be...
you. Yeah, in between we are losing you.
Okay, now is it okay? Can you hear me now? Okay, so our 10-bedded unit actually started off as a 2-bedded unit. So we had 2 cubicles, which we thought we will keep suspected patients who are unstable to be transferred. But over the period, as the number of COVID patients increased, we had to, pull in two more beds. We put one more area was designated. We put 2 more beds there, then another 2 more beds, and that is how we made it to a 10-bedded unit to cater to the patients who are unstable, who cannot be transported or transferred without stabilization. So that is why, and this 10-bedded unit actually helped us a lot to stabilize these patients, and also having a backup at Seven Hills for ward and ICU beds, we could be, at any point of time be able to transfer patients once they have stabilized from here to go over there. So this really helped us streamline our patient flow.
So Prasad, I don't know about Pune, but in Mumbai we had a very good system of this municipal war rooms. So each of the ward had a war room, and we had to mandatorily inform every patient who required admission to the war room. And then they would find out the appropriate bed depending upon the severity of disease, and then actually send ambulance and shift those patients. Although it could take a little more time, but I think it was overall an effective thing, and which was a very unique thing which was in Mumbai, and it helped us a lot. Because sometimes we would have up to 8 to 10 patients waiting in the ER to be shifted to other hospitals, because our hospital ICU and ward was full and there was no intake capacity. And these people would board the ER for about even up to 24 and 36 hours. And sometimes the one challenge which we faced is that in the night or sometime when we have a bed ready and we want to shift the patient, at that time the relatives are not there to do the admission, because all the relatives are quarantined and they have also a fear of being in the hospital, so they leave the patient and go home. And it is happening still today that patients are boarding in the ER, and after 7 or 8 p.m. if you look for some relative for doing the admission formality, they are not there. They say we'll come in the morning. So that thing is also a challenge, and limited the quick movement of patients.
Yeah, actually, it's very nice to hear that Mumbai had a good central coordination. We did have a central kind of bed display, or centrally beds were displayed, but this coordination I think was not good enough. So I think in our ER was very busy. We have attended more than like 12,000 patients in the Nath Mangeshkar. And also we equally had a very good fever OPD and home isolation protocols and guidance for home isolation, including some videos. And in the ER also, the ER was so full that we had to actually get some oxygen points, about 10 oxygen outlets in that waiting area, where we had to actually, patient comes in and we had to start the patient on oxygen. But we have faced a lot of challenge when it comes to bed management, where we as our commitment to the patients, we used to stabilize them, even to the extent of intubating them, providing them an ambulance also if the bed is not available with us. But then hunting the bed in another hospital was always a challenge for our ED staff as doctors, as well as the patient relatives. So that became a very big challenge for us.
In fact, when you use the word bed management, I remember that what we did is at Apollo, I got involved with the bed management. So I used to actually go up on the COVID floors, and just like, in emergency, like all of us, we improve the efficiency from registration to admission to discharge to everything. So those kind of efficiencies are not always available on the ward. So when this
Correct.
was happening and every bed was at such a premium, I joined the operations team, and we actually, along with the nursing supervisor, looked at all the processes. So much so that our management decided that they would process the discharges the previous evening. They asked
Correct.
the COVID care team to identify patients. So the discharge was initiated in the evening itself, and the patient is shifted out in the morning. That would help with some of the challenges of the relatives coming. And so we could get the turnaround time from a discharge patient to a new patient much quicker, which is, something emergency does quite well. And we could help the hospital operations help so that we could have minimum wastage of that critical bed time.
Sir, if I may add here, sir, it's a pure demand supply. So, sir, when we started in March, we had about 50 beds on the ground floor, and we had 40 O2 points in COVID. We anticipated the surge, and hence every day number of O2 beds. Right now, we are having 500 beds in COVID with our O2 beds, peak occupancy of 300 O2 beds. It had to be a triage system every day. Patients who are not on more than 10 liters, they don't even enter the ground floor. Now the criteria as of last week is people who are on less than 10 liters are on the second floor, HFNOs on the first floor, only NIV and invasive on the ground floor. So the anticipation and the surge capacity preparedness has to be there. And sir, you need a good administration and management support. What we had was clear instructions. Any patient who comes to our hospital cannot be turned away. The fact that he's landed up here, that means he has nowhere else to go. So there was no option for us. We had to make the bed. There was no option. We could send the patient anywhere else because we've had patients coming from Andheri, Kalyan, Dombivli, because they have hit every hospital on the way and they have finally ended up in Raigad, and there's nowhere for us to send them to. So we have our like with our backs against the wall that there is nowhere else. Jo karna hai, yahi karna hai. Get a cylinder, get a bed, move some patient around. We had got O2 splitters, various points. So
Yes.
So that is like you have to be prepared for the worst. You should not in this time just have that plan B in place. And even now we are adding 100 more O2 beds on another floor, centralized O2, just in case things go downhill again.
I think next time if I want a bed, I'll send patient to your hospital.
Sir, we have instructions not to refuse anyone.
Yes, I take that.
Definitely
So-
not Dr. Mehta. Huh?
So one thing I wanted to ask at all these, we have people from different centers. So has anybody faced any staff attrition because of the COVID, fear of COVID or, whatever?
Not in my hospital.
Good.
No attrition at all, Shweta?
No. Nobody has
Non-clinical,
left because of the
that
fear
is-
of
We-
COVID.
We've had the
non-clinical,
attrition-
clinical.
Yeah.
Sir, I had few of my nurses leave after the first wave.
Add on this that with this isolation facility with us and our protocols being so rigid, we ended up keeping patients who are very sick for a long period of times in the emergency department till we have had the complete COVID clearance. So patients used to be with us in the ER for 24, 48 hours. Dialysis happens in ER, ventilation happens in ER. So almost all ICU care happens in ER for these suspected patients for up to 24 to 48 hours. So this has actually been, a positive thing for the ER residents to get into, the management, the taste of ICU management, and a really, really good learning experience for all of us.
Great. So any other experience or anybody would like to share anything regarding this challenge of managing COVID and managing teams as a dual challenge? Any other comment by anybody?
I had one challenge which continues even now. is the consultants of various specialties not ready to accept the protocols or what the guidelines about suspect cases, waiting for reports, and the use of an additional HRCT or something like that. So that still debate goes on. Consultant sends a patient, this is the primary disease and this is why they're getting admitted, and then you're trying to tell them, no, look, these are the features where we need to still consider COVID. So that challenge is a lot less now compared to last year, because we had these patients with chronic diseases, whether it's cardiac, nephro, other stuff that the consultant just wanted to admit, and we had to say, no, hold on, we have to check COVID. And if they come positive, they have to go in a COVID area. And they would try and resist that, and they try and tell off that don't do this test, don't do that test. So that challenge is a lot less, but it is still there. But luckily, I think this has helped emergency medicine, I think, in a huge way. The management should have realized that we really know what we're doing when we're triaging, when we're selecting, when we're setting up protocols. So it's brought a lot of recognition, I would have thought, in most hospitals. So yeah, but that challenge is there, talking to consultants and telling them what they need to do.
So we also faced this that the consultants wanted to admit patient and they didn't want an additional filter of COVID screening. But as soon as we have the second wave, they all stopped interfering. So they say that no, take your own call, follow your protocol, because they felt that if some patient lands up in the ward and they go and see the patient and if they come positive, so then they really got a taste of it, and then they actually gave up.
No, actually, in the critical care, I think another problem which critical care physicians must have faced is managing of the death and further proceedings, rituals, and rites, how they are being conducted, packaging of the body, transporting of the body, handing it over to the corporation, relatives not being able to attend the funerals, and so many other challenges were there. So maybe, and also if anybody had any oxygen shortage, you can throw some light on that. Charu Datta and Sagar.
Yeah, I mean, that was a very great point about this death declaration and the process of dying, post dying, the formalities. I mean, I'm now working in critical care for such a long time, but this 1 year it has been extremely challenging in terms of this telephonic communications, especially for the patients who are critical and who we know that are not going to make it. Trying to be with the family in that moment, and daily trying to get them to an acceptance. It is challenging in face-to-face communication, and I mean, you can imagine how difficult it can be on a telephonic basis. But I thought that was extremely, kind of stressful to an extent to deal with that particular situation. But we've been through it. Try to talk to the families. In that particular instances, maybe multiple communication from our end, and the video, facilitation, conference calls with multiple people at the same time to make sure that the family is well supported, but from our end as well as from their end, and then trying to get them to an acceptance before the actual death happens. It was very important and very, very challenging. And after that, the process of post dying, we had a protocol in place, so that was not that difficult. But the process where the person is dying and we have to break the news and trying to get the family to come to an acceptance was very, very challenging.
Yeah, I think the COVID itself isolated individuals, human beings, and it was for the patient. If I look from the patient perspective, feeling very lonely, surrounded by the worsening, and then relatives. Not, it is very, very difficult, right, even for the patients, I'm sure. And all of us must have had some family member, some close friend who has gone through this. In my own family, I had 3 COVID deaths. And I've closely seen what it means to be a relative of a COVID patient. Yeah. Sagar, anything in your setup?
Yes, sir. Sir, we've had a lot of deaths, and it was very difficult for the residents. My boys and girls have been in the EM ICU for quite some time, but staggering number of deaths. And we had to keep talking to them. I was more worried for the team and the nurses. I've had nurses cry. Just the helplessness, the sheer situation sometimes, especially now in the second wave, we've had so many youngsters who have passed away. So it was very difficult for the team. And we do a few group counseling sessions. We try to keep a light environment once we're outside the ICU. We even got, with the psychiatry department has been very supportive, this mental health programs, mental awareness. And with the families, the last session, my resident's biggest regret was that, sir, we aren't able to give the families closure. So she was more upset about that. So they also go through a lot, and the body's packed given to the corporation. So a lot of emotions there, and the closure is not there for many of them. So I think, sir, that's something probably this generation is going to be scarred. I mean, nobody would want to admit it, but I think this generation is going to be scarred for years to come. And I hope everybody gets the help they need, not need professional help with medication, but some help.
Yes, you're right, because this mental support was very essential. We had started a helpline called as Manobal, where people can come out with their stress, anxiety, any experience which they want to come out with, so that they will feel little better or little lighter, maybe. Yeah. Sanjay, anything else?
No, I think we are closing in on our time, and I would like to thank all the panelists and Prasad for contributing to the discussion and sharing the experiences. And I would thank Sandeep Gore that in spite of all this year-long exercise and the fatigue now setting in, he still has the energy to organize such a mammoth.
We lost your voice. Yeah.
He still can organize such a big, involving so many people. And I think it's a great task and great energy. I think he didn't go to Himalaya, so he's saving some energy for this activity.
He's going next month.
He will not get a flight.
Thank you, sir.
Sandeep will not get a flight.
वो खुद उड़ के जाएगा.
Okay, thank you, everybody.
Yeah,
okay,
thank you.
Yeah,
Thank you.
Thank you, everyone. It was a very wonderful discussions. Now I will proceed to our next session, and our next speaker is Dr. Kedar Toraskar. Kedar Toraskar, sir, is the Director of Critical Care at Okad Hospital. But I would like to tell that he is the first President of Society for Emergency Medicine Maharashtra chapter. And he always contributed in Maharashtra chapter for academic growth. Recently, we have done a couple of programs at point of care testing in emergency medicine and critical care. And he has been a lead instructor for this program. Actually, the first thing we are going to do after this particular pandemic ends is that our pending program, and our students also continuously ask me that when that program is going to come. And he is a very renowned figure in critical care, emergency medicine, as well as point of care sonography. So Kedar Toraskar sir is today's speaker and the moderator for this talk. His topic is point of care sonography, the third eye. And moderator for this talk is Dr. Rajat Bhargav, who is a HOD radiology of our hospital, but I say that he is very much part of our department. He is actual third eye for us. Means Very few people from radiology I can see that they have clinical application in their diagnosis, and he is a big help and big hand for us in COVID, non-COVID, for everything. I can see he is a third eye for us for emergency department of Fortis Hospital. And I'm handing over the further section to Rajat Bhargav sir and Dr. Kedar Toraskar sir.
Hello.
Yes, sir. Screen is visible.
Yeah. Okay. So can I proceed?
Yes, sir.
Yeah,
Please
can you hear me?
You can proceed. Yeah.
Fine. Yeah, and you can see my slides, right?
Yes.
Yes, we can see your slide.
Yeah. Okay. Fine. Thanks, Sandeep, and really hats off to you, as Sanjay said, that to arrange such a webinar in midst of this pandemic. It's meaning hats off to your dedication there. And thanks for inviting me for this conference. So in the next 30-35 minutes, I'll be just talking on point of care ultrasound, as you have coined this term third eye in COVID pandemic. So I'll begin with certain basics of lung ultrasound, and then in the later part of the presentation, I will go to the COVID-19 focus protocol. So lungs are a major hindrance for the use of ultrasound at thoracic level, and obviously this was quoted by Harrison Principles of Medicine in 1992, and this was simply wrong. All of us know that. So this man, Daniel Lichtenstein, which I cannot not quote in any of my lectures, is the father of ultrasound in intensive care, and all of us who do focus in critical care have been influenced by this iconic figure. So he's a live wire when you meet him, and he's a bundle of energy, and he's dedicated to point of care ultrasound. He has this book, which is the Bible, Whole Body Ultrasound in Critical Care, which I would say all of you should read at least once. So what are the limitations of chest X-ray? Difficult to ensure breath holding, reduced spatial resolution, incorrect assessment of pleural effusions, consolidation, and alveolar interstitial syndrome. So if you see the COVID era now, these X-rays are very common. So every second patient in the ICU, you will see this X-ray. So you don't know whether it is a cardiogenic pulmonary edema, whether it is COVID-19 pneumonia. So unless proven otherwise, obviously it's COVID-19 pneumonia, ARDS. And of course, it may be cardiogenic also, because some of the subset of patients have a cardiomyopathy, or they have a COVID ACS, and they may have cardiogenic edema also. And of course, you don't know how much effusion this patient is having, and what is the etiology, or whether there is any underlying consolidation, infective consolidation, or secondary infection there. So that becomes a big dilemma. So limitations of chest X-ray are the sensitivity in detecting pneumothorax is 53%, especially in the ICU patients, critically ill patients who are lying down and in whom you do the portable X-rays. Now, this slide shows you the sensitivity and specificity of point of care ultrasound, lung ultrasound versus CT as a gold standard. Right side is the CT as a gold standard. So obviously pleural effusion ultrasound is more sensitive and specific for pleural effusion. It's 97% to 94% for CT. Alveolar consolidation, obviously CT has an edge, but it's not bad for ultrasound, 90 to 98%. Alveolar interstitial syndrome is great, meaning 100% in ultrasound, and that is what we call as a comet tail artifact. Okay. Complete pneumothorax is more sensitive and specific by pickup by the ultrasound, 100% versus 91% for the CT. Occult pneumothorax, of course, it dips down to around 78 to 80% in ultrasound, whereas it's 100% for the CT. So this is backed by publications in the best of the international journals. So there's no doubt about the utility of ultrasound in critical care and in management, whether it is ED, whether it is critical care, whether it is the OR or the ward. So this slide is showing you the earth and the sky interface, and this is exactly what lung ultrasound is about. So it's a mix of air to fluid ratio. So whenever it is a pure pneumothorax, it's all 100% air. Normal lung, it's 99% air. As the fluid part goes on increasing, obviously the air part goes on reducing. So interstitial syndrome, when you have early interstitial edema, it's around 97%. When it is when the interstitial edema goes on increasing and it goes to ground glass and the fluid part increases. Of course, pneumonia, there's only 10% air and more of fluid because it is a consolidation. And of course, atelectasis, airless lung, pleural effusions, it's all 100% fluid and no air. So this is what we call as air fluid interface. And this is one of the schematic diagrams which shows again the same thing, that air in pneumothorax, it's completely air. So the ratio of air and fluid is 1 here. In a normal lung, it's 0.9. In early alveolar interstitial syndrome, it's 0.95. And when it is pure pleural effusion, it's all fluid and no air. So what are the 7 principles of lung ultrasound? This is very important before we go ahead. A simple 2D apparatus is most important. It is most appropriate. You don't require fancy ultrasound machines, or you don't require high-end machines for point of care ultrasound. Thorax is an area where air and water are associated. So it's a mix of air and water, as I said. Lung is the largest organ in the body if you go by per square meter area, a cross-sectional area. All signs arise from the pleural line. This is very, very important. So all the lung ultrasound signs arise from the pleural line. And that's why it's important to demarcate that pleural line and pleural sliding. Lung signs are mainly based on analysis of artifacts. So it is all artifactual ultrasound. There are very few true images in lung ultrasound. And of course, lung is a vital organ and most of the signs are dynamic. And the most dynamic sign is the lung sliding in lung ultrasound. And of course, in COVID era, lung is the most primarily important organ which is involved. And last but not the least, nearly all the acute disorders of the thorax come in contact with the surface. So that's important. And this is the analogy, the bat sonar is the analogy which Dr. Daniel Lichtenstein coined. That is important. So you can see the bat sonar, the waves which are returning back. Okay, that's the principle of lung ultrasound. And this is what you see. So you don't know which is the artifactual image and which is the true image. So you have to go rely on the artifactual images. And importantly, lung ultrasound is about knowing the artifacts and how do you interpret those artifacts. So it's very challenging initially, but once you get the hang of it, lung ultrasound is very easy and fluidic to learn. So this is what I call about, meaning you need unedited images. So you have these artifactual images, they have to be unedited. Okay, you don't want any filters. So this is Rajnikant in the true sense. So we want the true Rajnikant or Thalaiva. We don't want the Rajnikant on the screen. So no filters, okay, no multi-beam technology, you have to put it off, no image enhancers in artifactual lung ultrasound. Now, these are the 10 basic signs of lung ultrasound. The bat sign, that is an important sign to know where your rib acoustic artifacts are. And that is important because your pleural line will be the hyperechoic line which moves with respiration and has inherent sliding capacity just below that bat sign. Then comes the A line. A lines are nothing but these are horizontal artifactual lines, hyperechoic lines, which are seen because of the reverberation artifact. And if you have sliding present with A line, that means it's a normally aerated lung in that field. Now, of course, third sign is the lung sliding. And the lung sliding is very important because if you have to identify the lung sliding. If there is absence of sliding, that means the viscoelastic properties of the pleural fluid are lost. It may be a pathological lung like in a pneumothorax, or it may be underlying consolidation, or it may be underlying bulla. So absence of lung sliding is very important, or rather presence of lung sliding and showing lung sliding is present is important. Then you have the chord sign for pleural effusions. Okay. Then you have the sinusoidal sign. So whenever you put the lung ultrasound on the M mode, you get a sinusoidal sign. Then in consolidation, you have tissue-like sign and the shred sign. So these are two signs of consolidation. Okay. Then you have the B lines and lung rockets, which are classical seen in alveolar interstitial syndrome. And COVID lung or COVID pneumonia is everything about different B lines. So we are seeing different types of B lines. Okay, new nomenclatures of B lines in COVID. And of course, last but not the least is the pneumothorax. So you have the stratosphere sign on the M mode, which you see on a pneumothorax, and the diagnostic or the confirmatory sign is the lung point for pneumothorax. So the mastery of these signs allows you to control multiple settings, and you can diagnose ARDS, or you can manage hemodynamic therapy, so on and so forth. So these are the portable machines which we use. But as I said, a basic 2D ultrasound apparatus is good enough. Now these are the A lines. Now A lines are nothing but repetition of the pleural lines. So you can see these horizontal lines here. Okay, those are A lines. Okay, and they are because of air blocking the ultrasound beam. So air in the lung blocks the ultrasound beam. And what you see here are these repetitions of hyperechoic horizontal lines, which are called as A lines. Now this is the bat. So this is one rib acoustic shadow. This is another rib. That these are the acoustic shadows of the rib. Okay, and the pearly white line which is below here, below the bat wing, okay, or the bat sign, is called as a pleural line. And this line slides with respiration because and it has an inherent capacity to move because of the viscoelastic properties of the pleura. So that is called as lung sliding. And this, okay, from the pleural line to the A line, this distance is equidistant. So from the skin surface to the pleural line, and from the pleural line to the next A line, this is equidistant. So this is because of reverberation artifacts. And in between, whatever parallel lines you see in between those two A lines are called as A dash or A prime lines. So which are again reverberation artifacts. So let's come to B lines, and this is important to know in COVID lung. So B lines are nothing but vertical lines. Okay, they are also called as comet tail artifacts. They arise from the pleural line. They are well defined and laser like. They are hyperechoic. They are long and do not fade. They go all the way down to the field. They erase the A lines, so A lines are not seen when you get B lines, and they move with lung sliding. So these are the 7 features of B lines which are distinct from the other comet tail artifacts. And B lines, basically, you get B lines because of alveolar interstitial syndrome. So fluid in the alveolar the sacs or fluid in the septae. Okay, so if you have interstitial fluid, you will see B lines. So B lines are nothing but alveolar interstitial syndrome. There are other comet tail lines also, which are called as Z lines, and there are many other vertical lines which are seen like E lines, but they are different from the B lines. So to define a B line, you have to have these 7 features. Now, what are the differential diagnosis of B lines? So you can get B lines in all these conditions. So you have to have a basic clinical knowledge of what your patient is having. So the history is important, your clinical background is very important, and of course your examination findings are also important. So you can have B lines in acute cardiogenic edema. So the clinical setting will be acute here. In chronic heart failure, it will be chronic. In ALI or ARDS, like we see in COVID ARDS, it will be again acute. And in interstitial lung disease, again, you will get B lines, but they will be chronic. Now, the number of B lines depends on the severity of the illness and acuity of the illness. So obviously, in acute cardiogenic pulmonary edema, it will be bilateral and symmetrical. Then in chronic heart failure, they may vary. Okay. In ALI, ARDS, again, they may vary. Pulmonary fibrosis, they may not be great, but depending on the severity of the illness, again, they may vary. Now, B lines are multiple, diffuse and symmetrical in acute cardiogenic edema. They are non-homogeneous in distribution, and there are presence of spared areas in ALI or ARDS. And in pulmonary fibrosis, they are most frequently at the basis, lung basis, or posteriorly, lower lobes. Other findings in acute cardiogenic edema is pleural effusion. Now, in COVID lung, you hardly have pleural effusion. So, working for almost 1 year, 3 months now, we have not seen pleural effusions directly to COVID. So, if you see in a COVID pneumonia, if you see effusion related to a non-COVID cause, okay, it won't be because of COVID. Of course, it may be because of a cardiomyopathy secondary to COVID. If you have a Takotsubo secondary to COVID and you get failure-like symptoms and you have cardiogenic edema because of that, you will get pleural effusion there. So, pleural effusion has a good negative predictive value to rule out COVID lung. Now, echo is also important. That's why not lung ultrasound alone, but lung, cardiac, and IVC ultrasound. That's what we say. So here, obviously, in cardiogenic edema, the echo will be abnormal. In chronic heart failure, the echo will be abnormal. In ALI, it's likely to be normal, but you may get acute cor pulmonale in around 15 to 20% of the patients. Okay, And of course, in COVID, you may see involvement of the heart also. Like you have COVID ACS, you have cardiomyopathy, or you have COVID associated viral myocarditis, you may get involvement of the heart also. And of course, in pulmonary fibrosis, the heart may be normal. You may have a cor pulmonale or secondary pulmonary hypertension. So these are some clinical applications of lung ultrasound. You name it and you have it. So you obviously avoid referral to the CT. I'll come to this when I discuss the COVID part. You limit the bedside radiographies. Obviously, it decreases the dose of radiation. So those centers which use ultrasound, whether it is ED or the ICU, the rate of doing radiographs and CT is much less. And that we have seen in COVID era also. We are hardly doing CTs. We are doing CTs whenever it is absolutely indicated. Of course, it helps to do a lot of procedures, whether it is bedside tapping or diagnosing and putting in the ICD in a pneumothorax, or whether it is putting lines in the ICU, so on and so forth. So it helps in guiding several procedures in the ICU and making them safer. Okay, of course, diagnosing pulmonary edema, cardiogenic versus non-cardiogenic, diagnosing pulmonary embolisms in trauma, cardiac arrest, acute dyspnea, you name it, you get an application of lung ultrasound. So lung ultrasound has application in almost most of the pathologies which we deal with in emergency department and critical care. Now, what is a stepwise protocol? So how do we go about interpreting lung ultrasound in a stepwise manner? First and foremost is delineate which zone or blue point is scanned. So the Americans have numbered it as zones. So 1, 2 is anteriorly, 2, 3 is in the axilla, 4, 5 is posteriorly. So these are the zones on each lung. Whereas we follow Lichtenstein's protocol, which is the blue point protocol. So we have the upper blue point, the lower blue point, we have the phrenic point, we have the flaps. And in COVID era, we are using also the prone blue point. So whenever we are proning the patients, okay, whether it is awake proning or whether it is patients who are ventilated who are prone, we are using the prone blue points also for scanning. So this is one more area where we are using the prone blue points to a maximum effect. Now, the first and foremost thing is identify the bat signs. So you have to identify the rib and the costal sector, because it is important to know where the pleural line will be. So obviously the pleural line is just below the bat side. The skin and soft tissue sector is important because you may see E lines. E lines are nothing but, again, vertical lines like B lines, okay, which are seen in the skin and subcutaneous tissue because of subcutaneous air. Or you can sometimes see E lines whenever you have a pacemaker or a foreign body in trauma. Okay, so you can see these E lines also, but they are above the bat sign. So how do you differentiate between them from the B lines? The E lines are above the bat side or above the rib, which we delineate. Now, E lines are also seen. A lot of patients, we get subcutaneous emphysema in COVID-19 patients, and we have almost seen a lot of pneumothoraxis and pneumomediastinum because of the disease process, and of course because of ventilation also. So E lines are not uncommon, and that's a hindrance for doing the lung ultrasound. So that's one of the limitations for lung ultrasound. Of course, the pleural line has to be identified, and you have to. The next question will be whether sliding is present or absent. That's very, very important. Then the next question will be whether the pleural line is regular or irregular. So in COVID-19 pneumonia, you see an irregular pleural line or thickening of the pleura. So that is a hallmark. And whenever you have a pleural line which is irregular or thickened, that is called, and you have B lines present, that is called as a B prime or B dash protocol or B dash profile, not protocol. So the next step will be the subpleural sector. So the subpleural sector, you see the various lines. So you can see the A lines, B lines, C lines, or a AB pattern. So whenever you have sliding present with A lines, that means it's a normally irritated lung at that sector. Then if you have B lines with a regular pleural sliding, it is a B profile, which is classically seen in cardiogenic edema. Or like we see in COVID pneumonia, you have irregular pleural line, but the sliding is present and you have B line. So that is called as a B prime or a B dash profile. So in COVID pneumonia, we see a B dash profile or a B prime profile very, very commonly. That's the most common profile which we are seeing in these patients. And of course, when you have consolidation, you have C line. So in COVID, again, it's a subpleural disease and it's basically a posterior-basal disease. So you see a lot of C lines there. These are curvilinear lines which dip down. Okay, so they are called as C lines or subpleural consolidation. So they are also very, very common. This is normally reported on the CT, but that is also nicely picked up on the ultrasound. And of course, you have the AB pattern in which you have a variety of a normally aerated lung and B profile. So the next step is to identify which profile, whether it is A profile or a prime profile or a B profile or a B prime profile or a C profile or a B pattern. And last but not the least is screen the heart and the IVC. So just not lung ultrasound, we are moving to a whole body ultrasound protocol, whichever pathology we have to pick up. So it's a LCI or a lung cardiac IVC ultrasound. And of course, fit it into a clinical syndrome. Now for that, obviously the history is the most important thing, your clinical examination. So always remember that ultrasound is not a substitute for your basic history and examination. Now, of course, you have to change the therapy as per the input of your ultrasound aided diagnosis. Otherwise, ultrasound, just doing the ultrasound and then not acting on it is not useful. So this goes for any tool like Swan-Ganz, which was brought into disrepute because people didn't analyze what were the findings from the Swan-Ganz catheter and they did not change the treatment. Now, of course, use the clinical history findings, biomarkers, and other diagnostic tools for the same. Same goes for COVID pneumonia. So you have to address it holistically. Use the ultrasound to guide procedures to make them more safe and successful, which I just told you. Now, this is a protocol called as Blue Protocol. Everybody knows this, but again, I'll go into a slight more detail here. It's called as bedside lung ultrasound in emergency. So the first question you ask, as I said, is whether lung sliding is present or absent. If the lung sliding is present and you have B lines, that's called as a B profile. And if the pleura is regular, so it is pulmonary edema. Now, if you have a B prime profile or a B dash profile in which the pleural line is irregular, sliding is present, is abolished here. Okay, it is pneumonia. Now, it can be COVID pneumonia. It can be anything else. Okay, it can be a viral pneumonia. It can be a bacterial pneumonia. It can be anything else. Okay, any etiology. Okay. So if you have lung sliding which is present and a profile, that is A lines, okay, then you do a venous analysis. You check the pipes, you check the deep veins. Okay, you do a 2-cus, that is a 2-point compression ultrasound. If you see thrombosed vein, obviously it's DVT, which is very not uncommon in our COVID-19 patients because it involves the endothelium and we are seeing a lot of thrombogenicity in COVID. Okay, it's a prothrombotic state. If the venous analysis shows that the veins are free, go to the flaps, that is the posterolateral alveolo-pleural syndrome, that is the flaps area. So if the flaps area is showing shred sign, okay, or tissue-like sign, it's pneumonia. If the flaps is free, it can be just an airway disease, it can be COPD asthma in which the parenchyma is normal. Then coming here, if the lung sliding is abolished and you have A lines, obviously you look for a lung point. Okay, lung point is the interface of a normally aerated lung and a collapsed lung. Okay, so then if you find that if the lung point is present, it is a 100% confirmatory point for pneumothorax. But if you have just abolished sliding at A lines without a lung point, then you may have to do other imaging like a CT scan for diagnosing a pneumonia, for diagnosing a pneumothorax. Sorry. But if you have a clinical scenario, you can always go ahead with the ICD or whatever, or the therapeutic procedure. And here, if the lung sliding is present or absent, and if you have a C profile, which is a consolidation profile, it's a pneumonia, obviously. Of course, etiology depends on what organism you have. So this is in short about the Blue Protocol, a robust protocol, which is based on the lung ultrasound findings along with the deep vein analysis. And of course, in some patients, you have to use the cardiac ultrasound or the echo. Now, this is what all of us have been doing in the last 1 year, 3 months or so, and hats off to everyone. Okay, all the fields, whether it is emergency department, critical care, or internal medicine, hats off to all the COVID warriors. And so, why ultrasound again here in COVID-19? So, the next part of my talk starts now. So, it's easy to learn, non-invasive, rapid, and repeatable. So, even if you pick it up right now, you can pick it up within a month or so. It is easier and faster than X-ray chest. It's point of care. So we have one machine stationed in our COVID ICU itself and one machine in the COVID ward. So we have 2 machines right now for the dedicated to the COVID section. Detection of pleural fluid as little as 100 ml, more sensitive and specific for pneumothorax and pulmonary edema. So it's obviously a visual stethoscope, and the real value of visual stethoscope comes in the COVID time when it is impossible to auscultate with the PPEs on. So most of the PPEs have hoods, but now we are just doing off with the hood. So it is impossible to auscultate when you are donned completely. So that's why ultrasound is more important here. And COVID pneumonia is essentially an interstitial pneumonia with a patchy, inhomogeneous subpleural involvement of the lung. So the commonest finding which we see in the lung is a B prime profile or B lines with a thickened irregular pleura, which is predominantly posterior basal. Okay. Now, COVID has a multi-system involvement. That's very, very important. COVID is not a single organ involvement as H1N1. That's why it's a different virus, okay, and causing so much of havoc, including major organs like the heart, liver, kidney, brain, and microthrombosis. So if you see the ACE2 receptors are in the endothelium, and endothelium is all across, whether they are deep veins or whether they are arteries, arterioles, and any organ. Okay, and it produces a DIC-like picture. What we call as the actual term is a COVID coagulopathy, and that can be missed if you don't screen the pipes. So what is the advantage? Again, bedside, no risk involved in transportation as in the CT scan. It is cost effective. Okay, each scan HRCT costs 3,000 rupees or maybe sometimes more. It is portable, no radiation hazard, can be used safely in pregnant female. Now we are getting a lot of pregnant females who are affected in the second wave also, and you can't do a HRCT there. So so lung ultrasound and a COVID-19 protocol really helps here. So why not CT and why focus? So additional risk of transportation, as I said, for the staff, the transportation staff, the other healthcare workers, it is more cumbersome to disinfect the scanner as compared to the portable ultrasound machine. The disinfection of the ultrasound machine doesn't take more than 7 minutes or 5 minutes. COVID-19 patients show dynamic symptoms and which progress and require repeated imaging. You can't have, COVID is not a static ball game. It is a very dynamic ball game. And we are seeing patients who deteriorate within 2 days or 24 hours also. And it's not possible to repeat the scan every time because these patients are critically ill. Some of them are ventilated. Most of them are on NIVs. Most of them are in prone position. Okay. So you forget about moving down to the CT scan department. You can't move them to the other side of the ICU also or the ED also. It is significantly costly and poor availability in remote areas as well as cities. So all the nursing homes may not have a scanner, but of course all the nursing homes can have a portable ultrasound machine. Now it is as sensitive as the CT scan when clinical pictures suggest COVID-19. And the most important thing here is that a whole body ultrasound protocol, which involves screening of the heart, lung pipes, is mandatory for COVID. It aids for invasive procedures like line cannulations, ICD. It aids in confirmation of EP positioning, especially when 5-point auscultation is not possible. Now this is a modified blue protocol. Too much into it, so don't be awed by that. Now, what do we do in our COVID-19 protocol? So all the patients with moderate and severe symptoms are screened. Okay, those with used to score more than 5, these are screened. Okay, the step 1 is lung ultrasound with a modified blue protocol, which I just mentioned. Step 2 is cardiac ultrasound. We just do the screening of the heart, no fancy measurements, eyeballing technique. Step 3 is venous analysis. We do a 2-point compression ultrasound for the lower limbs for screening of DVTs. Okay, and we have found out certain findings which are very, very specific for COVID-19. We generally repeat this protocol 8 to 12 hours depending on the clinical condition of the patient. And the complete screening should be completed in less than 10 minutes. So a good experienced ultrasound user can complete it in almost 5 to 6 minutes. Now, we also correlated with the other inflammatory markers, whether it is D-dimer, NT-proBNP, TROP-I, CRP, procalcitonin, ferritin, and so on. So the correlation with the clinical condition and the other biomarkers is important. And most importantly, we have to make changes in the treatment as per the combined information from the focus with the biomarkers. So what are the specific findings which we get? We see a classical B prime protocol, which I said. So it is a thickened and irregular pleura. Sliding is present. It's a break in the pleural line. Okay, and you see multifocal inhomogeneous distributions at the base, quadrant 5 or 6, or in flaps or prone blue points, which I mentioned, because it's basically a posterior basal pathology. And of course, severity of COVID is as per the extent of the B line. So this, I won't go into details, but if it is a single B line, it's not significant. There are two B lines, they are again not significant. Now, 3 or more B lines between two rib spaces are significant, and if it is 7 millimeters apart, it is thickened interlobular septate. If it is 3 millimeter apart, it's intralobular edema. And Birule, this is a variant which we say it is coalescing of the B line. So Birule, there is no anechoic space between the B line, and it is what you see as a complete whiteout on the X-ray or severe pulmonary edema, whether it is cardiogenic or non-cardiogenic. Now you can see subpleural consolidations in COVID, predominantly posterior basal. That's one of the most common signs. Now shred sign and tissue-like sign are very, very uncommon in the initial phases, but you can get it when you have secondary lung infection. When you have VAP or tracheobronchitis, you can get shred or you can get a tissue-like sign. But to get a secondary bacterial infection upfront is very, very rare. Now absence of dynamic air bronchograms, which is suggestive of a non-bronchial spread. So it's basically an interstitial spread. And if you have dynamic air bronchograms, obviously it is secondary bacterial consolidation. Now they can progress from focal discrete B lines in the early stages to gross alveolar interstitial syndrome. What you see on the CT as RCT scan score has increased from 6 to 16, okay, or 16 to 22, from moderate disease to severe disease or mild disease to moderate disease. And it's very, very sensitive to pick up pneumothorax, which can be a rare complication of COVID-19 or complication of mechanical ventilation at the bedside, okay? Because getting an X-ray in COVID era becomes very, very difficult, and the ultrasound is at the bedside. So we have put in ICDs for so many patients who have worsened because of pneumothorax just on ultrasound findings. So pleural effusions are not seen. If you see pleural effusions, that means you have to look for other causes, or it may be a complication of a COVID cardiomyopathy or myocarditis or acute coronary syndrome. So think of an alternative diagnosis or associated coexisting cardiac failure. Now it also helps in resolution. So whenever the patient improves, you get appearance of A lines, okay, in place of the B profile. So the B profile slowly goes into A profile, and it also correlates with the clinical improvement. So ultrasound heart, we just do the eyeballing technique. It's bimodal questions. Okay, whether contractility is normal, abnormal, whether they are regional wall abnormalities or generalized hypokinesia. So the most common finding is very, very mild pericardial effusion, and if it is present, it's very mild. Okay, and then the next question to ask is that whether there is a presence of severe effusion. If it is severe, whether it is a tamponade physiology. But in most of the COVID patients, you have not got severe pericardial effusions till date now. So we have not seen cardiac tamponade or severe pericardial. The maximum, the commonest finding is very mild pericardial effusion. This is again secondary to the viremia. Now, gross valvular pathologies also are uncommon in COVID. You see viral myocarditis, yes, not a great amount, but yes. You see Takotsubo, we have seen a handful of Takotsubo. You see COVID ACS, yes, that is very common, not uncommon. And you see mild non-specific pericardial effusions, as I said. Now, venous analysis, very important. IVC is small with more than 50% collapsibility. So most of these patients are hypovolemic when they come in. And in the deep veins, we don't see many deep vein thrombosis. We see deep vein thrombosis in our subset, which are around 4 to 5% of deep vein thrombosis. But we see smoky echoes in the common femoral veins, and that is akin to what we call as sticky blood, and that's the precursor of thrombosis. So if you pick them up at smoky echoes or spontaneous echo contrast in common femoral veins, that is the right time to start them on therapeutic anticoagulation. And we use the 2-point compression ultrasound insonating the femoral vein at the inguinal ligament and the popliteal vein at the popliteal foot. So other utilities, lung recruitment, okay, guides response to proning, management during ECMO, putting in the ECMO catheters, and focus-driven weaning protocols. Now, the patients can deteriorate because of a pneumothorax. They can be deteriorate because of massive embolism, secondary infection, and the last but not the least is worsening of the primary disease, which is a diagnosis of exclusion. So there are limitations. Acute emphysema, E-lines may not give us a good window. It may not be freely available because of the PCT, NDT, and the ultrasound machines may not be available everywhere. So this is what you see classically. These are the B lines, and you can see that this pleura is not a smooth pleura. The sliding is present. It is irregular pleura, and these are the vertical lines of the B lines. So this is called as a flashlight blue line, in which you have coalescing blue lines. Now these blue lines coalesce, and these flashpoint blue lines are secondary to the GGOs which you see on the CT scan. So these are nothing but the GGOs you see on the CT scan. So you can see that these are flashed line, coalescing blue lines. You can see that there is a break in the pleura. There is a subpleural consolidation here. So again, same thing. This is coalescing V lines, again called as a Birule pattern. So you can see, if you see the X-ray, there will be a whiteout X-ray here. One more example of a flashlight blue line. You can see subpleural consolidation. Can you see that break in the pleura and these hypoechoic areas here? Those are nothing but subpleural consolidation. And the sliding is present, but the pleura is irregular here. So this is again a Birule pattern, whiteout lung, coalescing V lines. Now this is important. If you can see here, this is the common femoral vein. It is completely collapsible, but you see smoky echoes there. So this is what we call as spontaneous echo contrast, and this finding is seen in almost 60 to 65% of moderate to severely ill COVID, and that warrants therapeutic anticoagulation. So that is another, the therapy is another part by itself. So this is what we are very commonly seeing. Now, this is obviously a Maconal sign, which we see RARV is dilated. This patient was thrombolized, okay, COVID-19 pneumonia policeman. This is a plethoric IVC in the same patient, non-collapsible IVC, plethoric pipeline IVC. This is a DVT which we saw in one of our patients, non-compressible common femoral vein, and you can see the hyperechoic clot there, thrombus there. Again, mild pleural effusion here. You can see anteriorly as well as posteriorly, most common finding in the heart. And of course, this is a Takotsubo cardiomyopathy, a 80-year-old Parsi gentleman who developed a cardiac failure, COVID positive, and it was a cardiogenic pulmonary edema. So just summarizing, Focus is one of the best imaging tools for managing critically ill patients. It's a whole body ultrasound approach. It's bedside, repeatable, fast, cost effective, no radiation hazard, no transportation hazard. Machine is easy to disinfect. It can be used in ED, ICU, wards, and the OPD. So just remember the Earth-Sky interface, and it's one of the best tools to be used in the COVID era. So with this, I complete my talk, and over to Dr. Bhargav.
Yeah, congratulations. I must congratulate Dr. Toraskar for this excellent talk of this rather demanding topic. And I'm sure not very many experts are there as able as your expertise that you have developed. And I must really congratulate you. And yes, I think COVID has brought ultrasound's role in focus, with all the limitations imposed by isolation protocols. I think this modality did need a boost up, which I think COVID has provided, and more and more emergency room physicians and critical care physicians should take this, because the beauty of this is speed and easy availability, meaning you get instantaneous information. Ultrasound can be a magic wand in the hands. Yeah, an excellent talk.
Thank you, sir.
There are no questions as I can see in the chat. So I think it's all clear, and people have understood the topic well. So Dr. Sandeep?
Yeah, thank you.
I think we can conclude this session now, and you can take this further.
Yeah. Thank you. Thank you, both of you. Yeah. Thank you. Thank you, both of you. And now I'm proceeding to our next talk, the oxygen and ventilator strategies in COVID, crucial deciders of the outcome. And for this particular talk, we have the esteemed speaker, Khusrao Bhajan sir. Khusrao Bhajan sir, I can say in one line, he is the person who brought ACLS, means he conducted the first ACLS program in India. And that is quite remarkable thing, that it's a landmark thing that I should share with you on this occasion, because ACLS is a part and parcel of emergency medicine. Here he has nurtured culture of emergency medicine in Maharashtra right from 2004, and he has been Vice President for Society for Emergency Medicine in India for 6 years, and he has always supportive and big support and for us. And he is also the academic chair of the Society for Emergency Medicine India in Maharashtra chapter. He has also great contribution in medicine also and critical care also. And I think if I talk about him, the entire time will not be sufficient to talk about him. And he has such a great credentials behind him. And our second the moderator for this particular talk is Dr. Pradeep Shah, sir. He is one of the senior most physicians in Mumbai. He's an astute clinician, and I can see very few physicians of his caliber in Mumbai. And he is faculty for medicine. He is lead faculty of internal medicine program happening in our hospital, and he is always a big support to emergency medicine in our hospital. So with this introduction, I hand over to Khusraw Bhajan sir and Pradeep Shah sir.
Thank you, Dr. Sandeep. It is a pleasure to be here. And today now we are coming to the most central theme of today's conclave. And this is the oxygenation strategies and ventilator strategies in a patient of COVID. As we all know, the COVID mortality in critical patient is very high. And we have to oxygenate patient with all the means which are available with us. Though we are in 14-15 months of this pandemic, still there are a lot of knowledge gaps. And I'm sure Dr. Khusraw Bhajan will enrich us with the strategies about mechanical ventilation in COVID patients. So I hand over to Dr. Khusraw.
Sir, kindly unmute yourself.
Yeah, you have to unmute.
Khusraw sir, you have to unmute yourself.
When I want to talk,
I think, sir, you have to unmute your.
Yes, can you hear me?
Now we can hear you, sir.
Yeah. So thank you, Dr. Shah, and thanks, Sandeep, for such an elaborate and expansile kind of introduction for me. I hope I deserve that. First and foremost, I would like to wish a happy birthday to all the emergency physicians of Maharashtra and India. And taking this forward, I'm very, very happy that the Maharashtra sector of the Indian SEMI is actually doing very well under the leadership of Shweta and Sandeep and the likes. So let me start off, because this is a very important topic and we need to understand right from the emergency room, or probably even from the home till discharge, and sometimes even after discharge, what are the critical deciders for outcome as regards oxygen and ventilation are important. Sorry, I just changed my laptop, so yeah. So let me start off with a quote here, which Michael Dooley said: "Disaster gave me two things, a moment to react and a decision to overcome." And the disaster and the menace of pandemic of COVID has definitely taught us not only to react, but to act and to endure and to overcome this demon that is COVID. We know that there are three main phases of COVID, and that is the viral phase, the pulmonary phase, and then the hyperinflammatory or the cytokine storm phase. And a patient may appear to us at any of these phases. And now in the second wave, we have realized that there are more and more younger patients who may quickly move from the viral phase into the pulmonary phase and actually deteriorate. And therefore, we need to understand the need for oxygen as well as the need for ventilatory strategies. And we can do the most favorite thing, which is the CT scan. And I'm glad that Dr. Kedar gave such an amazing lecture on POCUS, which actually can replace the CT scan. But we need the correct acumen, and not everyone in this country is as good as Kedar. I can vouch for that. And we all need to learn the POCUS as well. We should know that there is a CT severity scoring, which again may not correlate with your clinical background, but the GGOs, the more the consolidations, more the lung involvement, the reverse halo, etc., would probably mean that these patients, if not now, would have a very bad PF ratio and would deteriorate at any time. And therefore, what we have in our ER and ICU management is, as the patient may be stable till the patient becomes unstable, an entire gamut of respiratory therapy. And that would be starting them with a low flow nasal cannula, followed by a high flow nasal cannula or an NIV, leading then to an invasive mechanical ventilation, prone positioning, which I will also talk about. And if everything fails, then probably a VV ECMO. So let me go through all this in a little bit of detail. I won't be able to describe everything, but I will at least apprise you of the problems and the needs that we need to know of each technology. So I've just made a small mnemonic for the respiratory support, and that is on me. So O stands for oxygen, N stands for NIV and HFNO, M stands for the mechanical ventilation, E stands for ECMO, and at all times proning can be done. So proning in COVID is very similar to the triage we do in trauma care. So triage can be done on the field, triage can be done at the entrance of the ER, it can be done in the ICU, whether the patient goes to OT, etc. And similarly, the proning can be done right from home, the CARP protocol, till even the patient is on ECMO and ventilation. So let's talk about oxygen. First and foremost, the most important thing is that oxygen is not just a therapy, but it is a drug. And when we label it as a drug, we know that there are many complications that occur with any drug. There has to be a benefit and there has to be side effects. So we need to understand that the rational use of oxygen is important. What happened in the first wave, we all, even in the task force, we decided that the main drug that would help a patient would be oxygen, oxygen, and oxygen alone. But unfortunately, in the second wave, we realized that there is a very sparse proforma or usage of oxygen, and the usage of oxygen was high, and we did not have the supply. So we had to rationalize the oxygen therapy at best. So therefore, we also should understand a second sentence, and that is, do not abuse the use of the oxygen as a drug. Also, if we do not put sterile water, if we do not use the oxygen therapy easily, if we use oxygen concentrators which are not clean, then we also need to keep in mind the black fungus which has been generated not by only oxygen therapy, but by many other uncontrolled sugars and immunosuppression caused by COVID. Some hard light facts are that oxygen is the third most abundant atom in the universe, second most abundant atom in the biosphere, most abundant atom on the Earth's crust, but that does not matter here. What is important is it is the most abundantly used drug in the critical care and the ER, not only during COVID, but even in the pre-COVID era. So what is oxygen therapy? It is just plain simple giving oxygen at a concentration higher than 21%, which is ambient air oxygen content, to try and treat and prevent hypoxemia. We should understand that oxygen delivery basically is of two types. One is the low flow system and the high flow system. The difference between the two is that the low flow system delivers oxygen less than the patient's inspiratory flow rate, which could be anything from 30 to 60 liters per minute. And therefore, even if we dial 5 liters, 10 liters, 15 liters, the approximate FiO2 is not constant and it is variable because it is still less than the patient's inspiratory flow rate. As against that, a high flow system, earlier known as the Venturi mask or the Bernoulli phenomena, converts that 10-15 liters into a more than 60 liters per minute phenomena, and therefore you actually land up giving a constant FiO2, which is usually because it can be achieved because it is higher than the patient's own inspiratory flow rate. So on the low flow system, we have the nasal prongs, the cannulas, the face masks, and then we have the partial rebreathing, which we have, which is not available, and the non-rebreathing mask, which gives up to 90% oxygen. Mind you, all these, even the NRBM, is not a high flow system because it is still less than the patient's inspiratory flow rate, and therefore you cannot exactly deliver the constant FiO2. On the other hand, till now, Venturi mask was the only high flow system, as I mentioned earlier, because it uses the Bernoulli phenomena, converts the oxygen from the oxygen concentrator of 10 liters to almost 60 liters at the mouth, and therefore delivers a constant FiO2, not a higher FiO2. Now, in the last about 5 to 8 years, we have also realized that there is another technique called the oxy mask, and I'll just allure it in a bit. But what is most spoken about in the COVID scenario is the high flow nasal oxygen or the high flow nasal cannula. So this is the Venturi mask, and as I explained, oxygen is given through a small port. There is air entrapment, and then there is a viscous drag leading to a jet stream and a constant FiO2 delivered. This is the oxy mask, which has a lot of holes, and therefore it uses a mushroom principle or an umbrella principle, and therefore it can actually deliver oxygen from even a nasal cannula worth 6 liters till up to 90% oxygen. Now, this, in my view, should not be used in the COVID scenario because it does not achieve a tight seal, but it has got a lot of holes. So there may be aerosol generation in these patients, and I would refrain from using the oxy mask in a COVID patient. Coming to the HFNC, which today is the actual high flow when we talk about COVID. This is also known as the airvo or the super oxygen, as we fondly call it, like we also call super PEEP when the PEEP is more than 15 on a ventilated patient. So what does this do? It basically eliminates the carbon dioxide a bit. It increases the oxygen efficiency. It may decrease the work of breathing, and it can be a substitute which is very comfortable to use instead of a non-invasive ventilation. So generally, when we start using an HFNC in a non-COVID scenario, we would use about 60 liters of oxygen and 60 liters to 80 liters of flow per minute. But here, because we do not want the aerosol generation to happen, we might start at 30 to 40 liters per minute and oxygen depending upon the FiO2 or the PaO2 of the patient. So this is the picture of the airvo. It's got very easy nasal cannulas and it can be used. And again, there is a chart for pediatric use and infant use. And we are adult emergency physicians, so we probably know exactly what to use for which group. So where do I place my HFNC in clinical practice for COVID and non-COVID? I may have a graph like this going from oxygen therapy to improvement and back to the oxygen therapy. If the patient gets worse, we used to use CPAP or BiPAP and then use a mechanical ventilation and then taper them or wean them off back to O2 therapy. But if with the HFNC, we can actually have a big area where little more than oxygen and little less than NIV or even equal to NIV can be used. And this is the role of the HFNC. Now, as I mentioned earlier, in the second wave, we realized that we have a lot of oxygen debt in the country. And therefore, earlier we had said that HFNC might actually be better than NIV because the aerosol generation is less. And therefore, we invested in a lot of high flow nasal cannula machines. But because there was a high usage of this oxygen by this therapy, we then realized that in the second flow for some time till our supplies were met, we would have to refrain from using high flow therapy to a large extent. This brings me to the NIV, which is a brother sister of airway, maybe an elder brother because this has been used for a much longer time than the HFNC. And we know that besides many, many advantages of NIV, we are looking at only two things. One is decreasing the work of breathing. We need to know that in a COVID patient, the work of breathing is extremely high, much more than any other ARDS patient. And this is the main cause which leads to something called as not VILI, which is ventilator-induced lung injury, but it is called as PCILI, that is patient-induced spontaneous lung injury. So this is unfortunate that even in COVID patients, there could be major lung injury, even leading to pneumothorax, as Kedar mentioned. And this increased work of breathing is what we need to tackle when we are using an NIV and even when we are using a mechanical ventilation. The second thing that it does is it improves the oxygenation and may reduce the carbon dioxide in these patients. So the main two things that an NIV achieves in COVID scenario, since we are at it, and even otherwise, is an improvement in the oxygenation, and we can titrate our EPAP to improve the oxygenation and decrease the work of breathing, and we can titrate the IPAP in a bi-level to try and decrease the work of breathing even more. What makes the success of an NIV is the correct application and the right usage of the interface. So we know a lot of interfaces like masks, etc. in NIV, but we need to understand how they have been different in the COVID scenario. So we have all these masks, from a full face mask to a nasal mask to even nasal prongs to a total face mask and then a helmet, etc. So you have these interfaces here, and I will just discuss them a little bit in a bit. So when we are using a face mask or a nasal-oral mask, we must make sure that we do not have any vents here, because these vents are definitely going to make the patient release a lot of aerosol, and that could be dangerous to a lot of healthcare workers. And therefore, whenever we use a mask, we should be using a non-vented mask, and the tubings used in NIV should always be a double tubing to prevent aerosol generation. And this is how you can actually look at the correct choice of the mask and the tubings in a COVID scenario. You may have nasal pillows here, which are also very convenient, very similar to the airway usage. But again, if they are mouth breathers, this may not be good. And in the COVID scenario, again, it may not be good. This brings us to something which is the most recommended in COVID scenario, and that is the helmet. And it looks like this. Unfortunately, it was made in Italy. And in the initial part of the first wave, Italy had the highest number of COVID serious patients. And therefore, any import-export from that country was not available. And therefore, very few helmets are available in our country for usage. If somebody has been using it and has a large experience, I would really like to hear from them. So this is a very convenient one where the patient can be moving around. And the best part of this is that the patient can talk, communicate without any problems, and definitely does not lead to any aerosol generation, almost none. Coming to what are the principles of NIV with COVID? Yes, I mentioned helmet could be preferred. A non-vented mask is preferred. A full face mask is preferred. A double tubing is preferred. Minimal pressures, because if we go beyond 20 IPAP and 10 EPAP, we may cause aspiration and cause worsening, and a higher FiO2 can be used. The concept of PCLI, I already mentioned, and this is a nice graph where it actually tells you when to use HFNC, when to use NIV, and when to cut your losses and directly intubate. So this is just the entire diagram which we need to understand for NIV. And once you actually put them on a ventilator, then what should be the settings? The most important part here is about proning. And as I mentioned earlier, proning is done at any time, right from the house where the patient may have very low saturations and can be monitored. So I get calls from patients which say that my saturation is 92, but I am feeling good. And I say, and they say, we don't have oxygen. We do not have any facility. I'm alone at home to go to a hospital. Morning, my son or somebody will come and take me. So I say that try and go earliest, but if not, then try to lie prone. And believe me, the saturations from 92 on proning within half an hour, they show me a picture showing almost 97 or 98 saturations. And you can avoid the night fiasco. So this is how proning can actually be useful. And we know that there is a lot of science behind it. It increases the FRC, it improves the VQ matching, it facilitates secretion drainage, and so on and so forth. But it also takes away the heart from the lung, and therefore there is an opening up of the posterior basal segments, which are usually collapsed. And there are many improvements, including the positive pressures in the intrathoracic and the plateau pressures in the lung. So in COVID, how does proning help? This was a very good article last year, and this actually said that awake proning can be used, and it is of huge cost-effective benefit, no cost, and total benefit. So these are the 4 things, and this is called as the CARP protocol, where you can prone them, you can then do a lateral position, you can make them 60 to 90 degrees, and then in the other lateral position, and then prone again. And this is how a awake patient can actually do it, him or herself. And then you have the critical care management, where I said you can use the NIV or HFNC with proning, you can restrict the fluids, and you could do even awake proning in some patients, and notice that these patients might improve. I just mentioned this. So any form of oxygen therapy or intubation or HFNC or NIV, you can actually do very cautious proning. And then there are lots and lots of criterias, and this is just one taken from the Penn University, where it tells you what are the indications, contraindications, duration. Now it's important that you don't prone for half an hour on a ventilated patient and then give up. You need to prone minimum 16 hours, sometimes even 20 hours a day for the benefits to occur. And we had the ProSeva trial, which actually showed that long back in the non-COVID era. We also need to know what all to look for, how to avoid the pressure sores because of the proning, and also what should be done post-proning, and also why and how can we do the reproning back. So how do we make the patient supine again, should all be followed. And whichever protocol you may follow, you need to know and have a checklist and have the right team for that. So this is another very nice flowchart where it tells us the inclusion and exclusion criteria. It tells us looking at the saturations and what should we be doing and how long can we actually try the proning position. Coming to the most important and difficult part of COVID management, and that would be the intubation and the mechanical ventilation. And I definitely feel intubating a COVID patient is fraught with lots and lots of apprehensions. And therefore, we should try to understand how can we intubate somebody with the best precautions so that we do not delay intubation in the benefit of the patient, and we do not land up getting the COVID from the act of intubation. So first and foremost, the need of intubation, there are some pearls here. Never should you do a crash intubation, because that's when you are ill prepared and you will land up killing the patient. Always do a drug assisted intubation, which is the new term for RSI, and avoid aerosol generations at all times. So if there is an impending airway obstruction, signs of unsustained work of breathing, as I mentioned, refractory hypoxemia, you're giving them oxygen, you are increasing the oxygen, you have put them on an HFNC, NIV, and they are still breathing heavily, they are still not improving their saturations, then that's the time you might do it. There may be another group where COVID might have affected them in terms of a stroke or encephalopathy, and obviously because of an inadequate airway, we would need to intubate them. But the most important factor is anybody who is slowly worsening or anybody who presents with a PF ratio between 150 to 200 would be a candidate to presume and think and do the intubation at the earliest. The first studies in the initial last year showed that a patient who was ventilated, 85% had mortality, and therefore people were deferring the intubation and doing very late ventilation. But over the and it is much more dangerous to delay intubation at all costs. So there is no debate on this anymore. So we need to do our protocol, and that is planned intubation. Plan your steps. Healthcare workers should always wear an extra hood, Honeywell or anything else over the PPE. A video-assisted laryngoscope is the one thing which can help you, because you can stay at a distance of at least 1.5–2 feet and prevent the aerosols coming to you. And always pre-oxygenate them. Avoid the use of an umbu bag, as I've mentioned here. Use a bacterial viral filter, pre-oxygenate, and use RSI or DAI accordingly. So this is very important. Now, once I've put the patient on a ventilator, again, Gattinoni showed that there are 2 types of lungs we have. That is the L-type phenotype and the H-type. So the L-type was the early stage with low elastance, low lung recruitability, and had a low lung weight. Whereas the H-type had high elastance, high lung recruitability, and a right to left shunt. So there were patients that we put on a ventilator which could be easy to ventilate and difficult to oxygenate, or those that were difficult to oxygenate and difficult to ventilate. And this is a very nice chart. Depending upon the phenotype, as per the HRCT, you can actually decide what form of ARDS you are tackling. And as mentioned earlier, you may even have a pneumomediastinum pneumothorax to complicate these issues. Am I going back? Sorry. Yeah. So what are my principles? Yes, we have borrowed this from the ARDS net protocol, and that is a target tidal volume of 6 to 8 mils per kg of predicted body weight, plateau pressures not to be above 30 centimeters of water. And I have just made an ER and an ICU protocol, keeping all in mind. So when I have intubated somebody, I need to check the ET position, not by a 5-point auscultation. I would avoid an umbu bag because that's dangerous for aerosol generation. I will always use a filter. I will probably see the tube going through the vocal cords, especially if I'm using a valve, and I would keep the tubings ready with the filters attached. Now, when I'm immediately putting the patient on a ventilator, this is a whiteout lung. And if you start using your ARDS net protocol, where you are giving low tidal volumes and you are using pressure control, what would happen is the patient would not get ventilated and there would be stacking of breaths and the patient would die of hypoxia and hypoxemia and also a low blood pressure. So this would actually, we have seen in our initial days where doing this, putting them on a pressure control, patients would die within 2 to 3 hours or even less after putting them on a ventilator. Otherwise, they were maintaining on the sympathetic drive and they were maintaining on a NIV HFNC. So what I would suggest is when we initiate the ventilation, always start slow, use a CMV mode, put tidal volumes of 400-500, keep your high airway pressure limits very high so that patient at least gets ventilated, keep pressure alarm limits very high and watch the hemodynamics closely. You may try prone ventilation, but I would suggest do not try that in the first 1 or 2 hours till you have maintained the arterial line and also maintained hemodynamic stability. Once you've done that, now you can easily follow your ARDS net protocol of a 6 mils per kg tidal volume, plateau pressures less than 30 millimeters mercury, and a driving pressure, which is important now, which is plateau minus PEEP of less than 15 millimeters mercury. We have certain tricks in improving the oxygenation. And as I mentioned, we can prone these patients, but put in all your lines before that. You can't prone and then you say, oh, wow, the improvement in saturation is great. But now I forgot to put a central line. So again, unprone him and again put a line and then do that. So make your plan very appropriate. Increase the PEEP and monitor the blood pressure. You may use inverse ratio and you may use recruitment maneuver, but all these are not much to be used in a COVID scenario. Avoid Willy and lung protective strategy should be used at all times. And all patients, as I mentioned, should probably have a central line, arterial line, Foley and Riles tube for feeding these patients at the earliest before you even think of proning. Coming to my last part, I'll just take about 4 or 5 minutes more. An ECMO in COVID, and I don't have any personal experience on that, but this was a big study which said that there was a lot of coagulation and inflammation problems with COVID, and ECMO might help here. And this is an extracorporeal life support organization, which actually gives you an amazing guidance document of when to do ECMO, when not to do ECMO, and what are the steps that you should follow, where it is strongly recommended and weakly recommended. And this is a registry of the same ELSO. And you can see thousands of patients have actually received ECMO, mainly in the North America and the Europe, and the Asia Pacific usage is much less. So I end my talk here by giving some pearls of wisdom in the management of respiratory management from oxygen till ventilation or ECMO in a patient. So first and foremost, remember, whilst we are ventilating, we cannot forget our fast hug, and that is prevent a VAP. And oral hygiene, chlorhexidine, mouthwashes are very important. And believe me, if we do this, this is very important in also preventing the mucor, which might happen later. The next thing is physiotherapy. We tend to forget physiotherapy in our ICUs, especially for the COVID patients, because they have to wear PPEs and go in. So hygiene and physiotherapy have actually gone for a toss in the initial months. But when we have instilled physiotherapy, we open up the lung bases, we improve their capabilities, even on a ventilator, even in prone position. That really takes a long way in helping us in trying to wean the patient off early. As I said, these patients are extremely tachypneic and have a very high work of breathing, even to the tune that they might get a patient-induced lung injury spontaneously. And therefore, the first 2 days, what I do is I sedate them. I even put them on a paralyzing agent and take over and prone them. Once they are better after 3, 4, 5 days, then only would I unprone them with gaps, and then I would also reduce my sedation paralysis. And if there is an improvement in the PF ratio and the patient is conscious, I might do a very early, quick weaning. So that is very important. We also need to know that many patients may be treated well and go home and come back with post-COVID fibrosis. And we need to understand that this is another group of patients who might need aggressive physiotherapy, some very low dose of steroids, and also maybe a BiPAP at home to try and tide over any emergency. And in all these patients, a proper window and a timing of tracheostomy would also do us good, because the requirement for sedation would be less, their work of breathing decreases, and it makes us easier in weaning them off. Also, if they deteriorate, which they may do after 2 or 3 days of extubation, would be prevented when we have already tracheostomized them. So in summary, my friends, we can use oxygen low flow, high flow, NRBM, nasal cannula, whatever you may say. You can use NIV and HFNC. You can do proning at all times. You might have to intubate the right group of patients, and then you need to take care of the mechanical ventilated strategies and also the post-intubation medications and care. Benjamin Franklin said, "By failing to prepare, you are preparing to fail." And I'm glad that I'm part of the Maharashtra team of Task Force, and we are here to try and prepare and prepare and prepare along with all of us to try and fight this demon, which is a COVID, and we still have a long battle ahead. And I would request all of you all to stay safe and stay healthy. Thank you.
Thank you, Dr. Kushav. I should congratulate you. You have covered this vast topic and a very important topic in a very crisp manner. I will just summarize what he has told us. The COVID ARDS is a little bit different than the non-COVID ARDS. It is a heterogeneous disease. So for each patient, you have to tailor-made the ventilation strategies. Then he has told us about phases of COVID. Then oxygenation is a central theme for all patients of COVID, be they are mild, moderate, or severe. Then he told us about importance of proning in all stages of COVID, different systems of oxygen delivery, namely HFNC, but no use of oxymask. Then he highlighted about Willi and P-Silly. Then how to do proning on a ventilated patient. Mechanical ventilation management is a real test of the intensive care team, and the result out of this mechanical ventilation gives us idea about the caliber of the team. When we are doing intubating the patient, it should always be a planned ventilation. We should have a strategy of doing intubation in a COVID patient. It should never be a crash intubation. Most of the patients of COVID who are critical have a PF ratio in the range of 100 to 200. Here in Fortis, we are using 150 as a cutoff to plan our strategy to intubate. Then he told about L type of lung, H type of lung. Then tricks to improve the oxygenation on mechanical ventilation like proning, recruiting the lungs. And then what are the indications of ECMO? I really thank him. So there are no questions now here. So
Thank you,
Sandeep,
sir, for summarizing so beautifully. Thank you. Thank you, Dr. Shah.
Yes, sir.
Thank you.
Yes, sir. Yes.
So Sandeep, there are no questions here.
Yes, sir.
So
one question is for Khusraw, sir. Is advisable to prone patient for 48 to 50 hours?
Yeah, so basically proning is an art, and I had taken a very nice lecture on art of proning with the background of science. But remember, the earlier studies failed proning because we were doing for 8 to 10 hours. Only when you do it for a minimum of 16 hours and you do it very early in the stage of ARDS, the Proseva trial showed benefit. Now, why do you need to again unprone them? The reason is for nursing care, sponging, taking care of the front area of the patient, relieving the pressure sores. So trust me, lying down on your back, you will develop a pressure sore if you are vulnerable in 3-5 days. But patients within 10 hours of proning develop pressure sores everywhere. And therefore, you need the right pillows, etc. So 16 to 24 hours is what is recommended. And at least 2 to 3 hours in a day, you might need to unprone them for the nursing care and the other care. Going on for 40 hours and 48 hours is probably ek bar prone kar diya, so why should we bother unproning them? And let's get the maximum benefit that actually hasn't been studied.
Okay. Thank you, sir. Thank you, Pradeep Shah sir and Khusraw sir for this fantastic session. I appreciate your contribution to EM Conclave 2021.
Thank you, Sandeep. Thank you for an amazing conclave that you all have put up. And we are very, very proud of this section. Thank you.
Thank you. Thank you. Now I'm moving to the next speaker and next talk. The next talk is the managing the pandemic in rural area, the war fought with limited resources, and none other than Himmatrao Bavaskar is talking this particular talk. And I think, sir, are you online, sir?
Yes, yes.
Sir, video. Okay.
Video.
Okay, it's okay. So I will give you a brief introduction for sir. I think I think sir is a pioneer of emergency medicine in Maharashtra. I think he started emergency care at the rural area where resources are very less, and dramatically he did fantastic research on red scorpion sting, and he brought down the mortality by 84% in the coastal area of the Maharashtra. He has multiple publications in the Lancet, and he is authority on scorpion sting all across the world. He saved many lives there. I witnessed his work at his hospital, snake bite, scorpion sting, as well as he manages acute myocardial infarction cases in the rural and resource limited area place. And in one line, I can say that this man has made imprint on the planet by doing the extraordinary clinical work in the rural area where the emergency care needs the most. And in this pandemic also, I am in contact with sir from day one of the first case when he found in the Mahad, and I can see that he has treated more than 1,000 cases and in his settings, and with best recovery. As last time when I spoke with him, he told that none of his patients died there. So it's something extraordinary he achieved there, and I will not take much time to talk, and I will ask sir to please go ahead with his presentation.
Thank you, Sandeep, for my introduction. I'm hearing, are you listening to me?
Yeah.
I'm audible?
Yes, sir.
Yeah.
Very much audible.
So now let us, I recollect by your introduction that when I submitted my very important paper to the British Heart Journal, I said it is a primitive knowledge with the rural area. What do you mean, sir? It is not primitive, but advanced knowledge in primitive place. So that again recollecting me today's slide, My dear friend, when the COVID started in December 19, then I have decided when pandemic has started, pandemic will come to the India. So how I prepare, that is very important because no doctor was ready to touch the patient for say till the June. Nobody was ready to because they keep the patient at the door and what happens? Fever, go home. Fever, I'm not treating the patient. But I have decided, we both wife and husband have decided we'll manage the patient at rural area. So how both prepared to face the pandemic? I studied all detailed publication from December 19 to March 21 in Lancet, BM, then NHGM. We have decided hard his patient will be examined history in detail. We took MMR BCG vaccine. That was no vaccine was available. A MMR is the protein content of a measles virus is equivalent to the content of coronavirus. And no BCG, I would take BCG before the Sharad Pawar took the BCG because it increased the immunity. Regular putting diluted iodine in both nostril and gargling because AC receptors are more rich in the nasal mucosa and this virus has a high affinity for AC receptors. So only the betadine or iodine kill this virus. That's why we regularly putting betadine both nostrils. Regular use of double mask, washing hand and sanitizer, wearing specs is very important. No more than 10 minutes history and detailed examination. Patients are rapidly examined and rapidly allowed to go. Early, we noted simple CPC, lymphopenia and eosinopenia, first 24 hours to occur rather than CPR or other factors. Very important, hyperglycemia with a normal HbA1c. Even this hyperglycemia we treated with insulin, whether the HbA1c is low or it is high. No HRT what was so simple X as you learned in this previous lecture. SPO, SPO2 has helped us. Both we never use PP. This is not this is not my proud. I'm not only face field double mass PS Bowsker was only RT-PCR positive with no symptom. It was done as a routine. SSP was negative. So though I was hypertensive, hypothyroidism, at the age of my age is 7, still I courage to treat the patient at rural area because nobody was touching these patients. So ultimately, what is the aim of the table? First is antiviral. Now, as far as India we are concerned, I have never seen up till now remdesivir while the tocilizumab. We use flavipiravir, which is oral available at home even. Ivermectin, which is again antiparasital, very nice drug, useful in rural area, 12 milligram body for 4 to 5 days. Even we use this as prophylactic to the relatives of that is who has exposures. Anticoagulant, that is very important. We use of course all the patient with the weakness, fatigue, and that when we suspect, we start this drug and aspirin. Low moderate heparin, remember, patient is not ready to get admission because of the spread of the news in the society that the doctors are charging heavily. So what we avoid this, we train as the very relative with the taking due caution of the exposure and to give low moderate heparin at home. Rivaroxaban, when the patient don't want to injection, we reoxide, dabigatran, aspirin to all patients. Anti-inflammatories, dexamethasone was released in minimum 0.25 milligram per kg body weight, and within 7 to 8 days we taper it off. Metformin is a good anti-inflammatory drugs. Statin is, smoothing of endothelial plaque and is good. Colchicine is also again a very nice anti-drug. Naproxen and endomethacin. Patients who are diabetes, who are hyperglycemic, where steroids, so we don't use steroids to avoid this mucormycosis and hyperglycemia. We use all this. Metformin used in all patients, statin used in all patients, colchicine, naproxen, endopath used in diabetic patients. Another drug which we found a very good in early stage because patients are coming within a couple of days with the signs, symptoms of COVID, fluoxamine alpha-1 agonist. Because you see, this is cytokine storm which stimulate the alpha-1 receptor, which ultimately inhibit the alpha-2 receptor, which secretes adrenaline. So ultimately, adrenaline secretion of cytokine storm is prevented by agonist of the alpha-1, that is fluoxamine. And his antidepressants are very important. We give 50 milligram twice a day. If this CRP is very high and more symptomatic, we can raise the dose to 100 milligram twice. All vitamins, Methylene, This now recently their hypothesis has come. This cytokine storm, there is also additional other storm, that is a bradykinin storm. And the bradykinin storm will enhance the nitric oxide synthesis in the lung, ultimately vasodilation, capillary exudation in the fluid, and the vicious circle develops. Now the methylene blue is a nitric oxide synthetase inhibitor. Ultimately, this methyl blue is now soundly proving, but still, what we are selecting, we cannot go by the high flow oxygen. What now discussed, it is impossible. We have reached the poor people. We found it is as far as pure, good drugs, targeting drugs will be helpful. Now, hyperglycemia was corrected by soy insulin. Any victim, any patient with COVID or when they suspected by hyperglycemia, insulin, insulin, insulin. Irrespective of HbA1c normal percentage. We found a newer diabetes in many patients, though HbA1c is low, normal, but hyperglycemia exists because AC2 receptor, which block the pancreatic receptor, also pancreatic secretion, and we get hyperglycemia. That's why insulin deficiency occurs. Next is important. I never use even saw remdesivir and tocilizumab. Now, prevention. We noted the victim relative in full context. First, we write a prescription for them. When the patient comes with the victim, and first we write a prescription to how to prevent the relatives of, because many patients, I will make 12 ml every 12 hours or twice a week. Counseling of early symptom, use of 99 masks, 95 masks, and early house contact and report to the hospital early as the first symptoms. Now, the very first symptom we noted is irritation in the laryngeal, pharyngeal edema. We get very irritation and they get difficulty in pain while drinking the water. Is the first and most symptoms where the respiratory system is the virus started entering. And before that, we get a weakness, then we get a headache or various other symptoms. But this is a very the first symptom, all the irritation. Patient show like this is irritation. Ready to share the knowledge with my rural peers. That's very my poor never switch on chronic never switch on. Chronic excessive oxygen is avoided. You see, oxygen today we have seen a lecture. Why oxygen content is avoided? Because it is a lack of availability. Shortage, that is not the case. Because our oxygen itself is a toxic. I generally go to my in the COVID hospital, they give jumbo oxygen and this where oxygen, your 10 liters, 25 liters. I say them, make we want only 94% saturation. Never go to 100% saturation. Because the normal person surviving 21% of the oxygen saturation in the environment. So this oxygen itself, my complaint to our task force member, the oxygen itself is killing many patients now, rather than giving correcting the hypoglycemia. Oxygen content no more better in severe hypoxia because this is will not helpful. NI ventilator, see, this is BiPAP ventilation, is your hero and the darling of critical care COVID ward. So when the patient is breathless, when there is tachypnea, when the patient is SpO2 goes below 90, we start NIVP. Now yesterday, the day before we got a patient with 35% saturation, sinus, and patient was telling me, Dr. Malazagwa, we just apply oxygenation and BiPAP within 30 minutes, it goes to 90% and patient when conscious, he was worshipping like anything. So this is the chance of a doctor or researcher to get many worshipping because our hospital is becoming a temple. Many gods are coming to you. Ready to share the knowledge, this is important. Oxygen, NRV, most recurrent chance of hospital in many patients. That when I refer to the hospital, they come and this teaching doctor says, तुम्ही इन्फेक्टेड लंग घेऊन आले, तुम्ही दोन्ही लंग घेऊन आले, खराब लंग झाले, आम्ही काय करणार? And आपली patient dies after 10 to 20 days. So ultimately, home oxygen facility. I'm now today even 10 to 15 my patients are taking oxygen at home. Do care of preventing the exposure to surroundings. Once you put a tube in the trachea, the mortality is significantly raised. What USA did in the face of a pandemic. So this is because we do not get a skilled doctor. Treating a ventilator is an individual skill. Now avoid air conditioned room. This is very important. Open window the room or farm under the tree. If farmers are there, we make them go the farm, sleep under the tree. Continue antiplated for one more. This is always forgotten. If the patient is discharged, they forget everything. So doctor must say, because thromboembolic phenomena can occur up to one month also. So ultimately, my dear friend, this is my simple hospital. We believe no COVID-19 victim should die. We pray that no good. When we see the young people are dying, early members are dying, the cry of the relative is really continuously ringing to my ear, and we take place. We believe no good victim should die. Now, what happened? The age-wise, all age group are getting this is age-wise. All this first waves. That is in last year we get all age group. Most commonly, older people are more. And very important in this case, 144 is to give the exposure to COVID. So at this time I was discouraged whether should be their home quarantine or should be given the separate. But today, what I am facing, patient will come to base from the home. Already he has infected because he come with a couple of days, and this today's virus is a rapid progressing, highly virulent, highly deteriorating to the patient. That's very important. So when the patient come to already his family is infected, that's why now in the second wave I get 25% of families with the COVID. Now, important number, very important. When I say the Bavaskar is treating a case, within 1 week patient come to me, rapidly coming. And this patient prognosis, when they come earlier, we start our cocktail, that is aspirin, antiviral, then fluoxamine, anticoagulant, and all this system will started as this early stage. Whether I never wait for RT-PCR, I never for HRCT, I never wait for even CBC, simple CBC with a symptom, body ache, fever for 1 or 2 hours. Because of this fever, 1 or 2 hours, and patient disappear because of crossing and they self-administer or they eat from chemist, and ultimately there were delays. But the patient are coming earlier stage with a fever, 1 or 2 days. Take the history is important because they forget this history after 5 days. They says body ache, kankan. Kankan is a common word in the rural area. If it is kankan, it is a confirm, it is generalized this viremia, which is kankan because his virus has entered the body. Then tracheal, which has mentioned this, then body ache, loose motion, another important. I have seen the bulimia during night patient woke up and for eating and hungry, that's bulimia. One patient has hiccup. Now total insomnia which are patient cannot sleep the whole night. That is a very rare phenomenon. It's not because of depression, which improve with antiviral treatment. So the important thing is the patient who has the oxygen level. So less than 90%, 30% ultimately when they come earlier stage with the 96 and then we manage very nicely, they will never return. They will go to the home. This patient will go to the home. They will never return. And this patient will improve like this. So important is the blood group. Now there were drugs. Now we found the patient with a blood group deteriorate very fast as compared to O group. Because we don't know why. But blood that may be antigen because I am not a hematologist. But blood group A, if the patient with blood group A come with a viral infection, they really deteriorate fast as compared to blood group O and rest. Next important, what are the risk factors? Very important. Diabetes, very important thing. History, many patients forget tell the history. Hypertension, now ischemic heart disease, renal failure again because diabetes, hypertension, diabetes, cancer pancreas, one patient died. Breast cancer, this another patient died. COPD, 8 patients. Chronic cirrhosis, that one patient again. Hypothyroidism, HIV, CABZ, stroke, meningococcus, anemia, and obesity. Obesity, you see, in first waves, we get young and obese patient. In the second waves, we get obese. First wave, old and obese. Second waves, we get obese and young. And third wave now, obese and children. So obese patient remains in all 3 ways. So obesity is one of the important risk factors in the susceptibility of this virus. Now, this is how the curve, how the manifestation goes. So, early small, these are the 4 diabetes, hyper, ischemic, CO disease. This is a very important culprit because, and that's why we must take care of hypertension. We must take care of diabetes. If diabetes generally come with uncontrolled diabetes, So many our physicians or endocrinologists to be know that diabetes in India, as per discussion, it not this insulin will, this oral drug will not work after 7 years. They must put on insulin. So majority of diabetes victims come without insulin, and they say we got diabetes for 10 years, 40 years, and that's why they are more susceptible for tuberculosis and this viral infection. Next important, inflammatory biomarkers. All inflammatory biomarkers are raised in the victim. See, C-reactive protein is raised, and very important. C-reactive protein is raised generally third or fourth, not by immediately. Serum ferritin also raised. These are another good inflammatory markers which can diagnose the severity of the patient. Then D-dimer. D-dimer is very important. If D-dimer is raised and antiplatelets also raised, here comes a dilemma that we have to give low molecular heparin for the platelet, and for D-dimer, we have to anticoagulant. But anticoagulant will not act in the antiplatelet, platelet, that is thrombocytosis. So this is very important. Now, HRCT score. This is very important. Now, HRCT was not available earlier, so we just did on clinical manufacturing. Now, the HRCT has become available. 39, you see, more and more on the HRCT, which occur total. HRCT, high resolution chest tomography was more score, 25 to 50, and more than 50, which are the severe cases. Treatment and result. Flipure and adjuvant treatment, we returned 249 patients. Recovery was 62%. Adjuvant in what? Doxycycline. Why use that? Now the every clinician, every critical care, don't give antibiotic. Doxycycline, my dear friend, no doubt it is an antibiotic, but it is a cytokinin inhibitor. So doxycycline must be in your protocol. Ivermectin, aspirin, statin, metformin, vitamin B6. B6 is an anti-cytokinin strong. It prevents the cytokinin and cellular level. Heparin is dabiruxan, methylene we have just discussed, and NIV. Recovery is very high, to 94%. The 11 patient died because they come too late in gasping stage, bilateral crepe, hypoxia tumor, and 13 patients we referred. And out of these 13 patients which we referred, patient was, we don't expect they will return, maximum also they died. So, oxygen toxic use for long duration. However, sometimes patient may recur without oxygen, though it was essential. One should be cautious while applying oxygen for long duration. Priestley rules. That's a very important. I got this reference. Excessive oxygen might burn the candle of life. Too quickly and soon exhaust the animal power within. So thus oxygen has come to be recognized as both essential and toxic. Inhalation of poor oxygen can lead to the convulsion, asphyxiation, blindness, and death. So in animal studies, hyperoxia, excessive oxygen was found to be cause alveolar inflammation. That is, we are handling symbiosis with the virus action or cytokine storm, fibrosis, and loss of diffuse capacity. So one should keep in mind while giving oxygen, we are restricting oxygen, not by being supplied is wrong. Now next, severe, you see, this is one patient which I want to project. I was submitted it for the Nature, and I left 3 months. They are doing a review of this case report. Now this is a 45 years female, RT-PCR positive, raised reproductive marker. She was given she has a 76 dilution, and then 76 SpO2. So we give 4 liter oxygen, raised to 44%. She denied hospitalization. Gone home against medical advice. And then we are given the treatment, at least continue that whatever the after we are going to. On third day, same patient returned to home without oxygen 91%. On 27th, it was 99%. On December, it was normal. Look at the CT scan. So whether we are wrong, where we are wrong, whether we are just unqualified to treat the patient, because this is the patient without teaching me to, his oxygen was essential. So again, he was administered intravenous methylprednisolone, 40 years old male, and for 5 days, then tapered was oral prednisone. Remdesivir for 100 ml normal saline and 50 milligram for 6 hours. Tell me, sir, low motor heparin, subcutaneous, vitamin D. He was bypass 5th day, oxygen 10 liter per minute, continue for next 10 days, irrespective to 94. He was discharged this August. He reported to Maha. This was come for intensive care unit. He reported to Maha 29 September 220 with the complaints of weakness, mild pain, expectorant, cough, and exertion. His blood is 35 is 99. The chest figure is showed bilateral diffuse fibrosis. He was on piriperidone 200 ml 3 times a day, Defcon and clarithromycin twice a day for 2 weeks. His dyspnea took 2 weeks to disappear, SQ to 100%. Repeat chest X-ray was normal. See the figure. So ultimately, one should keep in mind that a chest fibrosis are very common. So here the methylene to prevent the fibrosis. Now this is the methylene blue report of 7 cases. Look at the patient. First when the saturation was 85% and the oxygen requirement goes on. See, 12 liter. When the methylene blue appear, oxygen requirement goes down and oxygen saturation improves. If same happen in all 7 now, we are treating now more than 100 patients with a methylene blue. This is important to know because underlying pathophysiology is the most important. It is acting that alveoli and better to buy. Even rural area, we give oral. Oral just give the 10 to 51% IRF 4 hourly. Or if IV is possible, but nebulization we avoid. But still they say the nebulization is better by the single, but aerosol is the most risk factor for us. Next important, this victim was given, this victim was severe. See, score was more than 20. And this patient come to me, we started orders, a methylene blue. After 10 days, recovery was very fast. So this fibrosis can be prevented. So long-term fibrosis can be prevented by methylene blue. But what is she? One task force has sent an email, a message. You can use methylene blue, say, this is useless. One sentence he has sent me, it was useless without giving a reference. That's why, my dear task force friends, come in rural area, not just attending a civil hospital is not done a duty. You must see what is rural area. Why you are not happening? The rural facilities, all facilities available in Bombay, and the task force member just pass a remark, you tell him is useless on this account. You passing such remark, you tell him is useless. So second waves which are come. Now in second wave, so both adults and children are affected. It is highly infectious. Whole family will infect rapidly. Whole family, rapid mutation patient in this victim is a highly virulent virus. The character has changed the virus. It has changed its cover, it has changed its dress, and the dress has become very tough. As compared to the सुताचा कपडा बदलून आता प्लॅस्टिकचा कपडा याचा व्हायरसने घातला हो and that is a highly infection difficult to damage. Now in the total cases were treated 502 days in second wave now May April death was 14 again they rapidly within a couple of days. Mortality of 2.60 same as the mortality yes in first waves. Family 26% were all family come with the infection. So this 55 years, 58 years male, he had a 2 days history of curved breathlessness, loss of smell, loss anorexia, body CRP rate. Within 2 days, yeah, HRC is forward 13 by 25. See, this is very rapid utilization. But and never wait for antigen as negative, RT-PCR negative, even influenza marker will not so raised. And this is important. That's what finding is the second wave virus. Male deteriorated 20 days hospitalized treated. Now see, many important. Patient in the government hospital, patient in the private hospital, it is not a treatment duty of a single, it is a teamwork. Treating a COVID patient with the respiratory is a teamwork, not an individual work at all. Now here is family, you see, these are the children. Now I'm telling whether second is a mix of the children and adults. And whether this third wave may not come, what I'm thinking, because children are already infected. But when I say this, but the task member says, no, it is the second dose only. This is important, what I think, because all family members, children are getting infected. So ultimately, this is the second and third wave mix. And I'm happy if the children get infected second wave, they will get a herd immunity and there will be few children left to face the third waves. Now, this obesity is one of the important factors. My dear friends, this patient has 110 kg weight. He recovered with all markers were raised. But his mother also successfully recovered, but father did not. Because when they both were at home quarter, they were not ready to go to other side of hotel stay. But he said his father was so confident, he irrespective of repeated warning, repeated caution, wear the mask. He did not wear the mask, suffered loss and died. She was a case of CABG, so he was even vaccinated. He received 2 doses of vaccine. He had a severe COVID and he died. So my dear friend, again the come. So father died of COVID And here, child take the body of the father, reverse of myocardial infarction is happening in this case now. In myocardial infarction, young body of father, young body of son carried to the critical care in need. But this is a reverse occurring if you don't care of this patient. Now, in fact, 60-year-old man, known case of old central wall myocardial infarction. This is again cardiomyopathy, cardiomyopathy. Breast injury. He walked to with the central sinus 35%. I just discussed, and two he recovered the oxygen and methyl immunobilization. So this he is now on bypass. So this is very no, don't look at the HRCT immediately. Look at the patient. Treat the patient. The HRCT is a lesson done. Research will come to the conclusion. So now the young adults are recovering. Now this healthy young adults. But in this scheme, if they are diabetes, hypertension, ischemic heart disease, obesity, sedentary life, on immunosuppressor, they will not recover. So second why, this is very important. So this is the only important thing now. Second stage where we can face the risk factor, but the young people, active members of the people who do regular exercise, who take care of their health, who take care of their weight, will recover fast. So ultimately, vaccine. My dear friend, everybody must say vaccine, vaccine, vaccine. Now I have seen I think 68 patient of COVID has COVID with HRCT positive. Out of his 4 died. So this is a very discouraging news to us. Because if it discusses COVID with any members of any member, they should, my dear friends, COVID patient get infected, but they will never poor patient dying. So important. What is wrong in the COVID victim? Most important. See, these are the COVID victims. 67 were treated. So they all raised. CRP rose, D-dimerase, ferritin was raised. Now antigen positive, RT-PCR positive, HRCT was positive, SPO was less than 91. So 40 days female received COVID vaccine on 7th May 2021. She had a fever since 3rd May. She received a vaccine on 7th May. She had a fever, cough, and breathlessness, weakness, headache, S94, HS1624, and died on 70th. See, before giving vaccine, she had a COVID, my dear friend. You don't have time to take this thing, to auscultate the chest even, and given the COVID. So what is it called? Is it an antibody independence phenomena? This is antibody score and antibody enhancement which has occurred in just like a dengue. One should care of this also. Take history. It is very important. If you at least take, and then now task force should never do antigen in this victim if you want a vaccine. Means you want to aggravate this antibody dependent enhancement, at least you must do antigen. If they are positive, be careful of giving co-vaccine or COVID, taking the detailed care of this victim. So 70 years male was co-vaccine in 21. Fever on 7th May, on 15 days. Irritation on the throat, which I discussed. Export to his and wife positive. Recovery SpO2, 10 days, 88 CRT. HRCT was 25. Ferritin was raised. Platelets also raised. NRV with 10 liter oxygen died on 26 May, yesterday only. And this was the CT scan. This is a typical of antibody enhancement. Antibody dependent enhancement. This has been studied now. I am studying in detail. 90 years old received COVID in 16 May to 26 breathless, cough, and QSPO2 84. HRC was 21. How this patient is coming? Very bad. Now, 18/4/21, HRC was 3/25, who has received a COVID vaccine. On 23rd, after 20 days, it has become 17 score. What is this? If after giving a COVID, if the HRC score increases, it increases by enhancement. A 60 years female COVID vaccine, this is, see the why enhancement is occurring. Now the symptom is COVID patient will get fever, myalgia, typical all the symptoms what the active COVID has covered. Loss of smell, cough, and dyspnea. All symptoms we get. Hyperglycemia. Now duration between vaccine and symptom less than 5 minutes because that is accepted. 5 to 10 days after, even after 15 days, 30 days, and after more than 30 days. So please this is my appeal to all. Please let the one close relative observe through the glass. because these are the complaints which patient refer to and critical emergency. डॉक्टर आम्हाला काहीच समजत नाही हो, नंतर पेशंट एक्सपायर झाला. मधात 1 तासाने ते सांगून जातात, 2 तासाने ते एक सांगून देतात. My dear friend, this is very, very difficult because it is very difficult to accept a close, healthy relative in a couple of weeks. And that's why their psychology should be prepared. You see, in my case, in fact, I kept one relative with the patient, so he knows what treatment go, how doctor is treating, how he's observing. So ultimately, his mind prepared. If good happen, well, good. Even worst happen, his mind is prepared. That we attempted maximum. So this is great. So this is the worst thing happening today because never follow the other protocol. Never follow that. We want to build up our own protocol according to culture, socialization of our society. Tell them with a simple vernacular language, advice to contact. No. This patient is new with a new sign and presentation and progression. Remember, don't go with a routine protocol. Routine protocol is done by the person who has never treated, may not have treated the patient. So can anybody try a needle biopsy of the lungs? I say to the one of the task members, sir, mention that time. Can we get a needle biopsy? Because some my friend has sent me this kind of gun needle. Can I take a gun needle biopsy of a dead patient to study the histopathology? One of the pathology you was carving hungry for to study histopathology. When I asked the permission of the task force, they said, no, it will spread the disease. How knowledge will progress? How science will progress, my dear friend? Because postmortem room there is written, here death delights the knowledge. Here death delights the science. Here death blind our science. So this is very important, my dear friends. Is appeal to all doctors, appeal to task force members, appeal to ICU caretaker. At least you must know. Don't presume that it is not COVID positive. Which lung that is wrong. So, my dear friend, this is must be applied. Okay, thank you. Okay.
Hello.
Oh, yes. Thank you.
Thank you. Thank you very much, sir, for giving new insights while dealing the COVID at very limited resources. And your thoughts are razor sharp, and many people got enlightenment from that thing. And thank you for joining us in this EM conclave. You have been always supportive towards the emergency medicine fraternity in Maharashtra, and I expect the similar support from you will be there in future also. Thank you very much. Now I'm moving ahead with next talk. Now the next talk.
Any question? Any question? Any question?
Any questions? Comments are there, sir. It was amazing session.
Okay.
There are no questions. Yeah. Sir, now the next speaker I will introduce means I think emergency medicine fraternity do not need any introduction for this person. Professor Suresh David. I can say he is the father of emergency medicine in India. And nobody knows emergency medicine in India in 1994 when he went into the Australia. He took the formal training in emergency medicine and came back to emergency department and established the first emergency medicine department of India at Christian Medical College, Vellore. He started the residency in emergency medicine in 1996. And I think hundreds of emergency physicians train under him. And I'm fortunate that he's one of the students. And he is the author of 2 textbooks of emergency medicines. He's one of the book which is very popular, the small book that is a handbook of emergency medicine. That is also quite crisp book, ready reckoner for emergency physicians. He has multiple paper presentations at various national conferences, and he has multiple research publications also. And I would also like to add that he has been constant support for the growth of emergency medicine in Maharashtra as well as in Mumbai also. I think his presence is like Varnam Airam, means like a thousand elephant. Yesterday I was in dilemma. I am doing such a big program at web conference. How it will go or not? From 5 minutes, sir came online and we get that power, and I got confidence that we can do it easily, and I think we are doing it quite very well. So that is the power of sir, and that is the power of Professor Sujay David sir. And I will not take much time. I will ask sir to give this keynote address for this today's conference. That is resilience, innate attribute of emergency physician. Sir.
Thank you very much, Sandeep. It was indeed a pleasure sitting down and enjoying the feast of lectures and panel discussions which we have had so far. I've been on board since the beginning, and it's really been something which has riveted me to my seat. You have made me proud. You and all my other students in Maharashtra have really held the flag of emergency medicine very high in our country. I'm proud of you. Happy Emergency Medicine Day to you, to all our students all over the country, and to all the emergency physicians who are enjoying this program. So without much ado, I think I will go straight away into the video, which I will have to
Before starting the video, sir, I will introduce to the moderator of this session. And moderator of this session is Dr. Vijay Shetty. He is a head anesthesiology from our hospital, and he's an astute thinker, and he did very much good, great support for us as well as critical care department during the entire pandemic. And Fortis Mulund is mostly known for his 100 heart transplant, and he was leading the team of anesthetists during that entire endeavor. And he's a great friend of mine and great support of emergency department, sir. Sir.
Nice to make your acquaintance, Dr. Chetty.
My pleasure, sir. Welcome.
Thank you. I am able to see my slide, but I am not able to see
we can
myself.
see, sir. We can see your slide, sir.
Is it? Okay. Okay. Are you able to see it on a
Yes,
show
sir.
mode, or is it on the slide sorter mode?
No, you have to bring it on a show mode, sir.
Show mode. Yeah, can you see it now?
Yes, yes, sir.
But I'm not able to see the screen, but I guess you're able to see me, so that's fine. Are you able to see me also, or?
Yes, sir. We can see you also.
Oh, great. Okay. Yes, as I said, I thank Sandeep for giving me this very interesting topic, which is resilience, which is supposedly an innate attribute of the emergency physician. Now, when I was trying to go through this and try and look at resilience, I was reminded of the days when we were writing the textbooks of emergency medicine. We wrote a lot of things about disaster management, about counseling, so on and so forth. But resiliency training was something which was unheard of those days. So people just took it for granted. People knew about PTSD, post-traumatic stress disorder, but there was not much of information available until the turn of the century when we started hearing about resilience. And one of the earliest and one of the most commonly utilized definitions for resilience is that it is a dynamic and evolving process which encompasses the positive adaptation towards any significant adversity. Similarly, there's another definition which says it's the successful adaptation to life tasks in the face of social disadvantage or highly adverse conditions. This is a little bit more complicated, and but the common thread which connects both these definitions is the usage of two words, adaptation and adverse conditions or adversity. And adversity means that it is a situation which you are unhappy about or it's distasteful. And also it is something which is usually associated with misfortune or calamity or distress. Now, when we start our careers in healthcare professionals, as professionals, be it doctors or nurses or anyone else, we look at life journey and we know that it's a long, arduous process, and we hope that in the process of traveling, we're going to have beautiful scenery and our pathways are clear and everything is hunky-dory, all is well, and we will reach our destination safely, securely, and comfortably. But the fact remains that it is never a reality. It's only a desire. Reality is that there are certain sections of the road which are arduous, which are treacherous, which slows down our progress, which sometimes damages our vehicles, our health, so on and so forth. So that is the fact, and we need to make sure that we understand the reality is such that our process of the journey of life is usually associated with some kind of a problem. And resilience is supposedly the innate attribute of the emergency physician. Well, let's look at these few words. Let's look at innate. What does it mean? It means that it is inborn, it is present in us, it's congenital. If we say that, then does that mean that if somebody does not have it for some reason, because as we have grown up and we find that we don't seem to have resilience because we are unable to face the problem of adversity, the question which comes to your mind is it obtainable? Can I somehow procure it one way or the other? Attribute actually is also the same. It's a quality or feature which is regarded as an inherent part of something. Attribute is a noun, and if you look at innate, that's an adjective. Basically, they mean the same thing. They just mean that it's supposed to be born within you, it's supposed to be in you. When I look at myself and I look at what are the attributes that I have as an emergency physician, first and foremost, when I was trying to enumerate, I realized that the first thing is that I am an adrenaline addict. Yes, I started my career as an emergency, as a surgeon. I was on the faculty of general surgery in the medical college setting. But then I found that the life became too monotonous. I wanted the rush of adrenaline, and therefore I went into this specialty of emergency medicine, and there's been no turning back. And when I look back, yes, I started my exposure to emergency medicine in 1991. So that makes it 30 years. So 30 long years has been the journey for me in the specialty of emergency medicine. And when I returned back to India, and I knew that my guiding light, the slogan that I would go by is to save lives. Yes, that's what I always stood by. And I would stand against people. I recollect standing against a professor. I was only an associate professor at that time when I came back to India after my training. And there was the senior professor of radiation therapy who was very unhappy that I had resuscitated a patient with terminal malignancy. So the question I had for him is, do you have a DNR? Do you have a certificate? Have you obtained the permission? Because when this patient came in extremis, I had to do what is necessary. I had to intubate him, I had to give him what is required, and I have to save his life because that's my guiding light. I also realized that one of my attributes is that I have very poor self-awareness when there is a life-saving intervention to be done. One of the times when I had a blood splash, I've had blood splashes many times, but one of the times when I had a blood splash from a HIV positive patient was when I was teaching my trainees how to do awake intubation in a patient who required it. And lo and behold, my face was against the tube because I was listening. And yes, I had a blood splash onto my face. I'm not sure whether it also touched my cornea, but the fact remains that, yes, I have very poor self-awareness during life-saving intervention because I think of the patient only and I don't think about myself. That is an attribute which is within me. I also have a process of continuous learning and improving because even today, I've had the opportunity through Sandeep to sit down and do a little bit more research into resilience and how to go about looking at it. I am a goal setter right from the beginning. It's an attribute of mine. I've always set goals for myself, for my department, for my students, for my trainees, for everything. And yes, I do have resilience. I do have resilience, yes. But is it innate? Is it an attribute? Well, what I discovered is we have all been blessed with an equal dose of it. Inborn, yes. I read a very interesting article which says, it's titled as Understanding Resilience. It comes from the US. Gang Wu has written many papers on this, and he and his associates printed this article, which is very interesting. And what he talks about is that there is an internal milieu within us, which is governed by the hypothalamus pituitary adrenal axis, and that is the one which is responsible for the flight reaction and fight. So therefore, the action is brought about, and it is brought about by the transmission of certain endogenous humoral products, of which neuropeptide Y is one of the important ones, because it causes anxiolysis and it also promotes a protective response within the body. So there is action, there is transmission, and there is modulation. There are two genes which actually govern the HPA axis, and these two genes can be modulated, and that particular field of study is not called genetics. Genetics deals with genes, obviously. Epigenetics is basically a subspecialty which deals with how do you modulate the genes or the DNA molecule without altering the DNA sequence. So therefore, there is something called as methylation. I know that I'm going a little too deep, but it tells you that at a submolecular level, there is a possibility that we can influence the susceptibility of disease conditions, malignancies. So there's an exciting world ahead of us. And the bottom line is that, yes, there is also evidence which has been published, which shows that children who had extremely stressful environment during their early years of life have shown that there is a lowered resilience for those who do not have the stressful environment. Children who have grown up in a peaceful environment do not have that much of a resilience, have more resilience than the children who have had a very early stressful environment. And so therefore, yes, apart from the fact that we are all blessed with an equal dose of genetic capabilities to handle, what do we do? What we have, if it is insufficient, if I feel that the resilience that I have is insufficient, how do I go about augmenting it, strengthening it? So is that possible? Yes. This is what resiliency research over the last 2 decades has shown. Resilience, although it is innate, has got a capability of being strengthened or being augmented. And it can be cultivated if we have not yet woken up the dormant gene within us. I want to introduce to you a person whose name is Viktor Frankl, and he is an Austrian neurologist who lived during the time of the World War II. Being an Austrian Jew, he was actually remanded to the Nazi concentration camp. His family, that is his wife, his mother, and his sister, all 3 of them were gassed and exterminated. Victor had to live in the concentration camp for about 4 years, where he suffered, and his descriptions, which I could read, are amazingly put together in a book which he wrote. It's called as Man's Search for Meaning in English, and it is something which he dictated to a person who was writing it down over a period of 9 days, and it was printed to begin with was 9 million copies, and then subsequently 12 million copies is what is written on this particular edition that I was looking at. And when I looked at excerpts in that, what Viktor Frankl talks about is when we cannot control the circumstances, the realistic pathway is to pursue and control our attitude towards the circumstances. So when we cannot control, what we need to do is learn and cultivate a habit by which we can control our attitude towards the circumstances. We all know about this. Failure is not an option. A very lofty ideal which was set up by the NASA. And finally, this slogan had to fall on its face when there was a failure of Apollo 13. Everybody knows that. The whole world knows about it. And that's when reality struck them. And they understood that failure is not an option, yes, but it is mandatory. Anything which functions will fail, and there is a possibility that it can do so. The option, however, is whether we are going to let that failure be the last thing that I am ever going to do. Am I going to stop with that and say life is over, or am I going to go on knowing and devising a method by which I'm going to overcome this failure. And by the way, NASA today has got a very robust resiliency training program because they have understood that failure as an option is a lovely idealistic slogan to have, but it is not realistic. Now, I want to spend a few moments on stress because stress is the one which is the outcome of any adversity. First and foremost, when do we get stressed? First is when there is a demand resource imbalance. Today, we have heard so many speakers talk about what exactly happens when this occurs, and I don't want to go into it. You are aware of it, so I don't want to talk about that. Unrealistic goals. Yes, we do set unrealistic goals, and the younger that we are, the more unrealistic and idealistic are our goals. Way back in 1997, yes, 97, when I was invited to the United States to give a lecture on trauma systems in India, I had the opportunity to go and visit the Adams Cowley Shock Trauma Center at Baltimore in Maryland. So I was sitting together with a bunch of young trauma surgeons, and the discussion over coffee in the cafeteria was about open thoracotomies. So one of the senior residents said, well, I can crack open a chest in 52 seconds flat. And then a slightly junior person says, oh, you can do it in 52 seconds. Wow. I'm not able to do it faster than 56 seconds. And I'm sitting and wondering, what are they talking about? I have been a surgeon. Yes, I have opened a few chests because we had to do esophageal surgery, but they're talking about in seconds. And I haven't even done a single open thoracotomy at that stage. Yes, I had not yet done. Now, did I set that as a goal? No, I wouldn't, because it's unrealistic. 52 seconds is possible in a trauma center, but it's an unrealistic goal. And if I had pursued that as my goal, I would have been a nervous wreck. Lack of control. That's another thing which stress causes, and stress also is a sequelae of lack of control. And this is what we heard about some of the other speakers who spoke earlier, how they lost control over many things which were beyond what they could do because the situation was such. The last one, which stress causes is, or stress is a result of, is the lack of meaning. One of the things which happened to me when I was in the UK working as a consultant in emergency medicine about 8-9 years ago was the introduction of the 4-hour targets. Now, before that, emergency medicine was this fantastic specialty where we saw the patient, we investigated them, we made the diagnosis, we initiated the treatment, and gave a well-packaged patient to the clinicians to take over and continue treatment. From then, because of political interference, came in these 4-hour targets where the government had promised the public that there will be not more than a 2-hour wait and every patient within 4 hours will be sorted and sent to the wards. So therefore, there was a little bit of a clash in idealism for me between practice and protocol, and that really caused me a bit of stress. Thankfully, I had to leave the country and come back because I've had enough of that, because that's not something that I trained myself to be. So these are some of the characteristics which stress can cause and also can be a consequence of stress. Now, the targets of stress, where does it strike? How does it strike? First and foremost, stress in me causes a problem, an obstacle with my domestic relationship, with my children, with my wife, with my surroundings, my friends, and you know what I'm talking about. All of you have experienced this, especially during these seasons when you have had quite a significant strain which has occurred to your family relationships and friends and everyone else. Second, also it causes stress among co-workers, because quite often it is easy for us to have something I'll touch upon a little later, and that's called a self-pity, and we begin to compare notes. How is our boss treating me in compared to others? How is that person treating me? And stuff like that, where you begin to compare yourself with others. The next one is, how does stress directly affect me? First and foremost, there is enough publications now which shows that there is a decrease in immunity. When there is stress, there is definitely a decrease in immunity. There is a decrease in your memory power, which affects your memory and judgment. And thirdly, it has a direct consequence on cardiac function. So therefore, you see, not only does it affect self, it also affects the people that you love and you care for and the people that you work with. So therefore, given that, what were the changes that I experienced during an adversity? And to me, one of the biggest adversities that I've had is something which I will turn the pages back to take you to the tsunami in 2004. Yes, because we've heard enough about COVID, and I want to take you back to the largest adversity which affected me, and that was the COVID season. That was the tsunami, the time of the tsunami. First and foremost is the fact that suddenly you realize that people and institutions change their behavior completely towards you. See, 2004 is one of the early years of emergency medicine, and we were slowly trying to establish ourselves and make ourselves known to everybody. But still, people considered you as, yeah, I don't know why he shifted from surgery to emergency medicine. I don't know what these guys are doing. What do they train in, etc., which I'm sure many of you are experiencing, because when you work in hospitals where the staff, the faculty especially, and your co-workers in other departments do not realize your value, you will find that there is this animosity which develops. But in the presence of an adversity like the tsunami, everybody looks up to you. They change their behavior completely. The institutions come forward and say, take what you want, do what you want. People, everybody comes together to help you. Secondly, we ourselves, like I myself, knew that I was pushing myself to the maximum. I was able to work very long hours. We went as a team of 10 members in 2 vehicles, and we worked for 2 weeks on the shores of the Bay of Bengal, where the tsunami had struck. We were right there in the middle of it, and we were busy. And I will talk about a few things as we go on. And one thing I realized, that I was able to work. I was able to shift my gears rather quickly and reach the peak of my performance, which I could sustain for a long period of time. The next thing that I look back and see, that I was reaching for feedback. Until then, I thought, yes, I knew about emergency medicine. I had trained in it. I had studied about it. I know everything about it. But here was an adversity which I had never come across, never encountered. I'd only read about it in the books as part of my training when I was a registrar in Australia. But I had never experienced it, nor I have been a part of an adversity of that magnitude. So therefore, I seek counsel, which I did. And I also realized that, yes, when I left CMC and came across to Nagapattinam to be there, I had set so many goals, and they were all idealistic goals, because the goals change every day. They kept changing as the days went by. As we began to learn, as we began to understand, I became more and more flexible. So therefore, these are all some of the changes which I have experienced. And when we are team leaders in the emergency department, we are expected to stand firm in the event of any adversity. We are supposedly firm, resolute, resilient. We are not supposed to move at any stage. And there were some interesting papers which I came across, and which talk about how exactly do we as leaders go about looking at it. This I am speaking not only to the leaders of emergency medicine today, but I'm also speaking to the leaders of tomorrow. Because I've always maintained with my students that I did not train them to become emergency physicians. I trained my students to become leaders of emergency medicine. And it's evident, you see that, it's right there. So therefore, we had set goals which were realistic, and we have achieved it. So therefore, for team leaders, there are a few things that I want to talk about. First and foremost, remember, you have a title called HOD or whatever you may have.
Right.
But that title is only given
Right.
to you. Some mic is on. Can somebody turn off your mic, please? Thank you. That title is given to you only when all is well and everything goes on well. But in the face of a chaos or a confusion or a calamity, others rise as leaders. And that is an opportunity for others to also become leaders. Now, how exactly is your leadership style? Are you like a cowboy or are you like a shepherd? Now, a cowboy is somebody who drives cattle from behind. So do you drive all your people, all your trainees, all your registrars, your co-faculty? Do you stay from behind and drive them, or do you lead them like a shepherd does? The shepherd walks in the front, and the senior sheep walk just behind him, and all the others follow. So therefore, we as emergency physicians, what I have learned over the last 30 years is that I need to lead by example. If I show the way things have to be done, if I lead the way, if I walk with my team rather than walk behind them, I find that the leadership becomes much more significant and has much more meaning. And I also realized when I was handling the tsunami, there are times when I need to sit back. I need to sit back. I need to listen to others, because there are others who can lead, who can take the initiative and help out to fill the lacunae which I was lacking. And the resilient leader always needs to see challenges when others see as obstacles. Yes, we have to see them as challenges. And we have to help our colleagues to convert their vulnerabilities to strength. Here, I want to take an example of one of the emergency physicians whom I had selected to work with me, and he came up and he admitted and said, I have one particular concern, and that is I am very hesitant to do CVP lines because once I lost the guide wire. And since then, I am very, very reluctant. So I said, not to worry. What you have done is not something which will condemn you for the rest of your life. Unless you've had failures, you're not going to get better. And we are going to put CVP lines together. Let's do it. So together we put lines until just a couple of months later, after having done around 10 or so, he was able to teach others. So therefore, we need to help our colleagues. A true leader does not condemn, but instead he converts vulnerability to strength. What next? Yes. So I talked about stressors, and there are 3 stressors which are very interesting, which are actually papers. One is called a performance anxiety. Okay, this is very interesting. This actually was studied among musicians, and people also call it a stage fright. Okay, this is something that we know what happens. As I said earlier, emergency physicians and leaders, especially, or even emergency physicians, are all in the glass house. And the glass house becomes completely eliminated in the presence of an adversity, when patients start pouring in, when everybody starts looking at you and you are worried about your performance, especially when you're leading for the first time, especially when you're handling an adversity which is so big in magnitude which you've never done before. So performance anxiety is something that we should be watchful about. And this is when we seek the help of others, and they will be able to support us and help us out. The next one is called as vicarious trauma. The meaning of the word vicarious is substitutional. You have heard about this in legal medicine. It's called vicarious responsibility. As head of the department, I am responsible. I substitute for the work of everybody which is being done in my department. So if there is a medical legal problem, I also will be questioned. I also need to be aware of what exactly has happened. So that is vicarious responsibility. Similarly, vicarious trauma deals with the situation where you are taking the responsibility or substituting yourself when there is an adversity. And the signs that you begin to manifest is that you begin to experience lingering feelings of anxiety, rage, sadness when you look at the victimization which has occurred. This is something which has been expressed very clearly way back. Viktor Frankl actually talks about this in his book, but I have personally experienced it where I became preoccupied with thoughts of patients beyond the work environment. This happened to me during the tsunami. Now, I did not realize that I was having PTSD. I had post-traumatic stress disorder, which I experienced for more than 6 months. Why do I say that? Because I could see myself doing what I was doing. And suddenly I would wake up in the night, sit up in bed, because I am busy disposing dead bodies, because I was involved with the team over there in the village where we were actually collecting all the dead bodies and putting them all together for identification. So therefore, this went on for me, this nightmare kind of a problem went on for me for nearly 6 months. So therefore, I was actually preoccupied with thoughts of these even beyond what happened. So that's actually vicarious trauma which now has been spelt out and termed so. The next one which occurs is what's called as compassion fatigue. This is something which I don't know whether you have experienced, but many of the people who work in ICUs tend to experience this. What exactly happens is that each one of us is blessed with a gas tank, a petrol tank, which each one of us has, which is full of compassion. So when we are stress-free, when we don't have a problem, we have a compassion tank nearly full. So we are able to dish out any amount of compassion to the people that we need to. It may be loved ones, it may be people in trouble, it may be people in the society, maybe our patients, whoever. But if we are undergoing a continuous period of adversity where you are dishing out compassion all the time, there is a very heavy risk that we will undergo a change in us where we become indifferent and we become numb to personal and professional lives. So therefore, we have to watch out for this. If we find that we do not have time for compassion for others, that's the time when we need to alert ourselves that yes, we are not coping very well. We are being robbed of our mental strength. And my mental strength, for example, can be robbed by me by 3 beliefs. The first belief is that I have unhealthy beliefs about myself. Being sad is normal, is physiological, it is acceptable when you're sad. But when we begin to have self-pity, where we say, why did this happen to me? Why is it that I am supposed to do so much of duties when nobody else seems to be doing? Or why is it that people don't understand that I have a disability which prevents me from doing so? What we need to do is to convert that why me into why not me. Because remember, an adversity has affected not only just you, it might have affected the whole department. And that's why you have to walk the extra mile sometimes. So we have to convert. And this is what Viktor Frankl talked about. What is your attitude towards the circumstance which has happened? So instead of having self-pity, yes, we need to figure out ways by which we can do things different. And we need to divert the focus from the problem to the solution. Third aspect is, first one we talked about unhealthy beliefs about myself. Second, I need to talk about what is it that I feel about others. And this is especially when I was a junior doctor. I remember when I was in surgery and I had young children. No, we had only our elder son was there. And I was feeling the stress, having to do extra work as an assistant professor in surgery. And at the same time, I need to give time for the family. And when I was asked, can you come for his birthday? Can you come for mom's birthday? I said, no, I can't. I can't because I have to work. And I have been told that I have to work because I don't have a choice. But then thinking back now, did I ever talk to anyone else? Did I talk to my boss and ask him, sir, I have my son's birthday. Would I be permitted to go for a while? I will do the duty for someone else or something of that sort. We begin to have unhealthy beliefs that there is no option for us. No, there isn't. We should ask. Third is also something which I want to talk to, especially the young people who are listening to this lecture. Sometimes we believe that if I work hard, if I work very, very hard, I will get the recognition which I deserve because I deserve that recognition. Not really. People, let me tell you, to work hard is not an option. It is mandatory. You are expected to work hard. That is default. So therefore, do not believe that, you will get it from the world. That is an unhealthy belief that you have about the world. So therefore, in order to make sure that I augment my mental strength, in order for me to becoming stronger in my resilience, to strengthen my mental health is mental strength is very similar to strengthening my body. If physically I want to build up my muscles, it is not enough for me to just go to the gym. If I go to the gym, I build my muscles, but that's not enough. I also need to make sure that I have a proper diet. I need to cut the unhealthy foods and eat the foods I need to help. I need to help myself. Similarly, to augment my mental strength, not only should I have positive beliefs and positive thoughts, I should also remove unhealthy thoughts about myself, about others, and about the world. So when you look at a glass of water, do you see it as half empty or do you see it as half full? Now that's a question which is necessary, because when you have to navigate through very tough times, there are three philosophical strategies which we need to undertake. First is we need to understand something very clearly, that adversity or hard times and unpleasant times is only temporary. It does not also discriminate. It doesn't cause you something and doesn't cause something else for somebody else. It's the road. Everybody travels on the road. There is a bit of road which is bad. It's temporary, it's short. I just need to go through this and then I'll be okay after that. The rest of the road should be all right. So the three philosophical strategies I need to undergo is to accept that suffering is part of human existence. Only in the fairy tales we have beds of roses. In real life, it doesn't. We need to accept that suffering is a chapter. It is not the whole book. The book of life has got many chapters in it. And one of those chapters is suffering. And we need to remember that not as why me, not have self-pity, but we should think, why not me? Everybody else is suffering. Everybody else is having a problem. So therefore, why not me? This is an interesting thing which I came across. Negative emotions, bad things, which we think about ourselves and others, is like Velcro. It just sticks. The harder you try to pull on it, it sticks. It doesn't go. Whereas positive emotions are like Teflon. Positive emotions about adversities will make sure it doesn't stick to you. It will just flow away. And thirdly, I need to remember that I have to modify things that I can change. Whatever I can change in an adversity, I should change. And whatever I cannot change, I need to accept. Otherwise, it's going to cause me deterioration in my mental strength. So therefore, first is to make sure that exercise. I always talk about this because I personally have experienced this. If you have some me time for yourself, where you will go and physically strengthen yourself, it gives resilience not only to your body, it gives you the immunity that is necessary because you have expended enough endorphins and you have built yourself up. It also gives some time for you to think for yourself and to introspect and also to strengthen your mind. Second is be compassionate to self. Quite often we really run the race. We run it so hard that we are injured and we have no time to heal. So make sure that you're compassionate towards yourself, especially when you're setting goals. That's very, very important. Diverting attention. Yes, don't think about work all the time. There are times for yourself. For example, what the astronauts who are in space, especially those who are, circling the Earth or who are on long space journeys, one of the things they tend to do is each one of them has got a camera and they all take photographs. That's the time they spend time doing things for themselves, not for NASA or this space station which has sent them there. Establish realistic goals, not idealistic goals. Idealistic goals are good, but if you find that they're not working, rearrange them, reorganize them, revise them. Set realistic goals. Also cultivate flexibility and curb expectations, because this is especially those who have a personality like mine. I am a person who was very, very rigid. Yes, I was very rigid. And I have read that, Aesop was a person who wrote a lot of fables, which all have got a significant moral in the story. And fable number 70 talks about the oak and the tree. The oak tree is a very, very strong tree, stands really tall, firm. In any adversity, it's not a problem. It will stand without anything. So it looks down and talks to this very humble reed. the reed which is small, which is bending, which doesn't stand like the oak. And then the oak says, hey, why are you so humble? Why are you so flexible? Why can't you stand up and be proud of yourself? So the reed says, well, this is the way I'm made. And then the oak says, well, I am the way I am. And soon after that, there is a cyclone. And then the cyclone occurs. That's when the oak tree breaks, because it is unbending and the powers of nature are such that it is able to lift it and break it. Whereas the reed is able to bend, be flexible, and therefore able to withstand the adversity which they have both encountered. So therefore, flexibility and being malleable is something which is we have to accept, which I did learn as a lesson when I was experiencing the tsunami. Because before that, of course, I come from a surgical background, and you can imagine how we are as surgeons. So I had to relearn many things in life. So how do I build up physician resilience? Physicians are having many stressors, especially in the presence of adversity. We heard that very clearly. We have challenges in the profession. Say we as emergency physicians are used to controlled chaos. We can work in a chaotic environment because we thrive in it. But when it goes beyond control, when we lose control, when we are overwhelmed by the chaos, that's when it becomes a stress. Also, we find that at that time there is a change in organizational structure and function. If you remember one of the previous speakers who was talking about it, I think it was Nitin who spoke about it, when he said that he found that physicians were not helping him to move his patients in planning of admissions into the hospital. So therefore, you lose that clinical autonomy. You witness a change in organizational structure. And these are all some of the stressors that we experience in adversity. Poor ergonomics, yes, that's something that is very difficult. And also, there is something which nobody touched upon, or I don't know whether I missed it. You know, when we put on the astronaut suit, which we do when we work in COVID areas, yes, we need to make sure that we empty our bladders and everything else that we need to, because we're going to be wearing it for a long time. And if you're going to be working in hospitals where you have 12-hour shifts, please make sure that you are not running to the toilet too often. But at the same time, these are all difficulties which we are experiencing all these things. So therefore, what do resilient people do? First of all, they share their failure. They do not hide themselves. And that is precisely what has happened today. You heard so many people, the speakers who before me who spoke. They shared their failures. They spoke about their difficulties, the challenges which they include. They did not hide. No, they didn't say everything was fine, we came out well. No, they didn't. They are the true resilient people. They are the true leaders, because they are able to share their failure. Second, resilient people always accept a margin of failure, because nothing is perfect. No system is perfect. And we also need to stay connected with mentors and role models. This is precisely what Sandeep has done. He has probably not realized, but he has established this fantastic opportunity for all of you who are listening to be connected with mentors, to relate with their experiences, and also imbibe from them characteristics and methods of coping, especially if you find that the amount of resilience that you have is inadequate. So therefore, thank you, Sandeep, for giving this opportunity for so many people who have done this so well. And of course, seeking feedback. That's something which we do, and it's part of disaster medicine. You know that the last step in disaster management is where we do debriefing. That's precisely what we need to do with our team. And that, let me tell you, significantly reduces the PTSD, which people like me have experienced, because there was nobody to whom I could go for a debriefing. Everybody debriefed with me, but I was left alone. So this is especially important for leaders. Please make sure that you talk to your mentors, have ventilating times when you can talk it out, when you discuss with people and find out how things are. I'm going to end now very soon, and I want to talk about something which I did with my children many years ago when my elder son was, I think he was 8. and my younger son was 3 years old. So I talked to them about a bedtime story which continued for 2.5 years. It was about the Fabulous Four. Actually, I took this from an Enid Blyton book which I had read when I was a small boy. But I made up the story on my own. It's actually four people who have an airplane crash in the middle of the Amazon jungle, and they had to travel around 800 kilometers to reach civilization. So therefore, they go through this process, and I had to invent and make up a story every night for 2.5 years. It was a fabulous experience. Children loved it. But what did it do to me? Well, what it did to me first and foremost, was to emphasize and reinforce within myself that I have to work as a team. I have to learn from one another. And second, I have to be optimistic because, oh my God, the story was so complicated and so dangerous and so thrilling. But we had to be optimistic, right in the milieu of changes. And the only goal was to lead towards destination. You stop, you starve to death, you die. And of course, adversity is the norm because there were snakes and pythons and cheetahs and tigers everywhere. Adversity is the norm. To plan and proceed is the motive. So many lessons we have learned as we go along. So therefore, it cannot be underemphasized, or it cannot be overemphasized rather, that building up all these things and having an opportunity to learn through our own experience is something which is very, very good. So I will leave behind 5 mantras with you. First, I should augment my optimism. If I'm not optimistic, I need to learn to exercise myself and my mental strength and make sure that I learn optimism. That's very, very important because we need to focus on the greater good to the greater number. Yes, our systems are far from perfect. We know that, we see that in WhatsApp, we know that when we have handled it ourselves, how imperfect our systems are. But remember, you as an emergency physician has been working for the greater good to a greater number. Look at the number of people you have saved. Look at the number of people you have directed in the right manner. Look at the number of people you have counseled. So therefore, you have done a fantastic job. Focus on that rather than the imperfections. Third is that I need to train my attention on today, now. Let me not look at the past or look at the future, because if I do that, I find that I get bogged down with negative thoughts. Negative thoughts are something which are going to be impedimenting my progress. It is an impediment. And I need to take care of myself, physical, mental, social, spiritual. Every aspect of it is important. I need to make sure that I take care of myself. Lastly, is to cultivate a higher thought, compassion, gratitude, acceptance, and forgiveness. So these are many things which, and in fact, if I can think of an example of this, I can think of Mother Teresa. I mean, she was a person, when people came and asked her, Mother, how come you're working in this kind of an environment where there's nothing available and all these people are dying? You are looking after a home for the dying. How is it that you're able to see this? And what she said was that in every person that I see, that I take care of, I see the face of Christ. So you see, she had a higher thought. She was able to look at compassion in a totally different way. So therefore, let us devise our own methods by which we can handle these adversities. Because the fact remains that, there are about 300 people who are sitting and watching this. If I give each one of you a whole lot of nylon threads of different colors and tell you, I want you to make a fishing net out of this. Yes, all of you can make it. But every fishing net that is being given is going to be a different color. Why? Because the way you make the net is going to be different to the way your neighbor is going to make. The number of stressors, the number of adversities that you have is very different to the next, and the way you handle it is going to be totally different. So therefore, based on what I have said so far, try and remember some of the things that I've talked about, and if possible, try and formulate a path for yourself, a method for yourself. Because what we need to remember is that as emergency physicians, we are going to be faced with disasters. We are going to be faced with mass casualties, large numbers of patients coming in. Yes, we cannot change that, and we thrive in that environment. I cannot change the direction of the wind, but I can adjust my sails of the boat that I am sailing in order to reach my destination. So each one of us has to devise our own method so that we will go ahead, and what we have to do, being resilient in the face of all the adversities, let us go ahead and save lives, which is what we were destined to do, which we are doing successfully today. Thank you, ladies and gentlemen.
Thank you, Dr. Suresh Dev. That was an excellent exposition, because I think it's worthy of being a keynote address and blockbuster. In the interest of time, I'm sure I'll not be taking any questions, but I want to just say that you touched on multiple facets about ability and strength, situations and adversity, the challenges and mental strength, and also you've given some strategies how to cope with them. And each time you rendered a very worthy lesson, sir. And I would not take much time on this, but I would like to suggest and give a call to all our colleagues in emergency that this is one talk that you need to probably view at regular intervals, because it is illuminating, uplifting, and is much needed. Thank you so much, sir. I learned a lot myself, and I will promise you that I'll put some of the lessons to use in my own too. Thank you so much for being such a wonderful speaker, and I think this conclave has been so much richer because of your presence. Thank you, sir.
Thank you, Vijay.
Thank you so much, sir. Listening to you is always such a pleasure. And I really feel so proud that I've inherited all the attributes of emergency physician from you, sir. And you truly continue to inspire all our budding emergency physicians who are present here. Thank you again so much, sir, for the brilliant session. It was truly an eye-opener in so many aspects. Thank you, sir.
Thank you.
Now, I would like to invite the brain behind this conclave to talk on facing the pandemic in mountaineers' way, fierce combat between passion and fear. So Dr. Sandeep Gore, who definitely needs no introduction, he's the Director Emergency Medicine from Fortis, Vice President West Zone SEMI, and a passionate mountaineer himself. He has summited Everest and is also a firm believer of let your passion burn brighter than your fears. So let's listen to him. And moderating this session will be Dr. Ravindra Rupwate. He is a veteran chest physician and a trekker who also knows both the sides, medicine and mountain. So both of them are like truly rare species. So request you to take over, sir. Dr. Ravindra.
Thank you. Sandeep and myself are working together for almost more than 10 years at Fortis Hospital, Mulund, and we are more friends because of our passion for mountaineering, and we are doing a lot of treks in the Western Ghats together. Sandeep has a distinction of climbing Stop Kagri Peak last year, in spite of this pandemic and all those things. And I'll request Sandeep to start, and then I'll give the concluding remarks.
Yeah. And just before you told that I have submitted Everest, I submitted Stock Kangri and I went up to the Everest base camp. I submitted Kala Patthar.
I mean, the base camp itself is Everest for us.
Oh, yeah. In your perspective, it's okay.
Yes.
Yeah. Yeah. So now I will share my slide. Okay. Who is sharing the slide right now? Yeah, I think sir is sharing this slide. Who is sharing right now? Share downloads screen.
20 minutes somewhere.
You are the last. Then I give the remarks and then he tells the.
Open. Hello, Shweta. I think it's taking time to open this screen. I think. Is my screen visible, Shweta?
Yes, yes, it is visible.
Okay.
Just put it on the slideshow mode.
Yeah. Okay. So I'm going ahead with the last talk of the day, the facing the pandemic in mountaineers way. And I'm going to talk the fierce combat between the passion and fear. So this video, I will take you back in August.
It's a crevasse. It's a crevasse.
I accidentally almost fall into inside, but luckily survived by the grace of the Shambho Shiv Shankara. I accidentally fall inside it, but these two gentlemen, Mr. नाम बताओ सर भूल गया सुधांशु and Dev saved me timely. Thank you for this, gentlemen.
Okay. So the story was that when I was going towards the summit of the Stock Kangri, there was a hidden crevasse and I accidentally fall into that crevasse particularly. And falling in the crevasse is a terrific experience. It's a life-threatening thing. And after these two co-climbers supported me and I came out of that crevasse actually. But that was the ultimate fear time for me. In my 40 years, when I was scared, that was the day. But that fear I overcame. I decided to go and submit this Stock Kangri and not to decide to come back. So fear is not abnormal thing. Fear is there for everyone. And what is meant by courage? Means courage is not the absence of the fear, but it's a triumph over the fear. So what is a passion? Now I'll talk about the passion, something that you are strongly interested in and you enjoy, strong and barely controllable emotion. We all have a passion of saving life, and that is the reason we are in emergency medicine as a specialty. We have a passion of high altitude climbing. That is also the only passionate people go into the mountain where the risk of life is there. So the most important step is the beating the fear factor and building the courage. So how to build the courage? One person requires passion. What he is doing, he requires passion. Without passion, things are not possible. And you require a mentor. Means where you are practicing emergency medicine, when you are climbing the mountain, you require a mentor and you require guidance. You require family support. Suppose you are going at trek or you are working duty in COVID, and if family member says, if agar tujhe kuch hua to hamara kya hoga? Your courage will come down. So for the courage, family support is very much required. Then requires planning, preparation, gaining the knowledge. Gaining the knowledge means we have to gain the knowledge of the terrain. The same way we have to gain the entire aspect of the COVID and we have to train ourselves on that knowledge. Know the equipments and infrastructure. Here we should know in mountaineering, we should know the ice axe and crampons. Whereas in this COVID management, we learn how to use video laryngoscope, how to apply the ventilator strategies and newer aspect of the ventilator management. Achieving the skills and techniques and performing it on the and practicing it, developing the temperament. In high altitude monitoring, there is always fear of death. The same way when you are giving a medical care in the COVID, you will have the same feeling. So that temperament helps. Planning on a paper means everything, means what to be done or what not to be done. There should be a proper planning and there should be the protocols. And like you require practice. You require practice in climbing also. You require practice in applying your skills also. And whatever you learn, knowledge and skills, you have to execute, and you have to improve through the experience. The knowledge or skills will improve through the experience only. Maybe it's a mountaineering or maybe it's a medical practice. Now the preparation. In first week of February, I got a call from Ministry of Health and Family Welfare, and they requested me to do the training of NDRF Jawan at Mumbai airport. That was little bit shocker for me because I can see the immediate threat was there to the country, and we have given the NDRF Jawans training and before they get deployed into the airports. At the same time, in February itself, me and my team started to gain the knowledge about the COVID. Whatever literature we learned, some of our friends were in Japan, we communicated with them and we tried to know the particular how the virus and how we can face this pandemic and which kind of skills will help us to overcome this. First thing, we developed the infrastructure, means we have made infrastructure such that COVID and non-COVID patient will not mix. Then we created 4 negative isolation room. All 4 negative isolation room have ventilator, multi-para monitors, and that helped us to preventing mixing the COVID patient from the non-COVID patients. Then equipments, we procured some video because some of my friends in Japan told that video laryngoscope will prevent the infection. So we obtained video laryngoscope. It's a high-end video laryngoscope with anti-fog technology. We also obtained a aerosol box and we practiced how to intubate by using the video laryngoscope in the aerosol blocks, and we practiced the same throughout the 1.5 years. And then availability of high-end mechanical ventilation and training on the mechanical ventilation strategies for all the doctors. It's a very important thing because improper application of mechanical ventilator can be dangerous for the patient. So adequate training on ventilator strategy was important, and we trained our doctors and nurses on the same. Then we procured this new thing also, the high flow nasal cannula, and we started proning the patient from emergency department itself. And these patients are really sick, and to transfer this patient on ambu bag was an impossible task. So we procured some portable ventilators. And in this pandemic, we used point of care sonography as a visual stethoscope. I think we started using echo as a stethoscope in this thing, and due to this thing, we could diagnose many myocarditis, pericardial effusion, and pulmonary embolism cases during this 1.5 years. And we have upgraded our point of care testing machine. So infrastructure training is different. Procuring the equipments and training on that is different. And then we started training in early March, training on the emotional quotient, because emotional quotient is quite important. What is the emotional quotient? Understanding one's own emotion is a very difficult term. It's not as easy as written there. To know what you are feeling is very important. If you meditate, then only you will realize what feeling you have. So it's not simple thing. We have to practice and know that what kind of feeling you have and what kind of you are feeling. And harnessing one's emotion. In this pandemic, we have difference. We have rage, we have frustrations, we have some anger, but we have to harness that thing. So harnessing one's emotion is another difficult task. And the controlling of emotion of other for the positive purpose means you have to control the emotions of your team members. In last 1.5 years, I frequently used to communicate with my team leaders, and we looked as the entire team as a family. Means we have looked after the well-being of the family members of the team members also. So these 3 important things are necessary to increase the emotional quotient. And emotional quotient, I think that emotional quotient training we did in early March 2020 helped us to go through this first, second thing. And I can see that if third wave comes, we are prepared for that thing. First, we started a triage protocol. We considered all patients coming to emergency department at COVID unless proven otherwise. Clinical evaluation and imaging we did, and we used judicious CT scan and chest there that time. An emergency department management protocol, oxygen for all patients whose oxygen saturation is less than 94%, judicious use of steroids. We avoided to use steroid in first 8 days of the onset of the symptoms. And when PF ratio is less than 150, and saturation is not improving, we started intubating the emergency department. Intubation of the COVID patient is one of the most challenging procedure in medical, because these patients are already hypoxic, and before that, when you paralyze this patient and you intubate this patient, it hardly give you just 30 minutes. So this is a senior person should be there in emergency department while doing this type of intubation there. And blood investigation, we have set protocol of CRP procalcitonin failure with respect to rationals. And we are so aggressive, we started anticoagulation in emergency department itself, whether this patient is getting ICU or what. Then this was the COVID intubation protocol, and this is the same we follow. This should happen in negative isolation room of emergency department. Aerosol box should be there. A rapid sequence intubation means we have to paralyze the patient and sedate. At the same time, you have to use the video laryngoscope. And after, as soon as intubation done, we have to use confirm it by ETCO2 monitoring, and we have to connect that to directly the ventilator. Initially, we avoided using ammobag while after intubating the COVID patient. So this is very important. Then ventilation strategies in ER. Initially, this all patient, COVID patient has ARDS. So our strategy to make and do mechanical ventilation is a lung protective strategy. This was by default. It can be a volume assist control, tidal volume of 8 ml per kg, respiratory rate of 15 to 16, and FiO2 to PEEP means initially we brought down to 40% to 5, and then we adjusted according to ARDS need, ARMA trial scale. And the target saturation we kept is 88 to 95%. Plateau pressure should not be less than 30. This is a lung protective strategy we have applied there. So our goal is that emergency treatment to all. No COVID patient should go from ER to the non-COVID ER. No, if beds are not available, then patient should be fully stabilized and transferred to the other facility safely. Non-COVID patient should not get affected. Neither you or none of your team members should get infected. This was an important goal. I think at this moment also, after taking a bath in COVID, my 50% of doctors are not getting infected with the COVID. I think they have achieved this particular goal. I can say proudly that thing. Then there should not be any problematic issue. These were the goal. And we have achieved this through the efficient triage, resuscitation in emergency department, aggressive resuscitation there, recognizing the deceptive presentation, disposing the patient with diagnosis and stabilization, managing the patient on ventilator till beds get arranged, and if beds are not available, counseling of the relative and transferring the patient to the institute where beds are available. To getting a bed was a big challenge there. So we made this invention. We made some 100 for telephone number, 50% from BMC and 50% from private healthcare. And we used to tell one of the active relative of the patient to call each and every phone numbers. And I think 80% time they could able to arrange this patient. So these particular two big standings reduced our stress by 80% by getting the bed. And this was the invention which is caused due to our necessity. Deceptive presentation, we have saw COVID presenting to emergency department in varied form. It presented as acute stroke, it presented as a status epilepticus. Many patients presented as acute myocardial infarction. We have seen acute limb ischemia, pancreatitis, pulmonary embolism, some 15 to 20 pulmonary embolism patients we caught in a COVID patient. Pneumothorax. Yeah, that means I can see this 3 to 4 patients presented to ER with pneumothorax with COVID. Altered sensorium with restlessness, loss of taste and smell. So you name the deceptive presentation, we have got there in emergency department. So the game changer was there to rapid antigen testing and CT test. Rapid antigen test, and if clinically is suspected thing is, then we use the CT test to diagnose it early. So I think my all doctors, they are able to diagnose what is the normal CT scan. This is a normal CT scan, and what is the abnormal CT scan. You can see this thing. But when we took the help of our radiology team, when we are in confusion, whether it's pulmonary edema or COVID, that time our dynamic radiology department always help us around the clock, making this confusion away. Then uninterrupted, we have kept this uninterrupted non-COVID work. Means primary angioplasty means we can see this door to balloon time we achieved less than 90% in 83% cases. In acute stroke, door to needle time we achieved less than 60 minutes in 90% cases. And 12 pulmonary embolism diagnosed and thrombolized in emergency department in last 6 to 7 months, and 100% survival was there, is there. Apart from that, neurosurgical emergencies were there, medical and surgical and traumas that we handled in a segregated care area. What were our challenges? Pertinent unavailability of the beds, inadequate space. Though we were operating almost 20 beds in emergency department, still we faced inadequate space there. Innumerable inquiries on the phone call. One of our staff used to be always on phone calls to sort of answering the restless relatives. Helpless and aggressive relatives. We have to understand the plight of relatives. They were quite aggressive sometimes, but fortunately my team members exhibited the good quality of communication skills, and we managed this thing very well. And Google patients and social media manipulator and socio-political influencers. That also we have handled quite in diplomatic way. How we dealt with these things? Constant support from our hospital administration team. They were rock solid behind us. Great support from our colleague from the other departments. And team spirit among us means if some of our colleague gets infected and he get sick, we have taken his duties and we have taken his responsibilities, and we made sure that the show will go on. And we tried the best possible professional and communication skills. We did a training in early March on this theme, and fortunately all my team members shown the perseverance without losing the calm. So though whatever I can see, these things are not rosy. The stress is inevitable. So to boost the stress means I adopted one hobby during to boost the stress. And how the stress booster will work essentially in the pandemic, I think I recommend everyone that they should find out one particular hobby there, and it will erase the stressor and it will give a reboot effect. When you are doing a pursue a hobby, if you that 30 minutes and 40 minutes, if you do that things, you will just forget for everything, and your system will get rebooted. So in 40 years of life, I never sung, but I started singing during this pandemic as a stress booster, and good. I have some good number of followers in the Star Mockers, and I'm enjoying this my new hobby, and it really worked me as a stress booster. So the last slide and the last button slide, and it's a very important slide. I would like to say that applying the principles of mountaineering while facing the pandemic. Mental toughness is very much required, because mountains are climbed in minds and then person physically climbs it. So mental toughness is important. So working in a pandemic also, you have person has to be very much mentally fit, and for that one has to improve his emotional quotient. And how to improve emotional quotient, I have discussed in one slide. Strategy is important. The goal is to reach the summit, but how to reach at the summit, that strategy we should have. Who will take which responsibilities, and everyone should be accountable for that thing. Similarly, we are going to face the pandemic, first wave as well as second wave. What should be our strategy? And we made this strategy, and I make sure that our all team is aware about the strategy. And preparation for mountaineering. If we are one is going for a high altitude climbing, he has to prepare for 3 to 4 months. Similarly, for COVID also, when this first wave vanished off, in intermittent time we took for a preparedness, as well as before the previous first wave, we took that time opportunity to prepare ourselves. And gaining the knowledge is a constant process, because initially hydroxychloroquine was considered as a miracle drug, then tocilizumab, then now we can say this remdesivir, and then we can see the plasma therapy is also not result. So different type of clinical guidance are coming, and we have to apply the evidence-based knowledge while treating the patient. So knowledge is very important in pandemic, and knowledge about terrain, knowing the terrain in a trekking, that is also quite important. Equipments, just like I saw the ice axe, how to use the crampon, how to prevent the fall by using the ice cup. This equipment training is required. Here the training of how to use the ventilator, how to apply the ventilator strategies, how to do the rapid sequence intubation by using the video laryngoscope within 32 seconds to 40 seconds. That is very important. Training and communication. So strategies, there should be training on the strategies, and the strategy should be communicated to all these people. And Reiki You have to practice. You have to practice on mannequin how to intubate. Then only you can successfully do that thing within 30 to 40 seconds in a patient who is paralyzed and sedated. Application of knowledge and skill. Only having knowledge is not important. Only having skill is not important. Application of that knowledge and skill is important in high altitude trekking as well as in facing the pandemic also. So we have to improve our skill with experiences. I started trekking 20 years back in Sahyadris, and after 20 years now I have great experience and I can climb far better than 20 years. We started managing COVID cases 1.5 years back, but now I can say this, we have with the experience we are better clinicians. So whatever the experience we should use in our next expedition or next clinical challenge. Team spirit, accountability, and calibration. These are the 3 core principles of mountaineering. Means you have to work as a team. Everyone should be responsible for each job. Accountability means one should give reasonable answer for his acts. That accountability should be there for all team members in high altitude climbing also, expedition also, and in that same applies in while COVID team also. Being the lean is very important. Lesser means you have, if you take a less luggage with you, you will climb higher. And the same way, the protocol of COVID management should be lean. Means unnecessarily you should have a ready reckoner what to be done at what these things. And in our personal life also, losing extra pound and being lean is helpful to prevent diabetes and hypertension and live long life. So being lean is very important. And temperament. Temperament means working under constant threat of fear of death. That is something high altitude climbers have, that type of temperament, and that particular temperament helped me to going through the first and second wave of this thing. And resilience, I think I will not talk about this resilience. Professor has given a great talk on this particular these things. So I won't be talking on that particular these things. And finally, whatever your passion, that should burn brighter than your fears. That passion should be prevail over the fears. This is my team. They are the masked brave hearts. Now I will unmask. They have very handsome and beautiful faces. And look at that. Second wave of COVID also cannot take away their charming smile from them. That is the spirit. And this is my team. And I am always proud of my team that the kind of indomitable spirit they are showing in first as well as second team. And I think the same spirit is the spirit of emergency medicine, and we are celebrating the same. I can say that tough times don't last, but tough teams do. That is important. And we as a team, we are going stronger and stronger. Standing at the foothill, I look up and peaks whisper. It's always further than it looks. It's always taller than it looks. And it's always harder than it looks. So climb up. Take up the challenges. Take up the challenges, grow in the life. Journey of life is always upward and onwards. And I again say, this is the spirit, and this spirit we have to take forward as a spirit of emergency medicine and spirit of emergency physician. Thank you. Summit is the only goal. Thanks.
Thank you, Sandeep, for your excellent presentation. With the purpose of mountaineering, well planning, well ahead, and with a purpose. Focus on the processes and not the ultimate outcome. Knowing your strength with the good doctors and limitations with the newcomer doctors and their training from time to time with excellent equipment backup has made all of us acclimatized to this new environment of the COVID. And we are all using masks on the regular basis. We are doing washing our hands, and now we have entered into a new life of all of us. Okay, so I can say that truly we are acclimatized to the new environment. Thank you, Sandeep, for all the presentation. Any questions?
Thank you, Sandeep, for such a crisp and succinct presentation. It is said that when we climb the mountains, it's not the mountain we conquer, but we conquer ourselves, isn't it? And that holds true for the challenges we faced and conquered during the COVID pandemic as well. So very well presented, and thank you so much again for this brilliant session.
Yes, Sandeep, I would endorse what Shweta has mentioned. I have listened to
many associations and comparisons. Never heard one where COVID is being compared with the mountaineering. It was very good, excellent presentation, good slides, and we really enjoyed the photographs. Thank you.
Thank you, sir. Thank you, sir. It's a big thing. Shweta, you are carrying the last session.
So this brings us to the end of the wonderful session of Emergency Conclave. And I think we had how many hours? We had at least 6-7 hours. We've been all glued to our seats, listening to all the exciting lectures. And it has been such a pleasure to listen to everybody. For the in our concluding session, we have Dr. Manisha, who is the head of the
Medical service.
medical services of Fortis. So I request you to take over, ma'am.
Thank you. Dr. Sandeep, it was really a great journey from mountain to pandemic. I mean, it was really appreciable. And as Dr. Shweta rightly said, like the entire day, whatever 6-7 hours or the time, it was a great feast in terms of information and knowledge. And I'm really proud that in spite of this pandemic, I mean, we could arrange such a successful conclave on account of this World Emergency Medicine Day. So really great. I mean, really great. I have immense pleasure to announce winners of our poster competition. So I think everybody must be excited to hear the names. And the first prize is...
Ma'am, before you just announce the names, I have a little bit of point to share that in a short span of a week, we received almost 15 posters, which was a remarkable, participation. We never thought that we are going to get such a good response for it. I would really congratulate all the participants who took so much of effort in such busy time to, put down all the thoughts they had and the case reports and whatever they had to put up on the posters. And also, I would like to encourage that, in our next sessions, we should have many more so that we can have much more people and much more academic knowledge to share with. So the panel of judges had 3 points in consideration when we decided about who will be the winner. So what was the presentation and layout? What was the relevance of the content to emergency medicine? And how rare and novel was the scientific content which was presented? So depending on that, this decision was taken. And over to you to announce the winners. I'm sure everyone is excited.
Yeah, and the first prize goes to tension pneumothorax from Dinanath Mangeshkar, Dr. Nikita Lakhe. Okay. The second one goes to neurogenic pulmonary edema, Team Hinduja. That is Dr. Arlene, Dr. Kishore, Dr. Buddhaditya, Dr. Mir Shahid, and Dr. Khusro sir. So that is second one. And the third one goes to coarctation of aorta, Fortis group, to Fortis Mulund, Dr. Deep, Dr. Vinith, and Dr. Mario. So I think now the suspense is over. Yeah, heartiest congratulations to all of you who have participated in the competition. And Dr. Sandeep, you want to say something?
No. This the first prize for this thing is 10,000 rupees trophy and certificate. Second, 5,000 rupees trophy and certificate. And third prize is 3,000 rupees trophy and certificate. Like this prize distributions we did.
That's great. That's great. And I just take this opportunity to thank ANVI, HPI, and Society of Emergency Medicine India, along with Fortis Hospital, for their contribution in organizing this conclave. I thank MMC also for their support. And I especially thank Dr. Sandeep Gore and his team for taking the lead and making the conclave successful. I thank all delegates, participants, and like all doctors who registered themselves and just took, like everybody took out time from the such a busy pandemic schedule. So just 2 lines, since it is a World Emergency Medicine Day today. I would like to salute all ER physicians, ER doctors, ER team, and just would like to dedicate 2 lines to ER team. So a beeping ambulance comes in through the door. A beeping ambulance comes in through the door, and everyone rush to aid. And everyone rush to aid. The whole ER gets to work at an extremely ambitious grade. They are the face of the hospital. They are the face of the hospital. In their scrubs, they go to war. And every time when a life is saved, and every time when a life is saved, we know who we are thankful for. Hats off to ER team. Thank you.
Thank you, madam. Thank you very much. We appreciate your words. Thank you.
Thank you so much.
On behalf of all emergency medicine fraternity across Maharashtra, Mumbai, as well as India, thank you very much.
Thank you.
Shweta Srinath.
I request Dr. Srinath, who has been present with us throughout the day, to please give the concluding remarks.
Yeah, can I talk a couple of minutes? Yeah, Srinath sir he is treasurer of International Federation of Emergency Medicine, and he is academic coordination of ANBEI, and he was instrumental to get us endorsement from Association of National Board Accredited Institutions in a very short time. And I thank him. He is being a constant support for Maharashtra chapter also, and for all emergency medicine doctors also across India. Sir, please.
Good evening all. Wonderful arrangements I could see from the afternoon. Congrats to the Maharashtra team under the leadership of Dr. Sandeep Gore and Dr. Shweta Tyagi, and also to thank our President of Society for Emergency Medicine India, Dr. Venkatesh, who has been a constant support for this program. On behalf of ANBEI, I would like to extend my warm regards on behalf of Dr. Alexander Thomas, who is the President of ANBEI, and our Secretary, Dr. Venkatesh. So it was a great event, which I could see, and with a lot of speakers with more enthusiasm, including Dr. Kushrao, Dr. Suresh David. Everybody were present and sharing their knowledge. At the end, I would just like to tell only one thing, that we emergency physicians are always the frontline workers, and whosoever has attended this program, the only thing is strengthening skills will strengthen the nation. That's what I believe. And each one should teach one to save more lives. That's our main motto for one and all, for the residents who are here. Each one teach one to save more lives. Thank you. Jai Hind.
Thank you so much, Srinath sir. Your presence has always been motivating and inspiring in so many ways. Thanks a lot to be around to inspire all our budding emergency physicians. So this brings us to the end of Emergency Conclave. Big thanks to Dr. Sandeep Gore for organizing this brilliant program and getting us all on this one platform. Give us this opportunity to share our all the experiences, the wealth of experiences which we all had in the last 1.5 years. Earlier we used to vent out all this in 2 to 3 months time, when we always used to have an in-person interaction with almost at least 50 to 60% of our group present in our conferences. But because of COVID, all this has sort of come to an end, and that is why I think this was a much needed break from the monotony which was required. Thank you so much. I'm sure all the attendees enjoyed the program as much. If anybody wants to share something, you're welcome to do that. Any feedback about the program? Anything you want to say about the program?
I think sir left.
Sir's there, I think.
Hello.
Yeah, hi sir.
Hi, I'm listening. I'm right here.
Yes, sir. Yes, sir.
Well, looks like nobody wants to say anything, and I think there has been information overload, most probably.
Yes, yes.
Yeah.
Everyone gone for the dinner, I guess, now.
Yes, that's right. So, but I think it's a very good start, and I wish that people would take this as an example, and many of the other chapters, which are also equal in size, which are scattered across the country, should be able to take this up and develop different themes and have meetings. Just out of curiosity, was this shared through to all the semi-members and?
Yeah, sir. This was we are going on a Zoom platform, and we just shared the YouTube link, so anybody can click that YouTube link and he can listen. So they need not to come live.
The link has been sent to everybody.
Yeah. That link
Very
has been sent to various group, and it was it was shared on Fortis Mumbai web page, web page, as well as on Facebook page also. We circulated that link quite on various groups, so it's very easy to attend the conference through that link rather than joining here. So it was directly going like a TV broadcast across the world. I can say wherever they can click, they can go and see these things. One of my friend from UK, he listened and gave me feedback that it went very well. So
I hope the same advice and guidance can be given for other aspiring chapters across the country. So people should be able to do this. That's very good.
Yeah.
So thank you all. And on behalf of the faculty, I want to thank you, because looks like not many of them are around. But thank you very much for inviting us. And it was indeed a pleasure to be with you all virtually and participate in this academic program.
Sir,
well done.
Yeah, your talk also was quite good, sir. It came at right time. We enjoyed that talk, and not it's enlightening as usual. Means whenever I listen something new, either about emergency medicine or about life. So it's good. And yesterday, when I got this confidence yesterday, when we had some brief chat for some 3 to 4 minutes, that time I got some confidence that we can do these things. Otherwise, I was skeptical. We are doing this on large scale. Some 400 registrations happen already. Whether we can do or not. So there are lots of dilemma and challenges were there. But I think fortunately,
all of you did very well. Well organized. Thank you.
I just Nitin here. Just a quick word. Just to echo the thing, I think it was a really good reflection on the last year and a bit. And Sir David sir's session really put it all together, the resilience. Because actually looking back and during your talk, thinking through the last year, it has tested every bit of it. And the strategies that you shared, I think that will certainly be very useful.
Yeah.
And really glad that, Sandeep organized this, Shweta, and just feels good. It feels like a good year almost capped off and feels positive. Thank you.
And the beauty of this presentation, sir,